artery, you have taken care of post-auricular artery in this case. And sorry, I'm forgetting your third question, please.
Thank you, Dr. Neja. I think we're running behind the schedule. And if there is any more discussion, you can ask him separately. Thank you, Dr. Neja, for the wonderful presentation. Thank you so much. One more thing I would like to share about Dr. Neja. Apart from being an excellent surgeon, he is a very good yoga teacher also. Thank you, sir.
Thank you so much, sir. Now I request our chairpersons to kindly present a memento to our speaker, Dr. N.K. Taneja, sir. Thank you, everyone. Now I request Dr. N.K. Taneja, sir, to kindly present a memento to our chairpersons, please. To our chairpersons, Dr. Raman Sharma, sir, and Dr. Himani. Thank you, everyone. Now, I would like to invite Dr. Shrey Rawat, sir, on stage for his talk on the topic, role of radiotherapy in head and neck cancer. The chairpersons for this session are Dr. Sudeep Munjal, Dr. G.L. Dhal, Dr. Ashina Saxena, Dr. Pawan Jain, and Dr. I.P. Nangia. I request the chairpersons to kindly come on the stage, please.
So there is one announcement. The residents who are presenting their paper and e-posters kindly go to the hall B and submit their papers and e-posters to Dr. Bhushan. Okay.
So please start.
Is it not? Is it visible on the screen? Presentation? Okay, respected chairpersons and distinguished faculty, I bring you greetings from American Oncology Institute, and thanks to the Association of Otorhinolaryngologists of India, Haryana chapter. So AOI means both. But I was wondering why in your presentations it is written only otolaryngologist of India. Why not otorhinolaryngologist? What? Okay. So I will be presenting the role of radiotherapy in the management of oral cancer. And at the outset, let me tell you, it is a multimodality treatment which involves treatment by radiotherapy, surgery, and chemotherapy at some point in time. Surgeons and radiation oncologists, we should not be competing with each other, but rather complementing each other. As they say, 1 + 1 is not equal to 2, it is 1 + 1 is equal to 11. And it should be never 1 + 1 - 1, that is 0. So these are some of the subsides of oral cavity which I will be talking about. Radiotherapy, as we know, it is of two types. One is teletherapy, and one is brachytherapy. Teletherapy means, this is the teletherapy machine. It means radiation, delivery of radiation from a distance, tele. And brachytherapy means installing the brachytherapy sources within the interstitium of the tumor. This is the latest state of art true beam radiotherapy machine, linear accelerator, on which the patient is made to lie down on the couch. He is immobilized with an Orfit cast, thermoplastic Orfit cast, as you can see, patient in treatment position over here. So this is the actual position when the patient lies down on the couch of the medical linear accelerator and is being treated. Indications of radiotherapy in head and neck cancers, they can be definitive treatment, either radiotherapy alone or in combination with concomitant chemotherapy, or it can be as an adjuvant treatment after surgery. There are some indications after surgery like T3 or T4 lesions, presence of perineural or perivascular invasion, multiple positive nodes, extracapsular spread in the lymph node in histopathological examination, closed margins or positive margins. Of course, closed and positive margins, ideally, they should be resected, but again, we have other option also. Before commencing treatment for any malignancy, not only head and neck, but any part of the body, we have to do some diagnostics like biopsy, it is essential. In imaging, as the case may be, either CT scan or PET scan, MRI, hemogram, basic biochemistries, and multidisciplinary consults as required. So coming to the site lip, majority of them occur in lower lip and male predominance is there. These are some examples of squamous cell carcinoma of the lip involving different parts. One of the main treatment goals apart from achieving cure is to maintain a good oral competence. And hence, surgery is the treatment of choice wherever the lesion is small. It can be excised without any functional sequelae, dysplasias or carcinomas in situ, and lesions involving less than 30% of the lip, where a re-excision can be done. And wherever anterior commission is involved, radiotherapy is preferred. These are some examples of patients who have undergone surgery with excellent cosmetic outcomes. Now, where we can come in with radiotherapy. This was a small lesion, T1 lesion at the lower lip and anterior commissure. Patient was implanted with brachytherapy. Okay, this is not showing up the slides over here correctly. Anyway, this is another example of patient who had squamous cell carcinoma of the upper lip in the central region. Patient underwent treatment with brachytherapy. You can see the catheters have been implanted in the interstitium, and this is the complete remission after completion of treatment. Excellent prosthesis and 100% remission. So this is before and after radiotherapy. The patient shared his photograph at his retirement function. He's all right. This was another example of a squamous cell carcinoma of the lower lip involving the angle of mouth, anterior commissure, entire lower lip crossing the midline. He underwent treatment with external beam radiotherapy as well as brachytherapy. This is an example of brachytherapy. After completion of treatment, complete response. So before and after treatment, you can see. So these are all patients treated with radiotherapy, either radiotherapy, external radiotherapy alone, or brachytherapy alone, or combination of both. When we have a hammer in hand, everything appears to be a nail. Now this case again, he was a patient having squamous cell carcinoma of the lower lip, but this malignancy was extending to the skin of the chin also, and superficial erosion of periosteum was also there. This is not an ideal case for brachytherapy. So this patient was treated with electron beam therapy. So it is very essential to make a good selection of case. There are some do's and don'ts. A pre-treatment dental evaluation is essential. Otherwise, if we treat a patient with dental caries, loose teeth with radiotherapy, then later on patient may develop osteoradionecrosis. Dental prophylaxis before and after treatment is must. Whenever we do brachytherapy procedures, we use shields, spacers. Say for example, the cases that I showed, between the tongue and pellet, if we put this spacer, the dose of radiation to the pellet will be decreased. Similarly, these are some dental shields which we place between the implant and mandible or alveolus so as to prevent high dose falling on the mandible and thereby preventing ORN. Otherwise, these are the kind of ORNs later on which we face after a few years. There is some issue regarding timing of brachytherapy versus external radiotherapy. Whenever we are combining external radiation and brachytherapy, what to do first? There is a school of thought which says external radiation should be done first and later on brachytherapy. I personally believe that if we do brachytherapy first, at that time the lesion is very nicely visible. We can implant our catheters at the site of disease. So I prefer doing brachytherapy first, followed by external beam radiotherapy. The target volume should be based on your clinical examination and imaging. And the duration of treatment, overall treatment, combination of external radiation as well as brachytherapy should be as short as possible, preferably within 8 weeks. An article was published in British Medical Journal saying good surgeon is, good surgeon knows how to operate, better ones know when to operate, and the best ones know when not to operate. And same is true for all specialties, even for us as radiation oncologists, which case to be selected, which case should be referred to the surgeon, which case should be treated with chemoradiation. So we should realize in time that perhaps I am the wrong tool for this and refer for the right treatment. Regarding case selection, especially for brachytherapy, the margins should be definable. There should not be a T4 disease with involvement of bone. Ideal lesion should be less than or equal to 5 centimeters. Patient should be fit for the procedure. Oral access should be good. No distant metastasis should be there, and favorable histopathologies should be there. Alveolus and retromolar trigon are basically surgeon's domain. These are the details of surgery which I would avoid. But yes, post-operative radiation when it is required. As I told you earlier, T3 or T4 lesions, close or positive margins, presence of perineural invasion or lymphovascular invasion. So we have to study the histopathology report in detail, looking at all these things, extracapsular spread, etc. RMT is also same state. So these were two cases which I saw in last 2-3 months of retromolar trigon, anterior tonsillar pillar, adjoining palate, and both of them I referred to the surgeon for surgery followed by radiation therapy. Now coming to oral tongue, this is a lesion of right lateral border of the tongue, superficial ulcerative squamous cell carcinoma of the tongue, and endophytic lesion. So it is very important to identify the nature of the disease, as endophytic tumors are very difficult to treat. Nowadays, depth of invasion has become very important in assigning the T status of the disease. T status means size of the tumor. So there is a question, can anterior oral tongue involve lymph nodes without involving level 1 node? So yes, almost 13% incidence is there, and it has got grave implication on the technique of surgery and radiation, whether to do the neck dissection involving the lower nodes also. This is an example of oral tongue. Ideally, this patient should have undergone surgery, but patient was in a profession which required a lot of speaking, and he didn't want any slurring of speech or any kind of functional sequelae. So he requested me to do treatment with brachytherapy and external beam radiotherapy. So this is the lesion, as you can see. The patient is taken in the operation theater. A very good extended neck position is very essential for performing this procedure. A tongue tie is applied at the tip of the tongue so as to prevent it from falling backwards. And then we start applying catheters. As you can see in this, first catheter has been implanted, second is being implanted, and so on and so forth. Multiple catheters have been implanted in the tumor. This is how it looks, and this is how it looks from outside. Once that implant has been done, patient is taken up for planning CT scan, wherein we can identify the tumor and the catheters that have been placed. We can do the contouring over there. This is the brachytherapy suite. Patient is taken up for treatment with brachytherapy, in which we use iridium 192 radioactive isotope. It is a remote controlled after loading machine. There is no risk to the radiation personnel. So weekly review is done. You can see where the implant is there. The dosimetry is also there, and the reactions over the tongue have also come over that area only. So this is the spacer that has been used to distance it from the palate, and dental shield before every treatment. And finally, the patient undergoes implant removal after 4 or 5 days, and patient is back home. These are the reactions which patient developed at the site of implant. So we feel happy by seeing these reactions, because these are the areas where disease was there, and this will lead to cure. On follow-up, patient's reaction had subsided. Now, as tongue is a notorious disease and has got high incidence of spreading into the cervical neck nodes. So after completion of brachytherapy, patient also underwent external beam radiotherapy. These are the kind of contourings which we do using intensity modulated radiotherapy, that is IMRT technique, in which we are able to spare the normal tissues like the parotids, spinal cord, oral cavity, and other parts. So this is these are figures of external beam radiotherapy contouring. Now coming to hard palate, this was the lesion over the hard palate. In this, we treat with mold brachytherapy, and we need a very good dental department over there. So these are the molds which we made with the help of dental department, as you can see over here. And this is the final treatment position. After completion of treatment, these are the reactions that were seen. Another patient who had this lesion over the junction of hard and soft palate, again with the help of dental department, we created and manufactured a mold, as you can see in these pictures. A negative and positive impression has been taken. And the catheters are implanted into the mold, and a dummy dosimetry is done, and finally the patient is taken up for treatment. So a very good dental department is also required, and very good coordination between the radiation and dental department. Now coming to buccal mucosa, early and late lesions. This was a lady with small lesion of the buccal mucosa involving the anterior commissure and right lateral buccal mucosa. Patient underwent treatment again with combination of external radiotherapy and brachytherapy. These are the brachytherapy catheters, as you can see. Usually all the brachytherapy procedures are performed under general anesthesia in the operation theater. This particular patient I had done under local anesthesia, because this procedure I had performed at Patna, where the operation at that time only radiation department was there, no medical oncology and no surgical oncology was there. So in the procedure room only we did this procedure under local anesthesia. So you can see excellent cosmesis before and after treatment, complete remission and excellent cosmesis, no functional sequelae. This is a case of stage 4A buccal mucosa. You can see the disease involving the buccal mucosa, upper and lower gingivobuccal sulci, RMT, and with a fungating mass to the skin. After completion of treatment, complete remission. This patient underwent treatment with concomitant chemoradiation. Concomitant chemoradiation means 70 gray in 35 fractions of external beam radiotherapy and weekly cisplatin chemotherapy. So chemotherapy acts as a radiosensitizer. It increases or enhances the effect of radiation. So you can see before and after treatment, complete remission is there. Another case of CA buccal mucosa, stage 4A, with infiltration of the skin and involvement of intratemporal fossa also. Before and after concomitant chemoradiation, complete response. Yet another example, before and after completion of radiation, complete response. Another lady, she was having severe trismus also after completion of treatment. This patient had verrucous carcinoma involving the lower lip, going to the opposite side, opposite anterior commissure, lower gingivobuccal sulcus, ipsilateral, entire buccal mucosa, upper and lower gingivobuccal sulci up to the RMT. He underwent treatment with concomitant chemoradiation. Complete response. I had contacted him in August and he sent me his picture. Complete response. So there is a myth amongst some of the medical professionals that verrucous carcinomas are resistant, but this was not so. Now just a word about conventional radiotherapy and intensity modulated radiotherapy. Like you can see in this, if we treat with conventional radiation, you can see the tumor in the blue, a small tumor in the blue color. In order to treat that, we have to take the entire field, which will be treating the parotid glands, the spinal cord, much of the oral cavity. But with, and this will be the isodose distribution. But with IMRT, as you can see over here, the parotids, the spinal cord, the anterior part of the oral cavity, all have been spared. This is the parotid which is spared. Nowadays, we have got a good diagnostic facility like PET-CT scan. So we use also PET-CT scan in order to better delineate the tumors. This is an example of Freeberg's applicator. Sometimes this was a case of recurrence of CA buccal mucosa in the infratemporal fossa after complete treatment. So the patient was taken in the OT. The surgeon did the infratemporal fossa clearance and we performed the intraoperative brachytherapy. This is called a Freeberg's applicator. Patient is taken up in the OT where the surgeon takes out the disease. We put the Freeberg's applicator. The patient is shifted to the brachytherapy suite, which is there in the OT only, given a single fraction, high dose, and then the wound is closed. Nowadays, there is a new entity which has come up, which is HPV positive oropharyngeal diseases. Especially oropharyngeal and especially tonsils, the majority of them are due to HPV positivity. So these cases have got very good prognosis, and in coming times, trials are going on to de-escalate the treatment. Lesser dose of radiation may be required. Michael Douglas is a US actor. He had stage 4 disease of the base of the tongue and tonsil. He underwent treatment with chemoradiation, and after that he is completely all right. This is the latest image and his status, which I picked up from the Wikipedia. He's doing well after so many years. And there is a myth regarding tolerance of elderly patients. So these are some pictures which I will show. This was an 85-year-old male who had squamous cell carcinoma of the skin of the scalp. He was brought to the hospital only because he started emanating maggots, foul-smelling discharge, and bleeding from this wound. So the family brought to the hospital. Patient underwent treatment with electron beam therapy. Complete response after treatment. Squamous cell carcinoma of the conjunctiva, treated him with electron beam therapy. As you can see, complete response. Hypopharynx, stage 4 disease, before and after treatment, complete response. Very elderly, 85 to 90 years of male. He came from East India. He had disease of the piriform fossa with fungating neck nodal mass, underwent treatment with concomitant chemoradiation. You can see after completion of treatment, 3 months after that, complete response. So I told you, there is a role of brachytherapy as an adjuvant treatment for positive surgical margins also. These are some studies, and they have shown that if we treat these patients with brachytherapy, it avoids the morbidity also and has got comparable outcomes. So that is one of the options if the patient is not willing for resection. They have talked about the positive surgical margins which are less than 2 millimeters and closed margins between 5 and 10 millimeters. Every procedure and every talk is never complete without mention of complications. So in brachytherapy and radiotherapy, there are some acute complications like hemorrhage, infection, airway compromise, CL adenitis, and long-term side effects could be soft tissue necrosis, telangiectasia, and rarely ORM. So we have a long way to go. We still come across such cases in OPD. This patient came in emergency with advanced lesion of the buccal mucosa with orocutaneous fistula, with bleeding, and only packing could be done, nothing much could be done. A person from a very educated family, he went to alternative treatments, and then the disease kept on progressing, and then he landed up with us. So case, if properly selected, results are excellent, morbidities are minimal, and we should always remember the criteria for good case selection. Thank you so much.
Thank you, Dr. Rawat, for an excellent talk. The newer techniques of radiotherapy are really excellent. In our early days of college and practice, we used to see the head neck cases, oral cancers after radiation with dry mouth, mucositis, difficulty in swallowing, but now the things are not there. So in future, I think your role is going to increase and the surgeon's role is going to decrease. And with early detection and early diagnosis, probably you are going to be the leader in the treatment of cancers. But the sad part is the number of cancers increasing tremendously. I remember some data in 2012, the number of surviving cases was 18 lakhs, and in 2020 it is 74 lakhs. So that is the workload you are going to handle. And the surgeons are available, medical oncologists are available, but the radiotherapy teams are very less, and the cost of your machines is too much, and to install so many centers who can cater the need of India is probably very, very difficult. So God bless you. Keep working hard. Our wishes and blessings with you.
Thank you. Yes, sir. Paranasal sinus. So, since you have asked this question, last year only when this mucormycosis pandemic was happening, I saw one case who was a small cell carcinoma of the paranasal sinuses involving the nose, the ethmoid, the maxillary, and sphenoid sinus and orbital part. It was a small cell carcinoma. So during that time, he was also diagnosed as having mucormycosis. He came to me कि डॉक्टर साहब बहुत ज़्यादा बीमारी के साथ आए, बोले कि मैं अभी ब्लैक फंगस का ट्रीटमेंट चल रहा था पिछले कुछ महीनों से, लेकिन अल्टीमेटली ये दोबारा जब उससे फायदा नहीं हुआ तो दोबारा बायोप्सी हुई, इसमें स्मॉल सेल आया. तो जस्ट क्योंकि आपने पैरानेजल साइनसेस के बारे में पूछा, so we keep seeing paranasal sinus tumors also, and we always consult with the surgical oncologist whether any surgical intervention is possible or not, and after jointly taking a decision, it is possible to treat paranasal sinuses also with combination of radiotherapy and chemotherapy. We do treat in our practice. So ideally they say that if you cannot achieve R0 resection, then the surgery is not good enough. Then you should not do that.
I have a series of 65 cases of malignancy of paranasal sinuses operated by total endoscopic technique. I have to publish my residence student. I've seen one mortality, I've seen 5 differences. Although I've subjected them to radiotherapy, but that O block or N block resection concept is no longer there. So you can do a piecemeal resection of malignancies, and that's why they are doing all those level resection of. So in 65 cases, I've seen one mortality, 5 recurrences, they've operated again and subjected them to radiotherapy, chemotherapy, whatever is feasible. Although 2 are on palliative treatment. But still, if you talk about 65 cases, one mortality, two compare here. And still, you do have 62 people who are happily surviving after even endoscopic, total endoscopic resection of the nose and pharyngeal sinus tumors. I'm telling you, this is something which is accepted, and you do have a dearth of publications now in the literature who advocate endoscopic excision of these tumors until unless it is going grossly in the brain. If dura is involved, I have resected the dura. If it is involving the skin, if it is involving the anterior anterolateral bony framework of the sinuses, then I don't do that. And going beyond the paramedian of the orbit. Otherwise, they are very much resectable endoscope.
It is not only acceptable, it is very commendable. And as I said, 1 + 1 = 11. We should always
I just want to
complement
make
each
a
other.
comment, doctor. As far as surgery is concerned, in tumor surgery, you are right that you have to do an R0 surgery. And if you're not doing an R0 surgery, you're doing a residual surgery. You have to be very clear about it that you are doing a residual surgery, which has to be followed by another modality of treatment. It is not complete treatment of the patient. And I think sir is right in surgical technique and according to these principles of oncology. If you are operating a case, then it has to be R0. That is the standard practice.
Yes.
There is no doubt in that what Dr. Gautam is saying, but what I was saying, if you can save the morbidity, decrease the morbidity of the patients, decrease the organ, you can preserve the organ. Why not have a microscopic residual rather than giving a complication and giving a deformity? And that can be taken by radiotherapy or chemotherapy.
So unfortunately, that is not so, because the
The
microscopic
effect
disease
of
that has been,
deformity on the psychology of patient, one must think of that.
okay, thank you.
Thank you so much, sir. I request our chairpersons to kindly felicitate our speaker, Dr. Shehrawat, sir. Now, I request our speaker, Dr. Shehrawat, sir, to kindly felicitate our chairpersons. Thank you, everyone. Our next talk is by Dr. Raman Vadera, sir, on the topic outcome following Montgomery T-tube stenting in patients with active blunt laryngotracheal trauma. The chairpersons for this session are Dr. Nitin Gupta, Dr. Deepak Katyal, Dr. Vikrant Dagar, Dr. Ashutosh Nangya, and Dr. Kanwar Singh. I request all of the chairpersons to kindly come on the stage.
ये संपदा बस नीचे करना इस स्लाइड में तो बड़ा बड़ा हाँ करवाना तो स्लाइड मोड पर डाल दीजिए ठीक है, ठीक है। Namaste to everyone. My topic is outcome following Montgomery T-tube stenting in patients with acute blunt laryngotracheal trauma. So now coming to laryngotracheal injuries. So broadly, laryngotracheal injuries can be divided in two subcategories. First is the external traumatic injuries, and second one are the iatrogenic injuries. So external traumatic injuries, they can further classified into two subcategories. Those are blunt injuries and penetrating injuries. So blunt injuries, they are usually caused by motor vehicle accidents, hanging, strangulation, and contact sports. For example, when a rider of a motorcycle hit a stationary object, a large amount of energy is imparted over a small area, leading to cricotracheal separation or a crushed larynx. Penetrating injuries, they are usually occur after gunshot wounds and stab wounds. Now, 80% of external traumatic injuries occur in males. Now coming to iatrogenic injuries. So iatrogenic injuries occur following oronasotracheal intubation, cricothyroidotomy, or during elective operations like laryngeal surgery, laryngoscopy, or routine tracheostomy. And post-intubation injuries, they are the damage due to the high cuff pressure, prolonged duration of intubation, and sometimes due to the use of large diameter endotracheal tubes. Now, prolonged intubation can lead to granulation and scarring with subglottic stenosis, and sometimes it can lead to vocal cord dysfunctions also. Now, these laryngotracheal injuries, they have been classified into 5 groups. So group 1 are the very minor injuries without any fracture, whereas group 2 injuries, they involve fracture of the cartilage, but this fracture is undisplaced without any exposed mucosa, and that fracture is detectable only on the CT scan. Group 3 injuries include massive edema, mucosal tears, and exposed cartilage. Group 4 injuries, they are more severe as to the group 3. So in addition to group 3 injuries, there are more than 2 fracture lines or massive trauma to laryngeal mucosa. And group 5 is complete laryngotracheal separation. Now remember, patients initially exhibiting only subtle symptoms can progress to complete airway obstruction from worsening edema. And remember, the hallmark signs are stridor, increased respiratory rate, tachycardia, sweating, and use of accessory muscle. Now coming to management part. So in the beginning, you will have to do the fiber optic nasoendoscopy. And what is the purpose of doing fiber optic nasoendoscopy? That is for assessing patency of the airway, to see the vocal cord movements, presence of lacerations, hematoma, and exposed cartilage. Options for acute management of threatened airway are routine endotracheal intubation, fiber optic awake intubation, tracheostomy, and in emergent situation, you will have to do cricothyroidotomy. Now remember, and it is very important, blind endotracheal intubation must be avoided, as it can lead to complete laryngotracheal separation in a partially transected airway held together by peritracheal soft tissue. An emergency tracheostomy under local anesthesia is recommended to secure the airway safely. Following stabilization of airway, you can go for CT scan with 3-dimensional reconstruction, and if further needed, you can go for MRI also. While some authors recommend delaying exploration of the injury until edema at the site of injury has subsided, but general consensus is that these patients should be explored within 24 hours after injury. Why? to avoid voice and airway dysfunction in the long term. And there is a consensus that group 1 and group 2 injuries, they can be managed by conservative approach. But in group 3, group 4 and group 5 injuries, you will have to do the open approach. Now, there are many options in open surgery. So few are, that is simple circumferential resection with primary end-to-end anastomosis. That provides excellent outcome in suitably selected patients, especially where injury involves only to the trachea. Other reconstruction options where there is loss of cartilage include use of local muscle flaps, using either the stem muscles or parts of the sternocleidomastoid for filling the defect. Use of free grafts for more extensive cartilage loss can be done, and most common graft taken is the graft from the rib. However, some people use graft from the septal cartilage to fill that gap. Now remember, stenosis that is at a distance greater than 1.5 centimeter from the inferior aspect of the vocal folds is considered safe for a section with primary anastomosis. Difficulty arises when you deal with the subglottic stenosis. So treatment of stenosis located in the subglottic region is a major therapeutic challenge due to the need for approaching a disease involving the larynx very near to the vocal cords. Up to half of the trachea can be resected and managed with primary anastomosis, but some people are of the opinion that resection of no more than 4 centimeters stenosed trachea so as to avoid anastomotic tension and failure. Now coming to our study, so I did retrospective analysis of 19 patients in our setup who had undergone Montgomery T-tube insertion after acute blunt laryngotracheal trauma. Most of the laryngotracheal injuries fell in 4 broad categories that I will discuss later on. Now, this is the photograph of the Montgomery T-tube. So it contains a vertical limb and another one is the horizontal limb. So vertical limb has 2 parts. Upper one is the proximal limb and lower one is the distal limb. And in another photograph, you can see Montgomery tube is lying in the airway. Now, what were the operative steps in our study, in our patients? So initially, tracheostomy tube was replaced with flexometallic tube for induction of general anesthesia. Then we did standard direct laryngoscopy to examine the glottis, subglottis, and trachea so as to assess the injury. It sometimes included the passing of a flexible bronchoscope through the direct laryngoscope and inspecting the injured segment closely and clearly. The injured segment was identified and then cross-referenced with the findings of CT scan. Then a horizontal skin crease incision was given at the level of upper border of cricoid cartilage, and subpalatismal flaps were raised to expose thyroid notch and upper trachea. So this photograph is showing that a incision line has been marked, and this incision line is at the upper border of the cricoid cartilage. And in the photograph, you are also seeing flexometallic tube. Now anesthesia is being given through this flexometallic tube. Now in this picture, subpalatismal flaps has been elevated and you can see the stem muscles. Now stem muscles were retracted laterally and blunt dissection was done to expose the injured area. Where required, a midline cricoidotomy was done and extended into upper 2 tracheal rings The cricothyroid membrane was opened horizontally to facilitate lateral retraction of cricoid chondrotomy segments. Broken necrotic pieces of cricoid cartilage and tracheal rings were removed. Particular care was taken while doing resection of cricoid cartilage. Why? A posterior shell of cricoid cartilage was preserved because the laryngeal nerves have access into the airway wall at the level of posterior plate. So to avoid injury to the recurrent laryngeal nerves, a posterior shell of cricoid cartilage was preserved. A pediculate flap from sternohyoid muscle was created wherever required. The trachea was freed from strangling structures. Now, this is the picture showing in this patient, there was injury of the subglottis and first ring of the trachea. So here I have removed the necrotic pieces of subglottic and trachea. And now you can see the tip of the bronchoscope. So superior one is the lower border of the thyroid cartilage. So now there is no injured area, no broken pieces of the cricoid and tracheal ring. And this is the bigger view. So this bronchoscope was passed through the laryngoscope. So in the inferior part of this photograph, you can see the tip of the laryngoscope, the tip of the bronchoscope. So this is the magnified view. So injured area has been removed. Broken pieces of cartilage of a cricoid and first ring of trachea has been removed. Now, after that, this picture is showing that a flap, pediculate flap is being raised from the left-sided sternohyoid muscle. After that, anesthesia circuit was disconnected, flexometallic tube was removed. The Montgomery tube with outer diameter ranging from 11 mm to 13 mm was used. Size of the Montgomery tube was selected according to the length and location of the injured site. First, the lower limb of the Montgomery tube was introduced in trachea, and then using artery forceps, the upper limb of Montgomery tube was introduced. Then anesthesia circuit was connected to Montgomery tube. So initially anesthesia was given by the flexible flexometallic tube. Now anesthesia was being given by the Montgomery tube. But upper end of the Montgomery tube is open. So there was a leak of the gases from the oral cavity and nose. So LMA was used by the anesthesia team to seal the escape of gases through the open upper end of the Montgomery tube. So this photograph is showing lower end of the Montgomery tube has been placed in the trachea, and upper and proximal limb of the vertical part has been caught with the artery forceps, and it is being introduced into the airway. So now whole of the vertical limb of the Montgomery tube is in the airway, but proximal limb of the Montgomery tube is lying exposed because there were present necrotic pieces of the cartilage which has been removed. Then using a rigid or a flexible scope, it was ensured that upper limb of Montgomery tube did not cross the level of vocal cords or touch the undersurface of vocal cords. Depending on the injury, the trachea was stitched to the cricoid cartilage. So in some cases, trachea was stitched to the cricoid cartilage, and where cricoid cartilage was deficient for suturing, then the trachea was directly stitched to the thyroid cartilage. The anterior tracheal wall was closed over the Montgomery tube using sutures, or in some cases where it was needed, it was covered with a pediculate flap from sternohyoid muscle. Then the strap muscle was sutured over the repaired segment and the wound was sutured in layers. Stay sutures were placed from submental region to the chest. Post-operatively, all the patients were prescribed daily saline nebulizers. That is very important. This is to prevent the crusting of the Montgomery tube. Skin sutures were removed on the 10th post-op day. So this picture is showing endoscopic view. So here you can see Montgomery tube is in situ, and you are able to see the upper limb, superior most part of the proximal limb of the vertical part of Montgomery tube, and this is present below the level of vocal cord. It is not crossing the vocal cords, because if it crosses the vocal cord, then patient will aspirate and cough will be there. So this end should remain below the level of vocal cord, and it should not touch the vocal cord also, because if it touches the vocal cord, then it can lead to the granulation formation. Now this photograph, after ensuring that upper limb of the Montgomery T tube is placed well, not crossing the vocal cord, not touching the vocal cord. Now this proximal exposed part of the Montgomery tube is being covered by the already raised pedicled flap of the sternohyoid muscle. So now exposed part of the Montgomery tube's proximal part has been covered with the pedicled flap of the sternohyoid muscle. Strap muscle has been sutured. Now suturing is being done in layers. So skin suturing has been done. So now this horizontal limb of the Montgomery tube is out, and anesthesia is being given through this horizontal limb. Now this is the photograph of the patient few days after the surgery, and you can see that this horizontal limb of the Montgomery tube has been plugged. So patient can speak. And if anyhow suction is required, then patient can remove this plug and suction can be done. And this is the X-ray. And in this X-ray, because Montgomery tube contains radiopaque element, so you can see Montgomery tube lying in the airway. So you can see the proximal limb of the vertical part, distal limb of the vertical part, and horizontal limb. Now results. There were 19 patients with age ranging from 18 to 16 years. There were 15 males and 4 females. Injury occurred due to blunt trauma caused by either roadside accidents, accidental strangulation, assault, or fall from height. But in our series, roadside trauma was the most common mode, followed by accidental strangulation. And how accidental strangulation happened? Accidental strangulation occurred due to a loose cloth worn around the neck that had got caught in a machine or in the rear tire of a two-wheeler, causing strangulation. So 8 patients had isolated subglottic injury. 3 patients had isolated tracheal injury. 3 patients had injury to cricoid as well as trachea, but not other laryngeal structures. Whereas 5 patients has combination of category A, B, C with damage to other laryngeal structures. Amongst these, 5 patients had a cricotracheal separation. So emergency tracheostomy was performed in all the 19 patients. In category C injury patients, 2 patients had crush injury of anterior wall of cricoid and trachea with intact posterior wall, whereas 1 patient had cricoid fracture with injury to the first tracheal wing. In category D injury patients, all 5 patients had undisplaced fractures of the thyroid cartilage, cricoid fracture, tracheal injury with a tear in the cricothyroid membrane. Tracheostomy tube was kept for less than or equal to 10 days in 15 patients and more than 10 days in 4 patients before Montgomery tube insertion. because some patients are referred to our institute from the other institutes. So already those patients were on tracheostomy tube. So Montgomery tube was inserted after a few days. But after insertion of Montgomery tube, it was kept 1 year in all the patients. So in 6 patients, duration of tracheostomy tube was 0 to 5 days. In 9 patients, it was 6 to 10 days. In 3 patients, it was 11 to 15 days. And in 1 patient, it was more than 16 days. Now, 16 out of 19 patients could be decannulated successfully. Out of 16 patients, 12 had a good airway and could engage in moderate to intense physical activities comfortably. 4 patients had a fair airway who could only do light physical activities comfortably. 10 patients had near normal voice in the immediate post-decannulation period. 5 patients had fair voice with very mild hoarseness, which improved subsequently. 4 patients had severe hoarseness. All these 4 patients had an element of vocal cord immobility, with contralateral vocal cord not being able to compensate. They were referred for speech therapy. Coming to final part discussion. So laryngotracheal injury is reported as second most common cause of death among patients with head and neck trauma after intracranial injury. A laryngotracheal injury can result in acute airway obstruction after an accident due to the edema, if not attended with a high degree of suspicion, especially in cases of multiple trauma patients. The larynx is shielded inferiorly by the sternum, superiorly by the mandible, posteriorly by the cervical spine, and laterally by the sternocleidomastoid muscle. The laryngotracheal complex is also supported by muscular and tendinous attachments, which can deflect trauma in all directions except posteriorly. This is the reason why laryngeal injuries are infrequent, and also the reason why a laryngeal injury is very commonly ignored or overlooked in a polytrauma patient. Now coming to stents. So stents are useful during most airway augmentation procedures to support a free graft in the form of rib or a septal cartilage or a vascularized pedicled flap from a muscle to preserve lumen, where injury involves the glottis, subglottis or trachea. For this, a tracheal stent is needed, which could be left in airway for a long time with minimal complications. But rigid stents are not recommended, like endotracheal tube, since they produce trauma that is similar to endotracheal tube. Piece of an endotracheal tube, celastic sheet rolls, and laryngeal stents require an alternative airway in the form of a tracheostomy. An ideal stent should be rigid enough to resist external pressure, but on the other hand, it should be soft and flexible too, so that it is minimally irritating to the laryngotracheal mucosa. All these advantages are there with Montgomery T-tube. The Montgomery T-tube is an uncuffed silicone T-tube. It is used as combined tracheal stent and tracheostomy tube, so there is no need to insert a separate tracheostomy tube. It has 3 legs, as I have already discussed, of different diameters and lengths. The external opening can be plugged for voice production, but plug can be removed if suction and cleaning is required. It helps in maintaining the patency of trachea subglottis, where the lumen has tendency to progressively narrow because of post-traumatic wound contraction. Other advantage is that it remains fixed in its place and is not disclosed by the cuffing because its shape is T-shaped. So it is not easily disclosed by the cuffing. And another advantage is it can be easily removed just by pulling the horizontal limb of the tube outward. So this tube is generally well tolerated and it can be left in situ for years. But however, there are few complications also. Granulation can form on the undersurface of the cord where the upper end of the Montgomery tree tube may sometimes touch. So you will have to take care that upper end should not touch the vocal cord. Cough with aspiration can occur if proximal end of the tube protrudes through the vocal cords. So again, you should do the check endoscopy to see the position of the upper end. Sometimes Montgomery tube may get occluded by dried mucus and sputum. However, daily saline nebulizers can prevent it. But still, carbocysteine can be added in those patients where there is evidence of mucus plugging. Rarely it has to be changed if there is no relief with nebulizers. So in the end, it can be concluded that due to the above discussed advantages, as well as the near normal phonation, Montgomery tube should be preferred when stenting is required after repair of laryngotracheal trauma. And second important point is, it should be left for at least 1 complete year in the airway, as it results in negligible chances of post-traumatic stenosis of airway later on. It has been seen where people have removed the Montgomery tube after 3 months or 6 months, stenosis has reappeared. So ideally, it should be kept at least for 1 complete year. Bundle of thanks.
I have one comment or something.
Hanji.
Sir, what we do is when we patient initially comes, and if the degree of injury is smaller, then we subject the patient to coagulation first and give coating of this what do you call it? This anti-cancer drug. I am forgetting the name.
Yes, sir.
Mitomycin.
Yes.
And some of the patients do not require M2. That is one comment which I want to make.
Yes, yes.
And secondly, what is your take when the injury is just below the vocal cord, at the level of the vocal cord, then the M tube, the segment, how it is bypassed, and the M tube upper end is just the stenotic segment starts just at the level of the vocal cord.
Because your first query is that Montgomery tube is required only where there is excessive fractures of the cartilages, gross fracture pieces of the cartilages. They can't be managed with other things.
Right.
You will have to open it, and you will have to remove those pieces of the cartilages because they are blocking the lumen. And second question was, what was your second question?
If the vocal cord, the stenotic segment is below just
if injury is at the level of vocal cords, then you will have to do the laryngo fissure. You will have to open the supraglottis, and then you will have to stitch the vocal cord. And in some patients, you have to insert a key in the where the anterior end of the vocal cord, because Montgomery tube will serve the function if the level of injury is below the level of the vocal cord.
The point is, if it is at the level of the glottis, then the laryngeal keel is good alternative.
Yes.
But if the point is, if it is just about 2 millimeters below the vocal cord, then there is a slight dilemma either to whether to use the keel or the Montgomery tube will upper end will go there and bypass that segment.
So that is very tricky. That's why I told if injury is below the level of 1.5 centimeter to the vocal cord, then outcome is very good. But if injury is in the subglottis, then you are operating very near to vocal cord. Then you will have to place tube just below the vocal cord. But again, you will have to cut it very nicely, and you will have to check it by doing the fiber optic endoscopy. It should not touch the undersurface.
But still, sir.
So those are the tricky
You
cases.
can use it in subglottis, but it should not touch the vocal cord. You can use Montgomery's tube in subglottis also, subglottic lesions also. I just wanted to ask you a question, sir. What is your take about tracheal stenosis? You in cotton wear grading from 1 to 4, grading 1, grading 2, 3, and 4 are there.
Yeah.
So what is your take? Which grade you repair with coblation, or which grade you prefer to do a tracheal anastomosis?
Eh,
The end-to-end anastomosis and resection.
Yes, yes. Because a coagulation or laser, they are advised if there are thin webs are present there. But if there is injury to the tracheal rings and rings are lying in the tracheal lumen and they are blocking it, so then you will have to do the Montgomery tube insertion. But if grade 1, where injury is up to 50%, you can try it endoscopically and you can place a stent by doing endoscopy there. But if level of injury is, if level of stenosis is more than grade 1, grade 2, that is from the 51 to 70%, then you will have to do the open approach.
Okay. In our experience at SMS, around 25-30 cases we have done so far. We are trying to do up to grade 3 with the coblation itself.
Coblation itself.
And believe me, patients are following up. We have to follow them every month. I'm calling them every month. I take them under GA. I inspect it. And if some constriction is again there, I do coblate it again. And believe me, patients are surviving. Grade 4, no doubt you have to go for
No doubt.
dissection and anastomosis.
But that is you are doing for trachea, yeah, for subglottis.
For trachea only. Not
For trachea,
subglottis.
this can be done.
Yes.
But for subglottis,
You have to resect.
you,
Cotton May grade 1, 2 for subglottis, you can do the coblation job with the Montgomery T tube, but 3, 4, you have to do a dissection anastomosis.
especially for
But in
subglottis.
trachea
you
up
will
to
have
grade
do.
3, we are doing coblation now.
Yeah, yeah. You are not using laser.
We are not using, I do have laser,
Okay.
but I'm more comfortable with coblation.
So do you put some stent after coblation there?
Coblation, no. Right now, we are not putting a stent. The problem is the syringe we use now. You have to wait for many weeks for the stent to come. So we have to operate these cases.
Okay.
We are using laser. We are using laser for T1, T2.
Yes.
Very, and we are getting very good results.
Yes. Yes.
We reserve our tracheal resections for. We do that.
Yes.
One thing more regarding the upper end of the Montgomery tube. Introp, you may assess it with the fiber optic, but you have to flex the neck and extend the neck. See, the change in position can alter the position of the Montgomery tube of the tube, and that might rub the under surface.
We usually flex the neck after that, so that just to ensure it should not come out to the. That is very good observation.
Sir, I just have a small comment to make, especially for the residents. When these patients come to the emergency, if you are planning an endotracheal intubation, please be very wary of asking an anesthetist to use a muscle relaxant. Because as soon as the muscle relaxant is given, the intubation has to be done immediately. If it takes time, the patient will lose his effort and will land up in cerebral hypoxia. So that's a very, very dangerous situation. You might land up with a young patient being brain dead.
So, and moreover, anesthetist should be very experienced.
Yes, sir.
If you want to do the intubation in the acute setup, then anesthetist should be very experienced.
Senior experienced person.
You should have a very low threshold for recall speed.
Yes, sir.
In these cases. Don't hesitate to do a recall speed.
Yeah.
The other important point which Asutosh has made is ask your anesthetist not to give extra positive pressure, because the wound is open and you may get a surgical emphysema and push the air with positive pressure. So that is also another point which is very important.
Definitely. The question. There was one more question. Pardon, a bit more loud, please speak.
He's talking about your experience of resecting the trachea by using some cartilage.
Filling the defect with cartilage. No, that experience is not good. End-to-end anastomosis is the best answer. Resection of the snore segment and end-to-end anastomosis is always preferred.
Do the end-to-end anastomosis. One thing that you may do some cartilage grafting. So of this damaged part of the this trachea, because only you are making a reconstruction by the muscles flap. There may be chance of later on to stenosis or sucking because of negative pressure during inspiration. So the patient will develop the stridor later on after the.
Some people are doing this approach
Montgomery
also.
too.
But the thing is, if it is a circumferential resection,
Yeah.
how will you reconstruct that? With which material? But if it is only anterior wall defect, you
Yeah.
can use a rib part, muscle cartilage,
Yeah.
or even hyoid to reconstruct. That was, a study was done by Dr. Kanti Bauman and Dr. Chakaki at ICT. They used the hyoid, dropping the hyoid to the attached muscles.
Yeah.
And even using the muscle cartilage, they built the anterior defect. But if it is a circumferential defect, it has only been tried by one Spanish surgeon who grown a trachea in the forearm.
Okay.
Using a brachial pump, he grown it and he made a 6 centimeter long trachea in the forearm. Then he replaced that back with the microscopic techniques. But that is not a problem.
Yeah, yeah.
So if it is a circumferential thing, how will you reconstruct with any cartilage?
Definitely.
You will have to excise it and end-to-end analysis have to be done. in that.
How much length you can
Sir,
make?
we are very much behind the schedule. No more questions, sir. You can ask during lunch session, sir. Sir, we are very much behind the schedule. Sorry for interruption. Okay, thank you.
Thank you so much, sir, for the informative session. I request our chairpersons to kindly present a memento to our speaker, Dr. Raman Vadera, sir. Thank you. Now I request Dr. Raman Vadera, sir, to kindly present mementos to our chairpersons. Thank you, everyone. Now, I would like to invite our next speaker for today, Dr. Gautam Veer Singh, who will be talking about circumferential subannular tympanoplasty, panacea for revision tympanoplasty. The chairpersons for this session are Dr. Sanjeet Roy, Dr. Anshu Gupta, Dr. Surendra Bishnoi, Dr. Reet Chandar Jain, Dr. Vivek Taneja, and Dr. Jagat Singh. I request all the chairpersons to kindly come on the stage. There's a small announcement, as there was a tea break written in our schedule that won't be happening as we are running behind the schedule. So the tea is being served outside. Anyone who wants to have it can go have it, and we'll be continuing with our session. Thank you.
सर बोलिए नहीं सर यहीं से बोलिए सर माइक तो यहीं पर
This announcement is regarding the quiz competition. There was a preliminary round in the morning for elimination of few teams, but there was a there is a tie break. And that tie break is between PGIMS Rohtak and Government Medical College, Kanpur, Sonipat. So I want these teams to be immediately here in the hall and on the rear side of it so that we can do a tiebreaker exercise once more. Dr. Uma is here. She can call her residents, and PGIMS Rohtak representative. Okay. We'll find out. Thank you.
आया नहीं है अभी इसको मैं डाल दूं व्यू में डाल दूं okay, it's very close to good morning and good afternoon. Okay, I think I'll stick to good afternoon, everyone. At the outset, I'll feel very honored to be the alma mater of my Pandit Bhagwat Dayal Sharma PGIMS Rohtak, Medicine for Soul. What would we all be without it? So this has been my alma mater. It's a great institution, and I'm truly humbled to be a part of it. And secondly, you know, I'm indebted to my teacher for living, but my teacher for living well. These were the words that Alexander used for his teacher, Aristotle. And I would be using this for my teacher, Dr. SPS Yadav. Whatever, he's been my friend, philosopher, and guide. Whatever small achievement I have made in life, he has played a very important role in that. So with these words, I think we should start on with the topic. The topic is circumferential subannular tympanoplasty, panacea for revision tympanoplasty. Fine. We all have this, you know, we all have these cases of failed tympanoplasty. And like any other scientific person, we have to think that why it is happening and what we can do about it. Okay. So fine. So we studied the literature and we found that worldwide, the success rate for tympanoplasty has been reported to be somewhere around 90%. And the minimal failure rate, you know, has been attributed to infection, hemorrhage, perforation size and location, tympanosclerosis, status of the medulla, and of course, eustachian tube dysfunction and faulty surgical technique. Now, all other features, you know, this infection, hemorrhage and all, you know, they have been taken care over a period of time. What we are basically dealing with two very important things here, you know, eustachian tube dysfunction and faulty surgical technique. Now, a few words about the eustachian tube here, you know. Now, the role of the eustachian tube stands highly disputed today. Number one, there is no consistent clinical method for the evaluation of eustachian tube. Number two, we have a gas diffusion theory, which is now regarded as a more plausible explanation for all ear pathophysiology. It's been proposed by Jacob and Sade. And lastly, you know, what is it that tympanoplasty restores the normal physiology of the ear once you close the ear. That is, once you do a tympanoplasty, what exactly happens is this, that the ear attains its normal anatomy and it starts functioning formally. And that is why you never evaluate the eustachian tube prior to doing a tympanoplasty. Fine. So there are two basic techniques of tympanoplasty. One is the onlay tympanoplasty and the other is the inlay tympanoplasty. So we'll be talking here about the failures of the onlay tympanoplasty. Now, firstly, you know, it's a very difficult technique. You know, you have to remove the outer layer, and the outer layer is very thin. Scientifically, it is just about 30 μ in size. And then you have the problem of lateralization of the graft. You have the problem of blunting of the anterior circles. You have the problem of epithelial pearl formation, and then you also have the problem of cholesteatoma. Fine. Now, what is the basic problem with the inlay tympanoplasty, which is a very popular technique we all are using? It hardly has any deficiencies, but yes, there are some problems with it. And what are these? Number one, anterior and subtotal perforations give very poor results. Why? Because the anterior half of the tympanic membrane is very poorly vascularized. There is inadequate access to the anterior sulcus and anterior annulus. and there is blind anterior tucking of the graft under the tympanic membrane. And here I would like to introduce a new concept, entirely new concept. It doesn't take into account the shrinkage of the temporalis fascia graft. So what is the shrinkage of the temporalis fascia graft? Now, Vormald PG, the same one who talks all about functional endoscopic sinus surgery, he was the first person to talk here about the shrinkage of the temporalis fascia graft. He said that, the temporalis fascia graft shrinks on rehydration. But the true clinical significance of this was quoted by England RJ in 1997, when he said that, the dry temporalis fascia graft shrinks in the physiological environment of the ear, and therefore it might lose contact with the remnant of the tympanic membrane. And similarly, another study came later on. This came in 2002. It was a Chinese study. It says that you had to take an adequate amount of graft, for doing tympanoplasty. Why? Because the temporalis fascia graft shrinks. Fine. Now, in accordance with evidence-based medicine, at that time I was in BHU. I was an assistant professor. We carried out our first study about the shrinkage of the temporalis fascia graft. Now, this got published in the Journal of Otology and Rhinology, and we found there was a significant reduction of the dry and wet graft by about 20%. Imagine. This was our first study which got published, and thereafter I got interested in this topic. Now, what exactly is temporalis graft shrinkage? If you will look down here, when you are doing your underlay tympanoplasty, you're tucking the graft like this. And what happens sooner or later, it shrinks and then it loses contact with the anterior margin. Now, this is very important because you're tucking blindly. A temporalis fascia graft shrinks by 10 to 20% in the physiological environment of the middle ear, leading to the loss of surface contact with the anterior margins of the perforation, thereby causing failed tympanoplasty. That is why you're probably having poor results constantly on anterior and large subtotal perforations because of this blind tucking and this phenomena of shrinkage of the temporalis fascia graft. To counter the discrepancies in the inlay and the onlay tympanoplasty, we have a host of techniques being proposed in the literature. You have the over-underlay tympanoplasty, you have a 3-flap tympanoplasty, you have a modified window shade tympanoplasty. All these tympanoplasties are there, there's a long list. You can go on with it, the loop overlay tympanoplasty, anterior tugging, creation of the pocket of the anterior wall, so on and so forth. And we have used this technique of circumferential subannular tympanoplasty. Now, what is all this technique about? We lift the tympanomeatal flap till from 11 o'clock to 1 o'clock position. Okay. And then there is the placement of the temporalis fascia graft on the annulus. I'll tell you that how much of the annulus you got to cover, about 3 millimeters of that. And then you finally repose the flap here. Okay. The flap comes back. This is the repositioning of the tympanomeatal flap. We studied the literature. We found only 4 studies in the world. Okay. And these were all studies which were done much earlier. And all these studies gave us very good results. It's a forgotten technique. It's not my technique. It's a technique which has been forgotten. In fact, there's a very good book by Portman which tells you about this technique. It is the shrinkage of the temporalis fascia graft, the concept which came in, that this technique is now once again coming in. So you had a 97%. You can see, William and Melody used this in children and found it to have 95% success rate. So the success rate varies from about 95 to 97%. So we carried out our thesis on this. This was my first study. We carried out a thesis of the role of circumferential tympanoplasty in anterior and subtotal perforations. It got published in the Journal of Laryngology and Otology in 2017. And we had a graft uptake of 97%, where the anterior perforations had 100% uptake and the subtotal perforations were 94.8%. And we concluded here that CST has a definitive role in managing the anterior and the subtotal perforations. Fine. With this background, we immediately planned a study to evaluate the success rate of circumferential tympanoplasty and revision tympanoplasty cases. This study was conducted in Lady Hardinge Medical College. It was a retrospective analysis of my data. You had patients, adult patients of more than 18 years of age who underwent chronic suppurative otitis media. The cases, cases with ossicular reconstruction and cholesteatoma granulation were excluded from the study design. You did in tympanoplasty, subannular circumferential tympanoplasty under local anesthesia, an intact graft at the end of 6 months, and a hearing improvement in 10 decibels in 2 consecutive frequencies was regarded as an audiological improvement. We also use a statistical analysis of our data. Now I'll just show you the technique, that what is the surgical technique. I wish the music played on, but it's not playing on. The first thing in this large subtotal revision tympanoplasty cases, we remove the margins of the perforation. As you can see, इसमें music नहीं आ रहा है, audio में audio नहीं आ रहा है. So once you have removed that, then you are doing this thing, you are lifting the tympanomeatal flap. And this tympanomeatal flap is being lifted by from, as I told you, from 11 o'clock to 1 o'clock position. And now that you can see, we are completely lifting the, this has been lifted up. And now it has been tucked in anteriorly. And after this, we are now going to denude the epithelium of the handle of malleus. This handle of malleus, there you can see I'm denuding the epithelium from the handle of malleus. And now we are preparing a graft bed, you know. We are just putting in the gel form in the middle here. It's a very simple technique and it will give you 100% results. And now we are placing the graft. The graft is resting on the annulus. It overlaps the annulus by 3 millimeters. And now we are repositioning the flap. What I showed you in the diagrams, exactly the same way we are doing it. And there you are, we have completely repositioned the flap. And now there you are, the tympanic graft lying between the repositioned flap and the annulus, the bony annulus. So there you are, you can take a quick recall of the steps. Number 1A, where you lift the tympanomeatal flap. And once the tympanomeatal flap has been lifted, the C part shows you the denudation of the handle of malleus. Then D, you prepare the graft bed. And then finally, you put in your graft and you reposition it by your tympanomeatal flap. Fine, we had 91 cases which we had done with this technique over a period of last 10 years. And when we revised our data, we could not find much. We included 81 of these patients. And they were most of the patients presented to us with post-operative discharge. All these patients had failed tympanoplasty only once. And most of them came to us, you know, after 1 to 5 years period. And in the previous surgery was either done by onlay in 17 cases. It was done by inlay technique in 50 cases. And they were unknown in about 14 cases. There was no medical record available for the 14 cases. Fine. What were our results? Our results were very impressive. We had a surgical uptake of about 80% here. You can see 98%, sorry. And we had an audiological success rate also, since the p-value was found to be highly significant. That is 10 decibels improvement in 2 consecutive frequencies. We found no effect of the site of perforation in our revision tympanoplasty. See, previously we picked up our cases, you know, we picked anterior and subtotal perforation, but for revision tympanoplasty, we at random picked our cases. And once we did a statistical analysis, we found that there was no significance of site of the perforation, and there was also no significance of the size of the perforation also. Fine. So what are the advantages of this circumferential subannular tympanoplasty? Number 1, the graft is placed directly on the annulus, not blindly tucked in. Number 2, it is not affected by the physiological shrinkage of the temporalis fascia graft. The graft is placed 3 millimeter overlapping all around the circumference. It gives you a very good anchorage of the graft, both at the annulus and the handle of malleus, and it facilitates ossicular reconstruction. If you want to do a tympanoplasty with this, again, an ossicular reconstruction, then you can do it. There is no problem with this technique. We want to make two very important scientific observations. Number one, we did not encounter any lateralization of graft. Why? Because probably the graft placed on the annulus is held in position by the tympanomeatal flap. And secondly, the gel form packing of the anterior part, we were able to generate a sharp tympanomeatal angle, which itself prevents the lateralization of the graft. We use the post-auricular route. We believe that the post-auricular route gives you a 20% more observational area. And above all, we in none of the cases required any drilling of the anterior wall. We have been doing in our college the post-auricular route, and we have never used a drilling for the anterior wall, even for this technique as well. And how is it different from the overlay underlay technique? When I presented this paper for the first time internationally, a lot of queries came up. So I immediately put up this slide here. Now, what happens here is this, that, in the overlay underlay technique, which was proposed by Cartouche in 2002, he says that you place the graft under the remnant of the anterior margins of the tympanomeatal graft, of the tympanic membrane. See here, he is taking the graft and he's putting it under the margin. In our technique, we are directly placing the graft on the annulus under direct vision. And our technique is and it is not a modification of an overlay technique. The tympanomeatal flap is lifted, you inspect whole of the middle ear, and you once again reposition your graft. And there you are. So we found in conclusion that there is an accident result for division tympanoplasty, number one. Number two, it seems to be a solution for the principal disadvantage of the inlay or the onlay tympanoplasty. There are three important causes of tympanoplasty. To summarize them, number one, eustachian tube dysfunction. Well, its role is highly disputed. Secondly, the surgical technique. We all have a learning curve. It takes time to adapt to your surgical technique. And thirdly, there is the shrinkage of the temporalis fascia graft. And circumferential subannular tympanoplasty seems to address this thing, the shrinkage of the temporalis fascia graft. Find what are the advantages of the circumferential subannular tympanoplasty. There is no blunting of the anterior angle. There is no lateralization of the graft, and there is no blind tucking. You are under direct vision, 3 millimeters overlapping all around the circumference of the annulus, which counteracts the shrinkage of the temporalis fascia graft. We published this got published in the American Journal of Otolaryngology. And I told you we received a lot of queries on this paper. We had to give a lot of rejoinders as well. They also stand published, because this is not my technique. It's a technique which has been lost in the sands of time. So it was a technique which was, we read in a book when I was in BHU. It was a Portman's otological surgery. He's a French otologist. Probably that's why he didn't get so much of acclaim for his technique. And well, both these articles have had a great citation index. There has been a revision tympanoplasty has got 5 already, and the large and subtotal perforations have got 9. And I recently from India, somebody, we all know him, Ripudiman, he met me, he said, sir, that we are also publishing a series of 224 patients on circumferential subannular tympanoplasty. So my idea of introducing this technique here is that more and more surgeons should start using this technique, because this really helps a lot and it counteracts the shrinkage of the temporalis fascia graft. So to improve is to change, and to be perfect is to change often. And in the end, I'd like to thank the organizers for giving me an opportunity to interact, especially Dr. Munjal, with all of you on this very interesting subject. And any questions, queries, they are most welcome. We'll answer them to the best of our academic and clinical knowledge. Sure, sir, please.
Very good presentation, Dr. Gautam. I am also doing the same way for the last many years now, and I find this is the fittest way of avoiding that shrinkage part that you mentioned very rightly, and the avoidance of lateralization and blunting of anterior-inferior angle. My query to you is, where do you place the graft in relation to the residual handle of malleus? Do you put lateral to it, medial to it,
Sir,
or
all
at the
these
level?
were cases of tympanoplasty 1. We have never found a case where the handle of malleus is eroded. Yeah,
So
you put
we
it,
seldom find it.
you put over it, I mean,
Yes, over it.
lateral
Yes,
to it.
Yes, lateral to it. In fact, that is what I want to emphasize. At the outset only, and without showing the video, I emphasize this is it, sir. I mean, everyone can appreciate this. The graft is placed, sir. मैंने कहा था मत कटाओ. आपने एक सेकंड नहीं लगाया, अभी तो चल रहा है.
Okay, it's all right.
नहीं, sir,
we
I'll
got
just-
it. We got it.
वहां से कर दो एक मिनट. It's lying lateral to the handle of malleus, sir.
Okay. Any failures, about failures you have not mentioned? Anything which troubles you with this method?
Sir, none.
Circumferential.
We have had
subannular.
failures, sir. Even in this series of patients, we had failure. There were, sir, there were 2 cases who failed, sir. In spite
Now
of
you are advocating it only for revision tympanoplasties,
So
or
this
for
study-
regular tympanoplasty also you are
sir. Sir,
adopting this?
No, sir. This technique we are only using for revision tympanoplasty now. But previously, sir, we conducted a thesis in our department. This one, sir. This we did only for anterior selective cases, sir. Just anterior and large subtotal perforations.
My take is, why not this method as a regular tympanoplasty method?
Yes, sir.
Why
I
only
think-
limited to revision?
I mean, I have
Sir,
no.
let us
reason, sir.
let us do
Exactly,
it
sir.
in first go itself, so that we do not have the need for a revision tympanoplasty.
Exactly, sir.
Thank you.
Exactly.
Thank
That can certainly be done. So the healing of there has been lot of studies on onlay. No, sir. We place a graft medial to the handle of malleus just because that it should not lateralize. It has no role in hearing improvement, sir. Nowhere is it written in the text that that if you place a graft medial to the handle of malleus, your hearing will improve. No, sir, it has. But nowhere is it mentioned that to improve your hearing, that you have to put your graft medial to the handle of malleus.
Dr.
Where, sir?
Surinder, I do agree that it is not according to the physiological conditions, but it increases chances of take-up.
Sir,
So
where
we
this
are
is
compromising a little for the sake of complete take-up of the graft.
So where
That
this
is the
written?
advantage.
I would like to know. I mean, we all want to get enlightened. In which book is this written, sir? No. It 1 or 2 odd papers is not, sir. Is not going to form the dictum. Yeah. We saying that the 3 millimeters, if you put on the
Yeah,
annulus,
3 millimeter will bring it on the canal also.
will bring it on
Obviously.
the canal. Definitely
Yes,
will
sir.
bring it on the canal.
I think keeping the time factor in mind, Dr. Munjal,
Sir, एक
Dr.
question-
Gautam can answer the queries later.
Chalo.
Thank you.
Hi.
Thank you so much, sir. Thank you so much, sir, for the wonderful talk. Now I request our chairpersons to kindly felicitate our speaker, Dr. Gautam Veer Singh, sir, with a memento, please. Thank you, sir. Now I request our speaker to kindly present mementos to our chairpersons, please. Thank you, everyone. Now, we have a panel discussion on the topic difficult situations in mastoid surgery, which will be moderated by Dr. Nikhil Arora. I request Dr. Nikhil Arora, sir, to kindly come on the stage.
So I think till it connects, we are already running out of time. So I'd like to invite the panelist, Dr. JC Pasi, sir. He's my teacher, sir. He's currently working as Dean in World Medical College. And sir is ex-HOD and director of MAMC and Loknayak Hospital. Dr. Aditya Bhargav, sir. Sir is the head of the department at Pandit PGIMS Rohtak. Dr. Vikas Kakkar, sir. Sir is ex-head PGI Rohtak and currently heading the department at SGT Medical College. Dr. Uma Garg, ma'am. She is head of the department at BPS Kanpur. Dr. Anil Monga, sir. Sir is senior consultant at Gangaram Hospital. Please, sir. Now, I think 2-3 panelists could not make it, so I've just taken the liberty of inviting. Sir, already here. Okay. So I've just taken the liberty of inviting 1 or 2 youngsters. Dr. Manvi, she's a consultant ENT practicing at Bahadurgarh, please. And Dr. Ashima Saxena, she's a consultant ENT practicing at Rewari. So we have a mix of both senior and junior colleagues. Not connected. It's not connected, right? So the difficult situation in mastoid surgery was the topic given to me. Now, this difficulty can be very subjective. A young postgraduate student who's starting a mastoid can have different anxieties, different apprehensions, and a senior person can have totally different. Now, I've just jotted down most common of the complications that we can see. Now, whenever we are starting to do mastoid surgery, this is one of the very fear that we have in our mind as a postgraduate student. There is a low-lying dura, there is an antepost sinus. So I just want to know from the panel, I'll start from Dr. Pasi sir. If this is the condition, there is a very low-lying dura and an antepost sinus, do you plan preoperatively, sir, which approach you will take, or you have a preformed approach in mind, or you can change accordingly?
To me, a post-oral approach always looks good for all kinds of abnormal conditions. I'm comfortable, like Dr. Gautam also presented, saying that he has performed all cases through post-oral approach, and he found no reason to even do some canaloplasty in all cases. So I agree with that. And as far as this particular situation of low-lying dura and antepost sinus is concerned, this is quite frequent problem. It's not infrequent. We generally come across this situation. And approach-wise, post-oral approach, and of course, many people are very fond of inside out, but I am not that much fond of it. I do outside in. I will open up the mastoid antrum in a conventional way, keeping all the precautions in mind while opening up the mastoid antrum in this kind of situation. That what I do is, generally I have seen in the beginners that they keep the posterior canal wall part very thick.
Right.
If you are very, very clear from the very beginning that you are not going to injure facial nerve, you should be clear about the anatomy. You should keep the posterior canal wall, which will become the anterior wall of the mastoid cavity now. That anterior wall of the mastoid cavity should be thin so that your drill is not touching the antepost sinus. And also similarly, we should take care while we are drilling or widening the adductors, which will also be narrowed in these kind of situations when the dura is low lying. As we know that as we go anterior towards the aortic region, the dura becomes lower and lower. So you are likely to open up dura more in the adductors area than in the sinodural angle area because of its inclination towards anteriorly. So if you keep these precautions in mind, you will be able to handle most of the situations of contracted antrum, low-lying dura, and antipose sinus.
Okay, Dr. Bhargav, sir. Sir, I'll be coming to each. So, Dr. Bhargav, sir, you go with the same approach or you change your approach if you see this?
There's no idea of changing the approach.
Right,
Only
sir.
my take here for the younger people is
Yes.
that the situation is there. How do you diagnose this situation? Like this is a operative picture, but we have to be prepared for
Yeah,
this.
pre-operatively we'll go for a
Pre-operatively, I think even a simple good digital X-ray of the mastoid's lateral view will point towards this. There is no idea of doing HRCT and all those for those cases. So you have to be preemptive.
Okay.
To know that this situation might occur. See, it is always not there that whatever the X-ray or the radiology is showing, and once you are operating, the situation can be a little different.
Yes.
But most of the time, it is pointing towards that, yes, we have got a, like Dr. Pasia said, we have got a contracted antrum. That is.
Yeah, so basically pre-op CT scan will guide you.
CT scan
But-
or X-ray, whatever, whatever
anything, any
the
message.
institutional this thing is there.
Okay. Dr. Vikas Kakkar, sir, anything, sir, you want to add? Or
the one thing I want to add is for the younger people, if you are not able to find the antrum, many times it's just below the medial to the posterior wall of the bony canal. What you have to do, you have to follow the dural plate.
Yes.
You keep on going anteriorly. What this mastoid antrum is, it is just another air cell.
Okay.
It's
Yes.
nothing else.
Right. Right.
You should follow the dural plate, and ultimately we will reach to the mastoid antrum,
Antrum.
where you will find the bulge of lateral central canal. That's
Yes.
my question.
Yes. Dr. Umagar, ma'am.
I think there's hardly anything to add. The thing is that in starting the drilling,
Yes.
anatomy should be very clear. I think a McEwen's triangle should be marked perfectly on the mastoid, and then you start the drilling. But if it is a small contracted antrum,
Yeah.
and you are not able to, or you happen to have a low-lying dura or antipose sinus, there's nothing to be afraid of.
Okay.
You still stick to the anatomical landmarks, and for a small contracted antrum, if you're still not able to drill safely without touching the problematic areas,
Yeah.
then we can go inside out.
Inside out. Okay. so
Otherwise, we'll be able to do it.
you will prefer outside in approach. Okay.
Yeah, yeah.
Dr. Anil Monga, sir. So anything inside out in this or
Sometimes
mic? Ek mic. Give one mic. Can you have one hand mic here?
Yeah, so I think I agree with all the panelists who have said everything, but once in a while I must have done an inside out in
Okay.
this kind of situation when the operative area was very narrow and I was tending to touch the low lying dura. So mostly I would follow what all the panelists have done, and this is what should do.
Right. So anything, Ashima, on inside out approach?
Sir, I'd only like to add one thing, that usually the bone itself will tell you that it's going to be sclerosed.
Okay.
What happens is if the mastoid is very cellular, you'll have a very good cribrose area, and when you will start drilling, you'll start getting air cells. If in the beginning of the drilling, you're not getting good air cells and it's a very thick cortical bone, anticipate a contracted antrum. And that's when what Kakkar sir said, that we should start following the dura, is a very good tip for all beginners. For another fact, if you're doing it in private or unsupervised, also switch to a diamond of the correct size, draw the McEwen's triangle in your head and switch to a diamond and follow the dura. You will be helping yourself a lot. The second thing is always raise the tympanomeatal flap so that you have an idea of the depth of the antrum. And there is no harm in curating the posterior superior wall of the canal to give yourself an idea of which is the direction of your adductus, and then you can locate your antrum much easily.
Okay. Anything you want to add, ma'am?
I think.
Yes, sir. Yes.
But is there any harm going inside out?
So just I'll be, yeah.
There is no harm. It is a
I
matter
think-
of confidence. We are talking in terms of beginners.
Beginners.
They might touch the drill with the ossicles. They might.
So these are the risks involved.
Yes,
Yeah, there should be a balance
Ideally,
basically.
yes.
If you are able to get it, then get it.
Yes. So basically, for beginners or outside in approach, like for these contracted antrum also, like sir said, if you are following the dura and delineating the segment, we will be able to find the antrum safely. But as we experience grows, inside out approach is very good for these cases. In fact, if we get used to it, and obviously preoperative X-ray or CT scan, as Dr. Bhargav sir said, will guide us inside out or outside, depends upon the experience of the surgeon. Very important, dura delineation, smaller size burr maybe in this area to avoid damage, and using of a diamond burr or a cutting burr with a slow speed in that area. So coming to the next, this is a sigmoid sinus bleed. Like we have already discussed this antepost sinus, but what happens if our burr accidentally touches this sinus and we start having massive bleed? It is in the surgery, we're doing the burring and we start having this bleed intraoperatively. So starting, I think Dr. Monga sir, how will you go about if you intraoperatively this happens?
See, the first thing we should put some gel form over there, wait for a while, to then pick up and put a cotton bud over it. After a minute or two, when you pick it up, you will find, exactly you can locate the bleed. And after that, generally I do muscle, collect a muscle and put a muscle seal in that. And most of the time over that, at the end of the surgery, we put a fascia over it.
Fascia.
Sometimes what has happened is that you have not completed your mastoidectomy. So what I do is I collect a piece of either the cardboard from the Ethicon suture material, make a strip and keep it there. Then I go ahead with the drilling to complete the job.
So you'll continue with your procedure, right, sir? Yes. So Dr. Yes, sir. So
it happened with me.
Yes.
It was about 2 years back or so, maybe 3 years. I was operating on one case, and that this sigmoid sinus was exposed. And accidentally, I was using the cutting, but it touched the sinus, and there was a profuse bleeding.
Okay.
In spite of best of efforts, we were not able to control the bleeding. We tried everything, put in the surgical, gel form, pack, everything. But we were not able to control the bleeding. Ultimately, I put the pack and gave the mastoid dressing.
Okay, you abandoned
I deferred the case.
Okay.
I opened the case after 48 hours, 72 hours. There was no bleed at all. It was absolutely healed.
So anything you added in that post-op period, sir? Like
I did it normally, and there was no problem at all.
no added precautions post-op. Dr. Pasi, sir.
I'm aware sometimes some people abandon the procedure because of the bleed in this area, but I don't think I have ever had to abandon the procedure.
Yes.
Number one.
Yes.
We only have to be patient, delay it. You start working in other areas. Once, you are working in the mastoid region when you have this bleed.
Yes.
So what you can do is you put the pressure with whatever means is available to you at that time. Put the pressure, sustain it, and you start working in the middle ear.
Okay.
By the time you finish your middle ear work and you open up this, you will find the bleed is controlled most of the time. But in case, like Dr. Vikas Kakkar's case, it did not stop. So we have a role of bipolar cautery.
Bipolar cautery, right.
Okay. We can always try that. There is no harm, especially when you all have a bleeding from a granulating sinus, which is already dehiscent, exposed due to the disease process.
Right.
There also this bipolar cautery works wonder.
Right. Anyone, ma'am, you have to add?
Same thing, like I agree with Dr. Vikas Kakkar. We had, I think, Nikhil, it happened in your
in our
only, that we had that despite everything, the bleeding won't stop. So we had to pack it and, wait for 48 hours or something, like exactly what Vikas was telling, that same thing. Because we had tried everything, all the pressure, everything was tried. I don't think so bipolar was tried at that time because...
No, actually, this one case we were able to control intraoperatively only. We continued.
There is, and my take on this is that since we are talking about the youngsters and for youngsters, the thing is that these type of bleeds, whether from sinus or from the dura, they will keep on happening. Accidentally, you can keep on touching the dura or the sinus, So the no panic situation should be there. We must understand that if the thing has happened, we have got means to control that thing.
Okay.
If we go by that belief, that we will not panic. So we will have to panic maybe later on, some ligation of somewhere and all those things. It is there. So no panic. If the person starts panicking, then things start deteriorating at that time.
For this, I always use the term packing, pressure, and the patience. These are the three things that really work for this.
Okay. So, like all the panelists have said, you have to just keep on packing. So we had this another case. We kept on packing and all, and believe me, if you will be frightened initially, but if you have patience, like sir said, you will be able to control the bleed, and you can put a bone wax or bone pate over it, and you can continue with your procedure. So, like preoperatively, you should look for a sinus plate erosion on CT scan. That will be a good landmark. Like tight packing, when there is a bleed, you can use gel foam, bone pate, bone wax. Surgicel, I think Surgicel is one thing which helps in these cases. As Dr. Pasi sir said, if there's a small bleed, you can try a bipolar. Post-op, if it's a dominant sinus, you have to rule out if the patient is having intracranial pressure signs and IV antibiotics in these cases. Now, sir, this is another scenario very commonly seen, the corner septum. And we usually, many times we lose the path where we have to go. So, Dr. Kakkar sir, if we have this situation, there is a pre-op corner septum on the CT scan, how do you go about it, sir?
One thing is there in the literature, the incidence of corner septum is very high. But in the practical scenario, we don't find that frequently. The reason is the corner septum is partial. It's not always that this is complete. And secondly, one should always keep the level of annulus in the view, mastoid cavity and the annulus in the view. This antrum has to be medial to the annulus. It cannot be lateral to the annulus.
So the depth, you want to say the depth of the
middle ear should be in view. You should always keep the middle ear and the mastoid cavity in one view so that you can see the level of annulus. You drill the corner septum, go medially till the time you find the antrum. It's nothing to panic about, nothing to worry about.
Yeah. Dr. Pasi said,
Dr. Kakkar said rightly that this is a very high percentage, up to 10% has been mentioned in the literature, and we don't find that 10%. The reason is that I will call it as a sort of underdiagnosed condition. It's quite frequent, but since most of these corners are incomplete, so we do not, think about that. But definitely it creates a hurdle in reaching the mastoid antrum initially. It gives you doubts, and you keep on trying to see the dome of the lateral submucous canal. You keep on putting the ball probe to ascertain that it is going into the natural passage of aditus, which will be the confirmatory test whether you are in the antrum or not. So the gold standard, as Dr. Kakkar said, keep watching the annulus, and it has to be medial to it. And also anatomically, we all know that from the cortex of the bone, this mastoid antrum in an adult should be deep to 1.2 to 1.34 centimeter. Okay, that thing should also be kept in mind. What happens is sometimes we start drilling and immediately it looks like we are in the antrum, though it is a corner septum. So it looks like, but you are not able to actually pierce through the aditus. So you should then gauge how much deep you have drilled. If it is less than 1 centimeter, so you know that you can still dig it further.
Anyone wants to add?
As far as radiological diagnosis of corner septum is concerned, as said that though the corner septum is as common as 10%, but radiologically diagnosed preoperative corner septum is much less. Because of maybe our lack of knowledge of this thing, or maybe we are not very, very keen to diagnose the corner. But if it is diagnosed, then the matter is solved. Then we are knowing that we have to deal with corner septum. The reason for that is partial corner septum is not always diagnosed radiological. 100%.
Sir, one thing I want to add, as a young surgeon, one way to be safe is to always drill a wider cavity. So if you're drilling wide, you will always be able to identify this bony plate. If you're going in a tunnel, chances of injury are very high. So that's just one point that I want to add, that go wide always while you're making your cavity. You will be able to identify this.
I think, as sir said, like we'll be able to identify the dome of the lateral semicircular canal. And what happens is that in irritation, frustration, like when you are starting, we injure the second genu of the facial. We think that we have already entered the antrum, and we start looking for the adductus that we're going to widen, and second genu of the facial now gets damaged there very commonly. So CT scan, like everyone said, less than 10%, not able to diagnose all the time. So it can help. You can delineate the dura and follow the tegmen. Look for the dome of the lateral semicircular canal. And this is one of the major causes of like disease left behind. Cholesteatoma usually lying in the antrum, and people think that they have opened the antrum and come out. So you have to be very careful. Now, coming to lateral semicircular fistula, Dr. Bhargav sir, so pre-op CT scan, we have got a lateral semicircular fistula. Intraoperatively, we see this. Sir, how will you go?
See, the fistula anywhere, the golden principle is that we have to, cover it with some sort of seal and carry on with your surgery. And the best things are that there are so many material available. I think there is no other doubt about it. Just to seal it and carry on with the surgery.
Dr. Kakkar sir, anything else?
And just for the sake of younger colleagues over here, in every case of cholesteatoma, you should suspect facial nerve dehiscence and the labyrinthine fistula. You go with the idea that every case is having labyrinthine fistula and the facial nerve dehiscence unless proved otherwise. And how do you diagnose a fistula? You should look for the bulge of the lateral semicircular canal. It has to get flattened before the fistula is formed.
Right.
The bulge is not that prominent. If fistula is there, the bulge will be flattened.
Okay.
Canal. And once you diagnose, once you know it, the fistula, we can tackle it separately. There are various things, I think.
Covering of the fistula, sir.
If you want me to
so,
explain.
no, pre-operatively also, sir, we can do, we can take the history of the patient and
yeah.
Vertigo will be there.
Yeah. So like ma'am said, vertigo will be there. We can do fistula test and all that things. We can.
There it is
yes.
pre-operatively already. It is CT
Yeah. So
scan
this is a CT scan.
pre-operatively.
Yeah. Pre-operatively we see.
That doesn't deter us from operating.
No.
We have to operate and then we are ready for it. So.
Sir, intraoperatively, while working around this fistula, Dr. Pasi, sir, any?
Yeah. That important thing is once you see or suspect a fistula is the last thing to be handled.
Yes.
While we are clearing the disease, we should see to it that we do not choose to remove the cholesteatoma sac from over it in the first go. It should be done at the last. And your suction has to be very carefully handled, that your suction should not touch this area. These are the two things that if you follow carefully, you will be able to manage it.
Okay. Dr. Anil
One more thing.
Yeah.
Adrenaline should not be used over the fistula.
Okay.
Right.
Okay.
And secondly, while for giving the repair, I just want to give one information to the younger people. It has to be replaced by the labyrinthine bone is the hardest bone in the body.
Yes, sir.
So just a fascia cannot repair it.
Okay.
So it should be repaired with either with the cartilage or that we can put the bone dust, because otherwise the patient will keep on having vertigo in the post-op period.
So I think that if endosteum is intact, we can go for fascia. But if endosteum is also dehiscent, then we have to go with some muscle or a
yes, and
bone
as
patch.
the labyrinthine bone, the hardest bone in the body, so
yes.
It has to be replaced with something hard.
Dr. Anil Mama.
Dr. Nikhil, bone patty is something I have observed. If you are not very careful and if you are not, you have not diagnosed it pre-operatively,
Yes.
then taking the bone dust will
Fresh.
be a risk
Okay.
of secondary infection post-operatively.
Okay.
So if you know it post-operatively, pre-operatively on
Pre-operative.
CT scan finding, then you harvest and store the cortical bone in the beginning itself.
Beginning itself.
Before you open up the antrum.
Fresh
This bone
bone,
must be
yeah.
collected before the mastoid is opened.
Open.
So this is the method of collecting bone dust to make it bone pate. This is which will be the best thing to be used. Otherwise, you should avoid using it, and cartilage is a safer option.
Safer option.
Sir,
I just wanted to emphasize the point that Dr. Pasi made, that we should, whenever you are in front of the fistula, you should tackle in the end. That's the
In the
point
end.
I want.
Yes.
Mics. So if intraoperatively we have added, again we have to repair it. After removal of the, basically it will be accidentally, like someone has drilled the lateral semicircular. Yeah. So basically, sir, what we'll do, we have to repair it intraoperatively, and we have to be very gentle. Like sir said, we don't have to put direct irrigation or direct suctioning over that area. Blunt instrument to remove any granulation or something. And post-operatively, we have to be very careful. Patient is not having any sensorineural hearing loss. We can counsel the patient post-operatively. No, sir. If we can give sense, sir, like you said, iatrogenically, if we drill the LSC, patient can have a dead ear post-operatively also. Yes. Okay, sir. Yes. Yes, sir.
Normally, physiologically, the uterosaccular fistula, that wall closes.
Yes.
Closes, that it cuts off the pars superior from the pars inferior. In fact, we had one resident who did it, and we kept a very close follow-up with the patient. The patient had no hearing loss.
No hearing loss. So,
surprisingly, he had imbalance.
So I think
that prompted us to study all about the lateral sinus fistula. A lateral sinus semicircular canal fistula is now written in the books. It's mentioned in Breakman's textbook also of surgery, that it doesn't cause much of a hearing loss. It will only lead to imbalance.
So actually, we are trying to avoid the hearing loss we can give as surgeons.
So Dr. Gautam,
that is what is being discussed.
Like what I tell my postgraduates also in all the ear surgeries or mastoid surgeries, what do they carry in the pocket first day? That is a tuning fork. Okay. So if the tuning fork test says that it is lateralized to the operated ear, I am happy. If the tuning fork says that it is lateralized to the opposite ear, then I am very unhappy. So
I
that
think
is
the situation that you said. I think you were very.
Sir, we also, I wanted to.
Yeah. So you were very lucky. Good for you. We had a similar case. Yeah, we had a similar case. Yes, sir. Yes.
Dr. Raman also wants to
yes,
say
sir. Raman, sir, if you want.
can you, without mic?
Mic, sir, you
is
can
not-
take. Okay, sir.
One more important one, if you see the blue line, then it will end of them
Intact.
Yeah.
That's right, sir.
Yes. Yes.
all the protocols.
Right.
But if it is soft palpation, then size is very important.
Right.
If size is less than 2 mm, you can remove the matrix.
Right.
If size is more than 2 mm, you will have to leave your matrix.
Okay. We will leave the matrix there. Right.
Sir,
Okay, sir.
Yes, size is important. Yes.
Dr. Singhal was trying to say the same thing. Thank you.
You should not leave the matrix. I'll move it out the party. You should never leave any cholesteatoma matrix in the mastoid cavity. That is very, very important.
Okay.
You got to seal the fistula, you just
Right.
can't leave the matrix.
Right. Yeah. So we'll. So yes.
Yeah, you can leave it.
I
You
think, sir, there is a.
Yeah, you can leave it.
So it's a very.
You should. No, you should pick up each and every piece. Of
Yes, sir. So
information
Raman sir
because
said like he'll
we are
leave. So I
pulling
think
things.
varied
If
opinions,
the
varied
cavity is
experiences.
okay,
That's what
then
we are here for.
Granulation will be.
No.
If you can remove.
Second stage.
Gently. It is
You'll do
okay.
second stage, right? So I think just to.
Dr. Nikhil, we have to hurry up.
Yeah, we have to hurry. So pre-op counseling, I'll say one thing: if you are suspected, you need to talk to your patient and tell him what can happen post-operatively. Remove at end, like Dr. Pasi has said. Avoid direct suctioning irrigation. I've seen many times residents doing pressure with gauze, thick, very major pressure they put, so patient can have vertigo, dizziness post-op. You have to use steroid pledgets. Steroid pledgets will prevent your SNHL post-op, can cover with fascia, cartilage or muscle, and post-op you give antibiotics to prevent the labyrinthitis and IV steroids as well. Okay, coming to next, I'll start with Manvi this time. So we got this situation, we got dehiscent fascia now very commonly seen in mastoid. In this case, we had a complete dehiscence of tympanic segment and it is prolapsing over the oval window. Only stapes suprastructure is present. So in general, tell me how will you go with the dehiscent facial when if you see it during mastoid?
Yeah, in case of a dehiscent facial nerve, first of all, the major thing that we start is we have to look for the landmarks. We have to be clear about the landmarks.
Right.
And if we don't touch it, then that will be a better thing. We have to operate, we have to widen our cavity and do a proper mastoidectomy. But while suppose if we are, when we are near the facial nerve, I think we should be using the blunt drilling counterparts rather than drilling very fiercely. And the irrigation part should be very good because the facial nerve is dehiscent in that area. Suppose while drilling around the area, we do an injury, that is a nitrogenic injury,
Right.
and there is some sort of bleeding which we see. Then we would say that, proximally and distally, we need to expose certain area of the facial nerve so that in case post-operatively, there will be some edema around the area and that gets some space so that there is no compression over the nerves. And post-operatively, I would give steroids to the
Right.
patient.
So, Dr. Anil Monga sir, like blunt instrument, she said, you'll remove the disease from the dehiscent facial. Anything other precautions?
See, you cannot do anything short of that. You have to
Right.
clear the disease. That's
Yes.
the main thing for what we are going.
Yes.
So we have to be careful.
Yes.
And generally, if there is a cholesteatoma sitting on this dehiscent facial nerve,
Yes.
you can start from the periphery. From there, if you can see on the right side, lower part of the picture, you
Yes.
can gently start making a plane between the bone and the cholesteatoma matrix, and gradually you get the plane and you are able to peel it off. And
Peel it,
generally the facial doesn't, it's quite a resistant structure, facial nerve,
Yes.
doesn't get damaged in a hurry.
Correct. Sir, Pasis, like in this case, it is prolapsing
Yes,
also.
I agree with Dr. Madhvi, but once we find the dehiscent facial nerve due to disease, we
Yes.
will have to touch it. We
Yes.
can't afford not to touch it. And I think it should not frighten you. Facial nerve, as Dr. Monga said, is not easily damaged. It has a sheath. And in a diseased facial fallopian canal, you will always either have cholesteatoma or extensive granulations.
Yes.
And you will have to touch in both the situations. To me, removing cholesteatoma sac from over the dehiscent facial nerve is the easiest thing. It doesn't bother me at all.
Okay.
It never gets damaged because it's very easy to peel off the sac of the cholesteatoma. What bothers me is the presence of extensive granulations, which will also hide the view of the facial nerve. It will not be very easy for you to delineate the facial nerve because of the presence of extensive granulations all around. But then there also you have to work, and you can always easily remove it. And of course, extensive heavy steroids post-operatively, as Madhvi said, will be required in all the cases.
Dr. Umagar, ma'am, you would like to do osteoplasty in this case, in same sitting or?
No, yeah, there's an opinion. If you are sure, it depends on the surgeon. If you are sure that you have removed each and every part of cholestoma and granulations as well,
Yes.
then you can do osteoplasty in the same sitting. But otherwise, you can leave it to the second sitting.
Second stage. Okay. So anyone?
See, if you are a little daring pathologist, you can always move the nerve. You take it out from its socket. You move it away from the suprastructure and
Right.
can still perform.
So you'll go for same sitting.
Yes.
Sir. And cartilage, sir, for ossicle.
I will definitely try to avoid keeping cartilage close to the exposed.
Close to the exposed. Thank you. Thank you. Okay. So I think we have discussed everything. One thing is we can decompress if you have damage during the surgery. So in the same sitting, we need to decompress. If it is cut, go for approximation, ossicoplasty plus minus, and IV steroids post-op. Now, this is also one condition very commonly seen in mastoid. We have a long incus accidental dislocation, or we have a necrosed long process. So, how will the panel go about reconstructing this one? I'll start with Dr. Vikas Kakkar sir. Only stapes is present, complete, and malleus is present, but incus is missing.
I generally prefer to use a small piece of cartilage.
Cartilage, right?
And make a socket over it and put it over the head of stapes.
Okay.
And again, it can use a little bigger in size so that it can touch the handle of malleus also.
Malleus. So basically, you're trying to increase the height of the stapes that way.
Yeah.
Right. Dr. Anil Monga sir, anything different,
Yeah,
sir?
it's better to use cartilage. Previously, we used to use a lot of homoincus, which was available deep. The long process was not there, but if you put a ball probe inside, you might find the body of the incus, which we used to use in the past. But later on, I realized that all of these ossicles made from the incus have some kind of fixation later on.
Okay.
So nowadays, it's better to use the cartilage or use a TORP or POP, some interventional artificial material like titanium or anything, whatever you like.
Right, right.
I'll always prefer an autograft.
Autograft, right.
Autograft, be it cartilage or the remaining incus. What is the other question?
So, how will you like to reconstruct this?
Yeah,
cartilage
so
and
I will prefer it tympanoplasty type 3 in most of the situations.
Yes.
And I will avoid a use of homograft.
So many people nowadays are using.
This must be clear to everyone sitting here that we should not encourage use of homografts anymore.
Because the results of TORP, PORP vis-a-vis the results of autograph, there's nothing to be talked about in that. Nowadays, TORP, PORP are not generally used. Only cartilage is.
So many people are using boomerang like we saw yesterday. Dr. Madhuri
Dr.
Mehta.
Madhuri showed it. Yeah, that is also one of the options.
Yes. Vertical strut. Which?
So in every case, we are using autograft, whatever way.
Cartilage. Right.
Diseased. Be diseased. Yeah.
No, this is a general cortical
see,
mastectomy, sir. And
Dr. Gotham, here
many
I would like
people
to,
are using
see, ossicles can always be used. In cholesteatoma also,
So-
it can be used. Can I complete my sentence? You can use your micro drill nicely. You can drill out the remaining ossicle nicely. Drill out nicely enough, thin it out. You will not have any cholesteatoma lying left over it. You can do it under microscope. There's no problem.
Yes.
So you can remodel the necrosed ossicle, but you have to satisfy by adequate drilling that no cholesteatoma is left on that residual ossicle. You can
So,
use it.
actually, as I
But
said-
cartilage is preferred not because of this fear.
Yes, sir.
Cartilage is preferred because it sustains longevity is more with cartilage than the bone. Bone resorption is very much there post-operatively. So for that reason, we always prefer now cartilage than the bone.
So, sir, like you said, there are two schools of thought. So many people say that the vascularity is compromised. So it but we have been using for years, like sir has been. Yes. Yes, sir. Yes, sir. Cartilage also, but we have been using it. We keep on drilling it, and we have been using it to create a socket, as sir said. Like you've got a body of
Dr.
incus.
Gautam, will you allow me to use autograft ossicle in case there is no cholesteatoma and yet I have to do it reconstruction? There you will allow me? Sure.
Yes.
So
So
thank you. I
seeing
think
the
that-
paucity of time,
that's
I'll just move ahead. Now, I'll skip this because I already discussed the segment sinus. So this is also very common, like we have injured the dura while drilling, if there is a low-lying dura or something, and CSF leak starts coming intraoperatively. Usually you'll be called only when, or you'll see this leak has started to come. So sir, starting again with, I think Dr. Bhargav sir, I'll start this time. Sir, how do we go about this, sir? We got a small rent in the dura intraoperatively.
This here, I would like to first seal it with this, like temporarily we put the gel foam and all.
Right.
And then with the help of bipolar, this can be
Bipolar. We can cauterize small defects. And you like to reinforce, sir, with some reinforce the defect, sir?
Yes, that is, of course, we have to make out the margins, a little bit of freshening of the margins on both the sides.
Yes.
And then seal it with, and then reinforce with whatever material is available, like muscle is there. Temporalis, muscle is there. With this bone patty also is being used.
Okay.
And nowadays, people, if they can afford, tissue glue is also
Tissue glue
available.
over. You like to apply.
So tissue glue also can be used. So this is something like we can think it as a parallel to the jugular. This thing.
Okay. Dr. Umagar, ma'am, anything you want to add?
If you, okay, sir.
Ma'am, please.
If you happen to expose dura during mastoidectomy, it's just a small, very small dent, less than 5 millimeters or so, you just put a pack for some time and do the rest of the surgery.
Okay.
And for very small dents, I have an opinion that we don't have to do anything.
No, ma'am, if CSF
If it
leak
is very, no, if CSF is not there.
Okay.
If
CSF is
CSF is leaking, then you have to, of course, repair it.
Here it is the bleeding which also, spurting of the bleed.
But if you pack it for some time, bleeding stops, and then you can leave it like that without CSF.
I think, Nikhil, it will depend on the size of the breach.
Yes, yes.
Right.
Whether you have to replace it
Replace
with
it.
some cartilage, muscle, or fascia. Or
If
not.
it is small, then you can leave it.
It is for the younger people. I just want to add one thing. If the dura is exposed, take it as a landmark.
Yeah.
Don't panic at all.
Okay.
And if it is less than 1 centimeter, doesn't say anything. Don't have to do anything.
Right.
If there is CSF leak, obviously you have to repair it, but otherwise just leave it as such.
Okay. So, Ashima, anything you want to add? Or?
Yes, only one thing, sir, that if there is a CSF leak which you have repaired, make sure to put the patient on an anti-meningitic dose of antibiotics IV for the next 3 to 5
Post-operative
days.
management. So what we have been following, if the dura is exposed, like sir said, we usually cover it with fascia if there is no CSF leak, so that there is no chance of any ascending infection if the mastoid cavity gets infected. Yes, sir. If you just 1 minute. Yes, sir. Yes. Yes, sir. Yeah, soft tissue. Cartilage. Okay.
If it is 2 centimeter or more,
Right.
then I prefer a middle fossa technique.
Okay.
Insert the
Cartilage.
and do it.
So multi-layer closure you like to do that, right? I think we are running short of time. You can discuss the query later. Okay. 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 No, please give her a mic. Give her a mic. Yes. Okay. Right.
Big one, then only.
So I think if you, yeah, yes, yes.
But what I want to emphasize more here is this one. By doing a plasmoid surgery, the chances of taking into a CSF leak are almost zero. So when your resident starts opening the plasmoid with a 3 number or a 4 number, if you take all the residents start a plasmoid
Larger size, bro.
you will never have a CSF.
So one thing, like you said, if you use a cartilage and if you put it like an underlay in the defect, na?
It's a bipolar. Dr. GB Singh, bipolar cautery, not unipolar.
Okay.
If it is already producing, then it is a non-functional.
No, sir. She's asking about intraoperative.
It is the whole brain which is What she was talking about was okay. I think we'll carry on.
So I have to move ahead. Right. Okay. So just last
I
slide.
think that the safest option is to get inside the middle cranial fossa and fix the cartilage. You will be safe.
Right. So this is the last slide. Recent carotid artery when we are doing any mastoid surgery, or aberrant carotid artery if it is not following the normal. Any of the panelists have any experience, any dissection of this great vessel during?
Let's not wish to have any
Not wish to.
such kind of experience.
In one of the cases, it happened with
Yes,
us
sir.
during my tenure.
Yes, sir.
And probably, I don't remember who was the surgeon,
Right.
but we had to pack and refer the case to Pant Hospital.
So I know about this case. I think Dr. Raman sir was operating, and
We had
this
one case.
this patient.
We had one carotid artery aberrant.
No, sir. This is before. So sir had sent to Pant, and the coiling was done. That paper is also published in American Journal, and patient whole disease was removed. Patient is fine also. There was an internal carotid bleed sir had. I also had a case which Dr. Bhargav sir is talking about. I was doing this mastoid surgery, and whole of the cochlea and promontory was gone, was eroded. So revision mastoid extensive, and I had this structure which was looking like carotid, like this, going not in the usual direction, and extensive cholesteatoma over it. One thing of the carotid I want to say is that it will not pulsate in the ear. So don't wait that it will be pulsating and you'll identify it. And again, as I said, we wish we don't encounter it more.
And if you do have bleed, please use muscle.
Muscle over it, right?
Please use muscle patches to
Yeah.
fill the gap. Keep it and then send to interventional radiologist.
Right.
Why immediately?
So this is what I did it. I took a lot of time. I used gel foam cotton pledgets. Yeah. I removed it, cholesteatoma. No problems.
The best thing is to do a canal down in such scenario and keep it open.
Yes, so the posterior canal wall was eroded already, and we just placed a small graft where we were completely sure. And
as possible as if you can remove, but it is always better to leave it, because we'll rather like to have cholesteatoma in my ear rather than having a ruptured carotid. So there is no doubt about it.
It is always better to underdo it than overdoing it.
Yes, that is the word.
Thank you for the discussion.
Very nicely moderated, Dr. Nikhil.
Thank you, sir.
And somebody's loss is somebody's gain. So MAMC has gained from PGIMS Rohtak. Henceforth, Dr. Nikhil has gone to assistant prof in MAMC. So my loss is their gain. But anyway, this happens in life.
I accept it.
Thank you so much, everyone. Now, I would like to request our panelists to kindly felicitate our moderator, Dr. Nikhil sir, with a memento, please. Thank you, everyone. Now, I request Dr. Nikhil Arora sir to kindly present a memento to Dr. Uma Garg and Dr. Manvi Mehta, please.
Now, I would like to invite our next speaker for today, Dr. Surinder Kumar Singhal, who will be talking about endoscopic management of nose and PNS tumors. Sir, kindly come on the stage. The chairperson for this session will be Dr. Uday Monga, Dr. S.K. Anand, Dr. Raghubir Sharma, Dr. Krishan Kumar, and Dr. Ravi Bhatia, sir. I would like to request Dr. Pavan Singhal sir also to kindly come on the dais, please, as the chairperson.
सर छोटी सी टॉक, टाइम ज्यादा ले सकता हूँ, टाइम छोटी वो काम कर रहा है ना, माइक कर रहा है काम, मेरा बंद ही कर दिया सर। हाँ Hello, good afternoon. At the very outset, I will thank the organizers for giving me this opportunity to speak in front of this august gathering for my experience in handling the tumors of nose and paranasal sinuses endoscopically. You know, endoscopes were introduced in sinus surgery in Germany in late 1970s. They were primarily for the treatment of sinonasal inflammatory disorders. And over the time, endoscopic sinus surgery has overtaken all the open techniques, and it has been replaced by endoscopic sinus surgery technique for inflammatory disorders. The advantages are, with the powered instruments, image guidance system, and hemostatic agents, biological materials available, it has led to decreased morbidity, decreased hospital stay, and early discharge from the hospitals. If you go into the background, the traditional approaches required large external incisions, osteotomies, craniotomies, and craniectomies, and which led to functional and cosmetic deficits secondary to injury to the neurovascular structures. And it often required local and distant flap for reconstruction, and endoscopic sinus surgery is an attempt to minimize this morbidity. The disadvantages of open procedures are there is a lot of postoperative morbidity, numbness of upper lip, hypoesthesia of cheek, functional disturbances, epiphora, sometimes blindness, and increased hospital stay. So why endoscopic resection? There are critics of endoscopic resection which say you cannot remove the tumor and complete tumor removal in en bloc. But practically, whenever you are doing an open approach also, you are not able to remove the tumor completely. On the other hand, the endoscopes provide you better illumination, better view with straight and angled endoscopes. You can see the corners and nooks and clear the tumor or the inflammatory disease from all where. Because of the better instrumentation, saver and intranasal drill, It can help you clear the disease better. Better hemostasis with a bipolar cautery and other materials available like tissue glue and flow seal. And this all has led to the decreased recurrence rate in long term. However, the basic principles of oncologic surgery must be followed. We should determine the resectability and operability. We should determine the curability of the lesion with the approach being used, and whether the procedure will improve the patient's symptoms or quality of life, and consider whether the reconstruction and or the preservation of function and cosmesis are feasible with the approach used. The surgical goals for this are exposure. It should be complete exposure so that you don't leave any tumor behind. You should have the complete extirpation of the tumor. You should try to preserve all the neurovascular structures. And if reconstruction of the skull base defect is required, it should be done at the same time. And you should also consider cosmetic rehabilitation, patient's function and quality of life. So preoperative evaluation, history is very important. And all the patients with the nasal tumors may present with non-specific symptoms except for 1 or 2. They may present with nasal obstruction, altered smell, nasal congestion, discharge, frequent bloody nose, headache and or facial pain. Then on examination, you may find nasal discharge which may be blood stained. There may be nasal mass which may be firm to feel, may bleed on touch. There will be loosening or numbness of the teeth, hypoesthesia of the cheek or face, problems with your sense of smell, a lump of mass of the face or palate, bulging of one eye or the other, loss of or change in vision, trismus or lymph node enlargement. These are the symptoms which the patient may present with. Then you have to do a diagnostic nasal endoscopy, which might tell you about the extent of the lesion plus the attachment of the tumor, where it is attached, maybe to the skull base, lateral wall or towards the septum. Then you do preoperative imaging that may range from the plain CT scan, contrast CT scan, magnetic resonance imaging that will delineate the soft tissues better. Then depending upon the vascularity, if you suspect a vascular tumor, you may require a CT angiography or an MR angiography. And in selected cases, you might consider embolization of the tumor, especially in nasopharyngeal angiofibroma. And ultimately diagnosis by biopsy. If you think the diagnostic dilemma because of radiology or diagnostic nasal endoscopy, you must do a biopsy first to confirm what you are dealing with, so that you can plan your excision and reconstruction better. A word about CT and MRI. In tumors, you must do CT and MRI both, because you can see the difference. On one side, you can see the maxillary sinus is filled with the soft tissue density. But when you do MRI, it's clear. It's a fluid only because of the obstruction of the ostium. So the tumor is limited to the nasal cavity only, not in the maxillary sinus. So MRI is helpful in such cases. So we have a record of patients from 1999 to 2012. And the location of tumor dictated the surgical approach. And in all the patients, we use endoscopic approach. In 1 or 2 cases, we have assisted endoscopic approach also. So there were around 340 cases. Most of them were inverted papilloma, angiofibroma, esthesioneuroblastoma, and pituitary tumors. We are doing a lot of pituitary with neurosurgeons, so that forms the majority of the lesions. Inverted papilloma is the commonest benign tumor involving nose and sinuses, constitutes 0.5 to 4% of all tumors. Although benign, the inverted papilloma is characterized by an aggressive growth, great invasive potential, multicentricity, and high recurrence rates. There can be a malignant change in 5 to 15% of the cases. So this was the case. Preoperative imaging you can see, and endoscopic medial maxillectomy was done with the cautery, incision given at the level of the piriform aperture, bone exposed laterally and medially. And with the chisel, medial wall of the maxilla was removed. And because of the paucity of the time, can I fast forward it, or you want to see it? Chairman, sir. Okay. So removal of the soft tissues. Then you can see the maxillary antrum is exposed, choana is exposed. We are at the posterior wall of the maxilla. cauterizing the blood vessels here. Then you can see we are stripping the mucosa of the lateral wall of the maxillary antrum. Then hemostasis is achieved with the cautery, unipolar cautery, section cautery, and then we do the packing. You can see the postoperative CT scan, the tumor, the preoperative on the above, and below is the postoperative CT scans. Then we have the check endoscopy. This is the healed cavity you can see. No evidence of any tumor. You can see the maxillary antrum, although it is slightly decreased in size because of the fibrosis. Then in follow-up, we have these at 6 months, and then we have it 48 months. Another case, it was arising from the septum. This is the postoperative CT scan. This is the postoperative endoscopy. 9 months postoperative. Well healed cavity. Another patient, 6-month follow-up. This was another case with a large inverted papilloma. It was involving even the frontal sinus. Intraoperatively, after tumor removal, the transillumination, you can see both the frontal sinuses are clear now. And this is a postoperative CT scan. Histopathology is typical. The Schneiderian membrane is inverted into the underlying stroma. Then we had a case of mucoepidermoid carcinoma. It was involving the nasal cavity and touching the floor of the nasal cavity. There was slight erosion of the bone. Although the mucoperiosteum was intact of the palate, we removed it endoscopically. So this is arising from the floor of the nose, pushing the inferior teeth turbinate up. You can see. And this is the postoperative video. This is the postoperative video of the same patient. These are the postoperative radiographic pictures of the patient. Angiofibroma, everybody knows it's a vascular tumor, and good clinical history and examination can make the diagnosis, and you do the radiology to define the extent and vascularity, and you might need embolization of certain patients. So we started with small tumor to begin with. It's localized to the nasal cavity, preoperative endoscopy. You can see the tumor localized to the posterior part of the nasal cavity. This is the opposite side, and the tumor is there in the nasopharynx. This is the operative procedure. This is the area of the sphenopalatine foramen being exposed. So we are mobilizing the tumor from the sphenoid sinus. This is the tumor, you can see. So these are the postoperative picture of the patients. Another patient, large tumor in the nasopharynx and nasal cavity. This is the resected tumor, and this is the first post-op day picture of the patient lying in the bed and walking in the corridor of the ward. You can see how much morbidity it decreased because of the endoscopy resection. If it was with an open approach, patient must be lying in the bed with a large pack in the nose, and he must be having so many problems. So that is the advantage of endoscopic resections. This is the post-operative picture. Then this was the stage 4, going to intracranial extension. We gave stilbestrol to this patient for fibrosis of the patient, and later on, patient did not turn for follow-up. We wanted to operate the patient. Hemangiomas are common in head and neck. They can occur in the nasal cavity also. They may present with profuse epistaxis, and the treatment is very easy. If you localize it, just cauterize it or resect it with a tissue margin. It was situated on the inferior terminate. Sorry, the video is not working, I think. Then there can be septal hemangioma situated in the anterior part of the nose. Again, will present with epistaxis and can be excised very easily under local anesthesia. Cavernous capillary hemangioma of the maxillary sinus. We have reported this case. It was published also. Typical histopathological appearance. Vascular spaces filled with hemosiderin material. Then we had esthesioneuroblastoma. Again, as I said, and earlier MRI was telling us that there was no tumor in the maxillary sinus. It was localized to the nasal cavity only. This tumor was excised endoscopically, and the cribriform plate area was laserized with carbon dioxide to remove the microscopic residual of the tumor. You can see the cavity. Nine-month post-operatively patient. What happened? This is the CT appearance. 9-month post-op. Sorry, this is another case, I think. I'll show you the other one. This is the post-op picture of the previous one, where we'll use the laser one 2 years later. Again, sorry, the video is not there. So this was the extensive tumor where intracranial extension was there. We subjected the patient to chemo-RT, cisplatin, etoposide, and radiotherapy was given. 6 cycles were given. And this was 4 months later after radiotherapy. And patient was on follow-up till 2 years. After that, patient was allowed to follow. Then osteoma are usually incidental findings on sinus X-ray, but when they produce symptoms, they need treatment. They are slow growing. They may cause frontal pain, headache, and CT can diagnose them easily. You can see the osteoma lying in the frontoethmoid region. This case, the osteoma was extending laterally, so we used an assisted approach with endoscope. So again, uncinectomy was done. Tumor was exposed, drilling was done. And when we reached the lateral limit, we switched on to the endoscopic assisted approach from outside in. So this is the tumor mobilized from laterally from outside, and we can remove the tumor from inside now. I'll show you that by coronal approach. So small tumor still left, and it was removed. Sorry. Another case, we did a partial excision. It was a large tumor pressing upon the optic nerve of the patient. Patient did not agree for loss of vision or decreased vision. So we did a partial resection, removed the nasal symptom only. This was the partial resection post-operative picture. Then we had a patient of osteosarcoma also. It was localized to the nasal cavity. This was the post-operative picture. Another one. This was an interesting case presented with change in voice and respiratory obstruction. There was a mass over the upper surface of the palate, nasopharyngeal surface, which is very well visible in sagittal and corneal sections. So it was excised with endoscope. This was the endoscopy examination. You can see it is attached to the upper surface of the palate. This is the attachment. So this is the post-operative endoscopic picture with the 70-degree. You can see the area from where it was excised. It is the blackish area cauterized with bipolar cautery, and bleeding was stopped. Then fibrosous tumors are also in our kitty, and we had a cementosifying fibroma which was excised endoscopically. Sorry, just I'm quicking. Yeah, this video is not working, I think. Okay, no problem. So this is the post-operative picture of the cementosifying fibroma. This was a pleomorphic adenoma of the salivary glands arising from the septum, and after excision you can see the picture of the patient. Mucoceles, you can see preoperative scan, and then after operation you can see the illumination in the sinuses. Mucopyocele, you can see another one. This is the endoscopic drainage of the mucocele. You can see the pus coming. You can see in the frontal sinus also, it was extending another pocket. You can see the pulsation of the dura. Pulsation of the dura can be seen here. Then another case of mucocele, plasmacytoma. This is a preoperative CT scan. This is the postoperative endoscopy. And this is the postoperative radiology. Then we had giant cell granuloma also. We had a patient of 3 days having nasal glioma on the nasal cavity. We excised it and it was published also. Nasal glioma in a neonate. Then we had a schwannoma, large tumor. The postoperative pictures can be seen lower down. Then this was a frontoethmoidal meningoencephalocele which was excised. I think if somebody has attended the rhinocone, they might remember this. So this video was awarded. So this is the defect in the posterior wall of frontal sinus was repaired after excision of the meningocele. This is the postoperative picture. This is the pituitary adenoma. We had operated around 190 cases. Just 2 minutes more. Sorry. So this is the exposure of the tumor, exposure of the dura, curate removal of the tumor, and then with the graft sealing it with the tissue glue. another pituitary adenoma. So we had our share of major complication and minor complication. In one case, we had a bleed from the carotid artery. This was a case of meningioma recurrent, which was operated thrice at some other center, and fourth time we were operating. We were just using coagulation. We were in the midline, but suddenly gush of blood came and we had a carotid bleed, and we managed it same day with the coiling. Although patient has some hemiplegia for some time, but later on it improved. When the voice and the hemiplegia improved. Thank you very much. Sorry for the time taken. It was a long one. Sorry. Any questions? Welcome, please. Which mask?
The soft pellet mask.
Soft pellet leiomyoma. That was a leiomyoma. Yeah. I think that is published in the Egyptian Journal of Otolaryngology. Should I remove it now?
Thank you so much, sir, for sharing your knowledge and wisdom with all of us. Now, I request our chairpersons to kindly present a memento to our speaker, Dr. Surinder Kumar Singhal, sir. Now, I request Dr. Singhal to kindly present a memento to Dr. S.K. Anand. Moving on to our next panel discussion. Next, we have on the topic FES and its complications, which will be moderated by Dr. Rijunita ma'am. I request her to kindly come on the dais. I would like to invite the panelists for this session on stage. Dr. Surinder Kumar Singhal, sir, Dr. Chandni Sharma ma'am, Dr. Sarika Verma, Dr. Pavan Singhal, Dr. Nitin Gupta, sir. Kindly come on the stage.
So, good afternoon all. I think we are already running with the behind time. So we'll be starting with the FES and its complications. I have been given the opportunity to moderate this panel, and so I invite all my panelists. These were the panelists earlier, but I think Dr. Sarika Verma, Dr. Surinder Singhal, Dr. Chandni, and Dr. Nitin is with us. And I invite Dr. Pavan Singhal also. He was here only. If somebody can call him. Okay. So not to waste time, I'll start with the objective. What is our objective of functional endoscopic sinus surgery, even for the primary as well as the revision case? So purpose of FES is to provide a wide and patent sinonasal communication. So we'll be discussing mainly for the rhinosinusitis part with polyps and nasal polyposis. And the other thing is to prevent recurrent obstructions, then to create such conditions which are conducive to reepithelialization. So my question to the panel is, that what is the rate or incidence of complications in FES in primary as well as secondary? So what is the rate? It is whether it is high, it is low, especially in rhinosinusitis, I'm asking, with nasal polyposis or without nasal polyposis. So you can tell that it is high or it is low. How you have done so many FES. So what do you think? That it is high in maybe when we call that it has been done by the experienced surgeon, skillful surgeon. Yes, Dr. Sarika.
So I think FES is a very interesting surgery. The rate of complications is directly inversely proportional to the experience of the surgeon.
Yeah, definitely.
The complexity of the polyps and the anatomy. So it's very difficult to pinpoint. And the best of surgeons can have very rare, unusual complications.
Yes, very right.
And the newbie who's very, very careful usually cannot have. So I mean, it's very difficult to point out whether it's major or minor. But yes, the more experienced you become, and the more careful you are, the more well you study the anatomy, things get better. So it varies from case to case. I don't think you can put a tag on it as to how many complications one can have.
So Dr. Surinder, you have some say on this?
I think complications are part of surgeons' operations. They are going to happen, but you should know how to manage it. Plus, you should be able to get it whether this patient may land up in some complication or not. For that, pre-operative assessment is very important in the form of CT scan. You should read your CT scan thoroughly. Focus on the areas where the complication can occur.
Yeah, we will be coming with that later on, Dr. Pawan. And what is the percentage of single surgery? If you will do single surgery, then what is the percentage of complications? And if we do revision surgeries, like in patients, we are doing one surgery.
Yes.
So what is the incidence of that?
So, if you talk about the minor complications, they are common. They are still
Yes,
common.
very right. So we have
If you
more
talk
minor
about-
complications
yes.
than the major ones.
If you talk about major complications, yes, in difficult anatomy, in revision surgeries,
Right.
you do have major complications. And if it is an amateur surgeon,
Yeah, I'll be coming after
Yeah,
for that
this
the
is-
factors.
yeah.
Yeah. So what is the percentage of single surgery?
percentage of single surgery
Is in
is-
skillful hands.
in is-
If you do
is
just one
low.
surgery and the patient is fine,
I
then
would
you
say
can
1
manage
in 100.
medicinally.
I would say 1 in 100.
Yes, very right.
But if it is a revision surgery, it may reach to 5 to 8 or 10 somewhere.
So,
Add one thing. I
yeah,
think
Dr.
the
Nitin.
complication in if we talk about synechial formation, it is slightly, I think, more synechial formation because it
Yes.
happens because
So
the raw
that
area
comes
is
as a
bigger.
minor complication. Yes. So rate of complication is associated with endoscopic sinus surgery is not much in skillful hands. It's not much. So with the increase of surgeon experience, the minor is only is 5% that we most of the time encounter, and major is very rare, around 1% only. And 80% of the time we do single surgery in the patients, and rest of the cases we do revision, only in 20%, that's it. So to achieve more appropriate goals. Now, what are the various stable intranasal landmarks in primary as well as revision FES? So what do you think when we are going ahead with the primary surgery? So what the surgeon should take into account? What are the good structures? For me, maybe I say that yes, all
Yes,
uncinate process, bulla, yeah. What are most important which we should keep?
I think most important landmark is middle terminate attachment.
Yes.
Axilla of the middle terminate should be there.
Yes.
That will define your all the landmarks, and you will be able to prevent so many complications.
Yes.
Perhaps especially in revision surgeries, most if the terminate has been already resected, so it's very difficult to decide where is the skull base level.
Yes.
And lamina papyracea also.
Dr. Pawan.
So middle terminate.
But if it is a revision surgery and there is no middle terminate, coina makes you the
Yes,
most
the most
consistent
persistent
landmark.
landmark is
The coina.
coina.
And you
Yes.
draw a line along the coina, you will be getting into maxillary sinus.
Yes.
You go 1 centimeter up there, along the septum, you'll get a sphenoid ostia. So coina makes.
Very right. So mainly in revision cases, so posterior coina is the most persistent landmarks. Although I must say all are there, middle turbinate. When there is a primary surgery, you are doing rhinosinusitis, you go for to look up at uncinate process. Then maxillary sinus os, you can see bulla ethmoidalis. Sphenoid os is important when you look for the superior turbinate. Endoscopic picture, medial to superior turbinate is always sphenoid os, and lateral to that is always posterior ethmoid sinus. So remember that when you are going for the skull-based surgeries or polyps coming out of the sphenoid sinus and all. And the posterior choana, of course, is the persistent. So this is a video showing the patient in which 2 surgeries already been done. Even if I say recurrence is a complication, do you agree with that? Even
No.
if we need to do the patient residual disease or the recurrence, is it a complication?
If you talk about polyposis, it is a must thing which will happen in the lifetime of the patient, maybe a minor residual or a recurrent disease, or maybe major.
Yeah.
So that's why it is becoming more of a medical disease rather than a surgical disease.
Yes. So it's
Sinus is a polyposis.
Yeah. But
Just
if you
add
can
something to
Yeah,
that.
yeah.
So when we were doing our graduation, they used to say the treatment for nasal polyps is endoscopic sinus surgery. But I think the last 22 years, things have changed a lot. And now we always tell the patient, we are doing the surgery only to open up the airway, and you will need intranasal corticosteroids.
Bhushan.
And if you have an allergy, you need to treat the baseline allergy so that the polyps don't come back. So recurrence is to be expected unless
Yes.
you otherwise look after the patient very well.
Yeah, so we do FES in those patients who are not responding medicinally. So just to open the os so that they can combine with the nasal cavity so that they should drain. So that is the important. Here comes the role of surgery. So it's a combined treatment. So this is a video I am showing. You can see the revision case as a severe polyposis, and everything is attached laterally, middle turbinate. I'm trying to dissect it out so that I can separate the middle turbinate with the lateral nasal wall. Okay, so a few things are that you can see I'm removing the polypodal part of the middle turbinate to skeletonize it. How much it is possible, you should preserve the middle turbinate, skeletonize it, but you should preserve. Otherwise, if you cut it, then again, there is polyposis of this and can trouble. Medially inferior region, you should open it, try to. Then I'm opening the bulla, uncapping of the bulla. So you should not go straight away towards the lateral side. There can be injury to the orbit. So stepwise, you can do the surgery. So that you can see some part of the uncinate process left superiorly. So that is important to take out. Otherwise, you will not be able to enter the frontal sinus. Now this is on the other side, left side frontal sinus, which was totally blocked. So we tried with the cell seeker and entering into the frontal sinus. So your instruments will reach like giraffe forceps, all those instruments, anterior posterior cut and sideways cut. You can see I'm using those. If you are not using those instruments, that means you are not in the frontal sinus. Very rightly, correctly, I'm saying this, that you are not in the frontal sinus. If you are using with the normal instruments. So widening it, suctioning, and you can see them. I'm using the anterior-posterior giraffe to make the os widened. And as soon as you make it widened, and it's good that if you have frontal glow always visible, this is left side, you can see the left side frontal glow visible nicely. So you are clear with that. The frontal sinuses clear with the disease. And I'm using this is a very good instrument, the mushroom punch, which is a favorite of Professor Stemberger also. This is on the other side. So use Merocell packs very often to decongest the area so that you can enter. So right side frontal sinus, you can see the glow on the right side too. And and this is the whole cavity, maxillary sinus. This is sphenoid. So if you open up wide cavity, so then afterwards, if patient has problems, so that that can be taken care of with the medicine, with the medical pharmacotherapy.
So what in the frontal exploration you have showed, it is a nice way to do that. But I think one thing which should be done always is to explore the agar-nejai cells first.
Yes.
If you remove the agar-nejai cells, you remove the lamella, you will be in frontal sinus.
Before
for
that,
sure.
if you can say something.
Yes.
You can see the first attachment of the middle
Yes.
turbinate. So axilla. So
Axilla. So
once you remove the superior
Whether
part.
you want to raise an axillary flap like
Yes.
PJ wormhole does,
Yes, PJ
or you
wormhole.
can use your carisons to take a bite
Right.
at the axilla so that your agar-nejai exposes there. You
Very
remove these
important.
lamella, and then you will see the frontal isthmus down there.
Yes.
Open it. Yes.
Yes, Dr. Surendra.
She wanted to make a comment.
Yes. Yeah. Yeah. That's fine. Yeah. Somebody can take up this question.
I think you start with the horizontal process first, take a backbiter, okay, cut it. And when you reach the hardest bone, stop there. And after that, you use a ball probe and try to fracture the vertical portion, out fracture the vertical portion. And when the bone is out, you can just use the debrider blade to remove that mucosa. You will be removing it totally. So that then it will not be a risk. When you have out fractured the vertical portion and removed it with the forceps, only mucosa is there, just gently go there and you can remove it.
Yes, Dr. Pawan.
Mans.
Yeah. So I think in this scenario, it is very important question. When it is very much lateralized, you don't have any groove to open the uncinectomy anteriorly with the freers or maybe the sickle knife if you want to use. I think Kunz backbiting, a flat leaf backbiting forceps, which has got a flat moving part, should be used first. Or before that, what you could do is you can use an angled ball probe. You insert this ball probe between the bulla ethmoidalis and the uncinate, move it upside down and move it a bit medially and anteriorly. You will develop some space to insert your Kunz backbiting. Take a few bites until you reach to the hard bone, as sir said. Then what you could use it, again the ball probe, medialize the lower half of the uncinate and then take the bites and use a curved suction, insert inside and use it to push the rest of the uncinate down there and you will be there inside.
Yes, very right, very right.
See,
And one more thing to add.
The most important thing is you don't take an anterior to posterior approach for uncinectomy here. Then you will end up in orbit. You have to come posterior to anterior as with the backbiter, as Dr. Pawan also explained.
Yeah, very rightly said, Dr. Surinder. If you are not able to see the structure anteriorly, then start coming posterior to anterior. And one more thing I wanted to add in that you look for the anterior end of the inferior turbinate. So as you are following that and just enter into you can see the part of the uncinate, just enter there with the ball probe, very correctly said. Or sometimes we use the ring curate too, that angled antrum curate, antral curate. So that is also to localize when you are following the anterior end of the inferior turbinate. So then you can look for that it is there, but accidentally you should not go higher up, right? So then only, this backbiting, right side or left side. And more common is which side, Dr. Surinder? Right side or left side? Have you encountered or seen that
The
right?
experience had, it should not be the problem with the hand.
If we have good landmarks, we have good anatomy, there should not be any problem with the left hand side and right side. But many people say right hand sided. Yeah, it is more common. Yes.
Yes, before
So-
she asked the question, I wanted to make a comment
Yes.
regarding the middle turbinate. You said it should never be removed. No, anterior part should never be removed. Posterior two-third or one-third can be removed so that your drug delivery can be better in post-operative period.
Yes. So as much as possible, you should skeletonize it. Try not to remove it. Not to remove it. Because whenever the polyps arise, in allergic nasal polyposis cases, that cases all polyps again come up with the cut end. So that block the ostia. So it is always preferred not to remove, only remove,
But,
skeletonize it.
I differ there. If it is a polypoidal middle turbinate, it will always pose a problem. It will cause obstruction of maxillary sinus again and again.
That is why
And
I'm
it
saying.
will have contact points with the septum, with the ethmoids, with the maxillary
Okay.
sinus. You can do a partial middle turbinectomy. You should never ever remove the horizontal attachment of the middle turbinate, because that makes it a stable unit. So that should never ever be touched. But inferior part, you can cut anytime. You can cut. Always leave the vertical attachment to the skull base
anterior
intact.
vertical attachment.
Always leave the horizontal attachment intact, and that is in my
Right,
books.
Right. So we take up another question. What are various minor as well as major complications which can occur during primary phase and revision surgeries? Any classification related to that? And what are the techniques in primary as well as the revision surgeries? In primary, which technique you will go for? In revision cases, which technique you will go for? Dr. Nitin?
So there are there is basically classification which divides into two parts. It is the minor complications and the major complications. The minor complications include such as minor bleeding, dental pain, headache, and periorbital emphysema, while the major complications include obviously severe anosmia, severe epistaxis, and then intracranial complications, intraocular complications leading to diplopia or blindness, and catastrophic injuries such as carotid injuries. These are all the major complications of the face.
Yes. So we
CSF leak.
Yes, CSF leak. So we categorize in minor and major. So in 4 categories, mainly orbital infections, then intracranial complications, then hemorrhage and other traumas, synechia. So minor are more, major are less, but if they are there, then it is very troublesome.
So I think it was a modified Lund-Mackey's classification now. It was given by Fokens and Lund's. It has been further modified there.
2007.
Yes. Now it has been further modified by Lund-Mackey's classification there.
Yeah.
But the important thing, I think your last question was, how do you go ahead? So in revision cases, if you don't see anything, please come from posterior to anterior.
Yeah.
That is Wiegand's technique.
Very correct for the beginners.
For the beginners, come from posterior to anterior.
Yes.
And the most important thing to avoid any complication in such scenario is your tip of the instrument should always be visible to you. And the angulation of instruments should never go towards the skull base like this, should never go laterally towards orbit. From the side of the instrument, you should be cutting.
And for the primary?
Yes.
If it is simple rhinosinusitis or
For the
small
primary
polyps.
also, the same principles are there. You should appreciate the landmarks, use your instruments with precision. You should be more medial and inferior when you are operating. If you are an amateur surgeon, you are a beginner, start operating from medial and inferior side on the polyps, then come step by step towards lateral and up there.
Yeah.
Because your skull base is receding down there posteriorly and your orbit is going medially in the posterior part.
Yes.
So this is how you can approach.
Yeah. So anterior to posterior, this is Messer-Klinger technique. Everybody will agree to that. And for the revision cases, I think it's Weigand's.
I just want
Dr.
to
Sarika.
add the essence of FES is always vision. You have to keep all your landmarks in place whenever and be oriented. So because when you go right inside, you forget where you are. So always step back, look at the septum,
Yes,
look at your
orient
uncinate,
yourself.
look at your turbinate. When every few minutes, whenever you are defogging, always keep a look at the orientation where exactly you are, and then your rate of complication will be much less. Like Dr. Pawan said, keep the tip of the instruments always in vision.
Yes.
The vision and feel are the two things that will stop you from making any major complications.
Yes.
I think in primary surgery, anterior approach is good enough.
Yes.
When there are good landmarks available. But
landmarks
in
available.
revision cases, you can combine both the anterior part you can do with
Yeah,
anterior
as well
approach.
as-
When you want to work posterior ethmoids or sphenoid, then identify the coina, sphenoid ostium, and then you can clear the areas.
Yeah.
You know, one more mistake I have seen people, even on surgical demonstrations, I've seen the upside image sometimes tilts. Your image on the monitor should be upside down. The floor of the nose should be at 6 o'clock always. I have seen surgeons operating and the septum is coming at 4 o'clock or 5 o'clock.
Very rightly said. So you have
And
to
they are
orient.
just operating because they know we are operating. But this will make this will create complications. So your orientation during surgery should be upside down.
Yes, very correctly said. You go with the tip of the endoscope inside. You know, it's a big cavity. So if you have a good monitor, have good zoom, and you can enter as if you are entering into the nasal cavity. You know, that should be the.
And especially
criteria.
with working with the angled endoscopes like 70-degree or not, then this problem can occur
Yeah,
more.
this can happen.
Yeah,
more.
she wants to make a.
So this was a.
She wants to ask.
Yes, yes. Yeah, definitely.
Yeah, please feel free.
So for that we are coming. What are the factors by which? Yeah, that we will come afterwards. We will answer your question. So this was the classification. Now everybody must have seen minor, major comes in grade B, grade C, when the disastrous complication which can cause death. So what are the risk factors, situations which can lead to more chances of complications? So here comes your answer, I think. So more chances of complications. So what are various factors, risk factors?
Extensive disease.
Few you have enumerated.
Extensive disease.
Yes.
Revision cases, when the bleeding is more, patient is hypertensive, patient on ecosprin or anticoagulant, antiplatelet drugs. So these are the factors which can lead to more complications.
Yeah. Anything else, Dr. Nitin?
Anatomy is obviously very important.
Yes.
Sometimes we have
Abnormal anatomy.
abnormal anatomy. That is very important to understand before going to the surgery.
Dr. Chandani will speak something on this. Yes.
So at that time, we don't have to use patients. We have to pad, then spray that the bleeding stops, instruct the anesthetist to get us the DP to an appropriate level.
Yes.
And just operate when you are able to see. Don't go in blind. Even if it's bleeding and the surgeon keeps on doing that, I have to repeat the surgery.
Dr. Pawan.
That leads to.
Yes.
I think for me, the most important thing is unprepared patient.
Yes. Very right.
An acute case or an unprepared patient you take for surgery. So this is a guideline for me to prepare for the
Prepare your
for at
patient
least
for the surgery.
2 weeks
Yeah.
with the steroids.
So what is your
nasal
criteria,
washes.
Dr. Pawan,
My
to prepare the
guidelines,
patient?
It is antibiotics and steroids on a tapering doses for 2 weeks and nasal douching if it is possible. If it is diffuse polyps, I'll advise a steroid nasal spray.
Oral
and
steroids or
test-
local sprays?
Oral steroids also.
Yes.
Before taking the patient for
Yes, very
surgery,
rightly.
especially
Oral
polyposis.
steroids.
So if you prepare it well, I'm telling you, your half of the complications are reduced.
More than half of the complications are done because there will not be any bleeding, there will not be any congestion, and you will be able to see your landmarks very nicely. So your mucosa, nasal mucosa is well prepared.
I think I agree with Dr. Pawan. Oral steroids and antibiotics for 2 weeks is a good thing, and it definitely
You can say
solves your problem.
peri-operative.
It will
Yes.
ease your operation. Plus, I don't give topical steroids because when oral steroids are already there, they are going into systemic circulation. There is no role of topical steroids. So I will,
Yeah, shrinkage
Patient
local.
has diabetes, would you still give 2 weeks of
still we
Yes,
give, they monitor the
diabetes.
blood glucose.
Yes. So.
Makes the life so easy when you operate.
Yeah, definitely. So everybody should, this is a consensus that everybody should prepare the patient. Without preparing the patient, the time is consumed, you will consume more time, delaying in surgery. You will get frustrated many times, and that again lead to complications.
And even your EPOS, the European position paper on chronic rhinosinusitis, it goes in favor of preparing the patient for at least 2 weeks with oral steroids, antibiotics and all.
Yes. So one more thing is left. What about surgeon? Patient factors are there. What about surgeon factors? So
Factors, of course,
the
very
absence
important.
of a sufficiently experienced surgeon.
So, I
And
mean,
what
in
about
our-
in the institute? What is there in the private?
I'm telling you, one word is there.
Dr. Sarika?
In our medical college, until we had done 100 diagnostic nasal endoscopies, we were not allowed to do a FES.
Very
So, I mean, that's the basic concept, and everyone has to follow it. If you are inexperienced, you will end up with complications. It has to be guided, and it has to be supervised surgery at least for the first 20 times. You should not do it anything unsupervised.
Dr. Surinder?
I think
What about a skilled surgeon? When you will allow your resident to operate without even, supervision.
I will not.
In FES.
I will not.
I
At
can
least
say in
I'm-
head and neck oncology, wide open areas, but whether in FES, I have not allowed my
I
resident to
will not,
operate.
and I am famous in my medical college. I don't allow these things.
What about Chandni? What
Maybe
about
smaller lesions
Dr.
such as a
Nitin?
small septal hemangioma or a enteroconal polyp maybe.
Then
we
it's okay.
Yeah.
But he has to show you the cavity
Not a
also.
full-fledged polyposis. Not.
Yeah, they can create what they can create. They can do more harm to the patient rather than you know taking out the disease. So
there are-
harm.
One thing which we gained with Neether was like our residents got such a extensive
Experience and
Experience that led to.
that was misleading also because those patients never used to bleed and we used to cut the IMAX also like this.
Yeah.
That was misleading for the starting surgeon. Like, actually, you should get the feel of the patient bleeding.
Yeah, Dr. Pawan.
I think there are two words for it. Yes. Primary
Yeah, that too.
So there are two words, megalomania and overconfidence. I think no surgeon should follow these things.
I have not
He
guts
should-
to give
he
it to
should
the
be
residents.
Introspective. So residents, what we do is, at first I give them a follow-up. Do a suction endoscopy on follow-ups.
Very right.
And even in OPD, you start seeing patients with the endoscope. And if you see some secretions, do it in the OPD itself.
With yours.
So that they are well versed and you are seeing what they are doing. So they are well versed with endoscopic handling. And they should be well learned. They should have done at least 10 cadaveric dissections. Should have attended some workshops and
Yeah,
all.
but I'll
And then
come with
with
it.
strict observation of mine, if they are operating, then I can allow that. This is
So
something.
what are the factors which help in reducing complications? And what are the newer concepts coming up which are evolving are this technique of FES? So I think this was opposite to the avoiding the risk factors and then reducing complications is this other way around now only. So I have explained because this is already covered. So good understanding, thorough knowledge of anatomy, improved. What about endoscopes and video equipment? They have also come up now so that to avoid and reduce the complication. What is your say about this, Dr. Chandni?
Yeah, ENT now I think it's totally technology driven. The better equipment you have, the better the result will be.
Yeah.
Even in the hands of a skilled surgeon, he can improve the results.
Because earlier,
Navigation systems and all, you and PGI,
yeah.
have that.
So Dr. Surinder must be doing, he was my senior resident in PGI. So earlier we used to do with the naked eye, directly into the endoscopes and what hell is going on inside. We never came to know about it. So we learned when we were faculty. Yeah.
I think
That is important for teaching also. How will you teach when
Yes. Yeah. Definitely.
I think endoscope is important, monitor is important, but what happens is sometimes you tend to oversee the complications. You are seeing on the monitor and you are not seeing at the eye. Sometimes the orbital injury may occur, orbital hematoma may occur.
So
You may
it's
notice it at
overall-
the end of the
overall you
surgery.
have to-
So
yes.
it's always
So keep on-
advisable that whenever you are doing it, keep an eye on the
Yes.
orbit also.
So yeah, if you
So
are
that is very
near
important.
orbit, you
Not
look
concentrate
for
on the
the
monitor only.
Yeah. So look for the.
I think for technology is in my initial practice, I used to see my videos back. How my hand is crossing each other, my instrument is crossing like this. Where did I make a mistake? I think retrospectively, if you see your videos, there comes the technology. So technology is important. It should be there to teach, to see, to do a good surgery.
correct.
But to retrospectively see
It is
yourself.
not everything.
what-
Again comes the skillfulness of the surgeon. So it definitely helps. It definitely helps. But yeah, so it has definitely boomed us. With this FES.
One thing I want to add.
Yeah.
In other hospital, I forgot the name of the drug. The new thing. Dexmedetomidine. So that is also very helpful in FES patients when you need this patient has a tendency to bleed. So kindly use that drug.
So here comes the role of hypotensive anesthesia, as you were asking. So we can reduce the complications by having hypotensive anesthesia, have proper hemostasis, and keep those saline adrenaline patties, decongest first with the marrow cells and saline Adeline marrow cell, and then only look for that. If there is a congestion, lot of edema, then you will not, if you are going ahead with your instrumentation, you will cause more of bleeding, and you will not be able to see your landmarks. So always decongest nicely, pre-operatively, outside the OR and then inside the OR, right? And of course, pre-operative imaging that you have told already, that is important to understand the extent of the disease. Yes. Yeah. I'm coming to that. I'll be coming to that. You will get your answer. So what is the radiology, which is most important, which is best when before going ahead for the FS, and what is the role of MRI?
Only landmarks, I think CT scan is the hallmark for us people.
So plain or contrast enhanced? Do we need that for rhinosinusitis? We are talking about rhinosinusitis. So not.
Not for.
Yes.
NCCT is sufficient.
Yeah.
But
And
I
what
think
about?
the cut size is very also important.
Mhm.
Because in institutes who are also institute, sometimes the radiologist gives a 3 millimeter, 4 millimeter cuts. So it is important that it should be 1 millimeter less than 1
Get the
millimeter.
videos from
CD,
the
CD.
Yes.
we get on WhatsApp. So
You get a
that
CD
is-
and you can
CD
follow.
then.
Yeah. So all those to see the various variations, as you have already told. So study it well so that you can recognize concabulosa, Heller cells. In one of the video that I have showed you, in that Heller cell was also there. I didn't comment on that. So that was there on right side, and we could open that by probing and then open it. Otherwise, there will be again a residual disease, and then again the recurrence will be there. So where comes the role of MRI in rhinosinusitis cases, or with the extensive nasal polyposis?
Complicated cases.
Complicated
Plus,
cases.
you are suspecting a tumor, like in case of inverted papilloma, there is a
No,
cribriform
this
pattern.
just rhinosinusitis with
diagnosed.
nasal polyposis.
But in case of the rhinosinusitis, only the complicated.
Or
disease.
AFRS, yes, extending to the skull base. Yeah. And intraorbital, yes. If it is going, there comes a role. So high resolution CT scan combined with triplanar reconstructions, well-read radiology. Then there is a close mnemonic. There is a mnemonic cribriform plate. You should look for the cribriform, lamina papyracea, Monodi cell, wherever it is there. Then sphenoid sinus, pneumatization, and anterior ethmoidal artery. However, a surgeon should be capable of meeting with sudden pathological events. So you should be prepared for that. Even in spite of reading the CT scan, you should be well versed in taking up the situations when there is a lag between the FES and the CT scan. So this is also there. So what are the indications of image guided system? When we want image guidance in this is a little advanced thing. I just wanted to know
extended sinonasal polyps and revision cases, they're definitely better in the hands of an image guided to reduce your complications.
Yes.
Wherever it's possible. So in Gangaram, we had it even in 2006, 2007.
Okay.
But I'm sure now a lot of government organizations also having that. So it's a very good tool to reduce risk of complication. And whenever it's involving the skull base or at the orbit, wherever you need high risk surgeries, will definitely do better with image guidance.
Yeah, we don't go many times for the image guided system, but whenever if we have a facility and if we have like in frontal sinus lesions and the disease which is more near to the skull base, orbit, optic nerve, we can go ahead with that. And that is the guidelines from the American Academy. So when do you say, even now this, sorry, I have already put up that slide. I just wanted to know, with image guidance, the study came up that, the complications are less. But when now the studies are coming that with image guidance, there are more complications happening. Why?
Because
they save the previous image and you're taking out the tumor and then
not tumor, sinusitis discussing.
Taking out the polyps, so that image is not fed there. So your instrument will be like you'll be confused a bit. You can be confused.
Okay, Dr. Pawan.
You become more daring with the navigation system.
Yes. One of the thing is you become, we are having image guidance. We can go ahead.
Human tendency Yes.
There.
Yes. I'm seeing on the navigation, I'm going close to carotid. Even if it is very same, I'm trying to pluck out the polyp from the external sinus because I do have women's guidance. No, don't follow that.
Yes, and
It's
we are
like
doing.
you are wearing a helmet and you want to drive faster.
Yes, very quickly said. And in the cases which are more complex, even in those cases, we are going ahead with the image guided system, not in the simpler cases. Even in simpler cases, we are having complications, more rather many times. In complex, you are always careful. So only in complex cases, we are going ahead with the image guided system.
The principle is don't depend upon the technology.
Yes.
Anatomy should be very clear to
Yes.
you where you are working.
Very correct.
Unless your anatomy is clear, the technology
Very
will not
correct.
help you.
Very correct.
Yeah.
So this is a small video showing like in this we need image guided system. Like this was a recurrent case. I did FES on this and it was the floor of the orbit. This was a allergic fungal rhinosinusitis case and the floor was of the frontal sinus was destroyed coming into the pus was coming into the orbit causing proptosis. And we operated, made such a nice nasal communication, but the patient didn't turn up. So our patient came after 1.5 years, and I saw the same situation as the patient came with me in the primary stage. So the middle turbinate was lateralized, and then adhesions were broken. And then we saw that some whitish thing is coming out from above. So maybe CSF leak. So we got scared a little bit too, but kept on opening because it was too anterior to the middle turbinate, just after the middle turbinate. So, but we should be careful in these cases, like recurrent cases. So all anatomy is always distorted. So we could see there is a big mucopyocele. That bluish thing was seen earlier. So that is a sign of mucocele. And later on, as we debrided, the whole procedure had to be done again. That the patient compliance was very poor and patient didn't turn up. So one with a large cavity this time we had made, you can see a lot of pus, mucopus coming out. All of it was drained. And then you can see the anterior ethmoidal artery even at the base. And this was the whole picture. So you have already told perfect surgery in CRS conducted by most skillful surgeons. So you'll have less number of subsequent complication, decreased surgical interventions. One surgery will do. Otherwise you have to, again, okay, resident has done, you didn't have time. So he did the surgery. I know that the patient is going to come back and you have to repeat it. So it's better if you are present there at the time. And it's a good positive thing to do FES in contrast to pharmacotherapy. Just keep on giving the medicine and not do the surgery. So I just wanted to discuss the trends and complications after functional endoscopic sinus surgery, which was done in Japan. It was a comparison with the previous study. Like they reported 2007 to 2013. Earlier they had published, then 2013 to 17 they had published. And they wanted to compare that with the advancement of things like instrumentation, technology, everything, is it comparable? We have improved or not, as this was discussed earlier. So this was a just study I wanted to tell you. Overall complication rate was 0.5. Only two things happened, like modified Lothrop procedure, they could enter into their universal health insurance system. And secondly, they had come up with the eosinophilic chronic rhinosinusitis, ECRS, which has gained recognition for the surgery as well as the medicinal point of view. So the extent of FES was not associated. They had classified the this rhinosinusitis into in the surgery of this into single sinus opening, multiple sinus opening, all sinuses opening, and extensive sinus surgery into types 2, 3, 4, 5. But they had seen that with the extent of the FES, that is not associated with the occurrence of overall complications. Rather, they are associated, more complications are associated with the comorbidities. That I had showed the slide, this thing also in the slide, that many times the patient is very comorbid, age is more, other things, diabetes, hypertension, renal diseases, all those things are there, and academic hospital status. If the patient, if the residents are there involved, learning curve, then you have more complications rather than a skillful surgeon operating. And use of microdebrider, yes, with the advanced instruments, lower occurrence of complications were there, but they couldn't see any apparent changes from 2007 to 13 and 2013 to 17. So this I wanted to tell, because with the improving of technology, you go with the even experience matters in that too. So high complication rate was 3.1% with Stankiewicz et al. And otherwise, again, the complication rate was very low, 0.36 and 0.46 major complications. Krings et al., he told Medicaid insurance. So insurance companies are associated in the outside like America and other countries. So insurance companies are always, they look for the complications and they are being paid. All those things are there. So Medicaid insurance, that was a marker. And this thing has come up that lower socioeconomic status, delayed treatment to those, more advanced disease in those cases. So those patients have more of complicated complications. So what is the criteria for trained and skillful surgeon to perform tests? Half of these criteria you have mentioned, Dr. Sarika had mentioned, 100 diagnostic endoscopies. And capable of easily handle the endoscope tool. This is also important. This was told, staged and supervised surgery told by Dr. Pawan, and dedicated work in the post endoscopy clinic. Yes, this was there. And they should be able to carry out in emergency procedures. Like you said, mucormycosis, they had got very good experience with that. So all these cases should be, and cadaveric dissection courses. So that should be, otherwise, more chances of complications. So what are the common complications causes in pediatric FES? We just want to little bit have the pediatric discussion on pediatric FES. Yes, Dr. Surinder, Dr. Sarika.
The anatomy is different.
Yeah, I think another 2-3 minutes. Yes.
The anatomy is different. The airway is smaller. Things will be the sinuses are not well formed, because as you know, the nasal bone and the septum and the sinuses develop till the age of 16. So you will have a lot of difference. And also, unless you're a trained pediatric surgeon, if a regular surgeon does once in a while, then the rate of complication will definitely be high.
Yeah, definitely that intimate relationship, small nostrils.
Even for the skilled surgeons, the experience with pediatric tests is really not that much. And also the operating endoscopes and all, they are very thin, and instruments should be appropriate for the pediatric surgery.
Yes.
I think as per the literature available, they say most common cause of sinusitis in children is adenoids. To handle the adenoids.
Yes.
It's the sinus surgery is only for complications.
So many times if you are having allergic fungal rhinosinusitis,
and all that.
Yeah,
in
that
case
gives
you definitely do the
apoptosis
surgery.
and all.
Otherwise, inflammatory disease, non-polypoid, non-FRS, you treat the adenoid, that will take care of it.
Yes, that is about rhinosinusitis cases, but in AFRS.
One more important point in pediatric chronic rhinosinusitis is not to treat the CT scan.
Yeah.
They all usually come up with the acute or subacute episodes of chronic rhinosinusitis. Please give them medical treatment, a conservative treatment, maybe for 2, 3, 4 weeks. Then only get a CT scan done, so that you don't treat the CT scan rather than the disease.
Less role of surgery in pediatric patients.
I think
So more of
the
medicinal.
one big indication for endoscopic pediatric surgery is JNAs. And of course, the rate of complication.
Rhinosinusitis,
Yeah.
nasal polyposis, without nasal polyposis. That's it. So there was a meta-analysis, but there was a meta-analysis that again, the complications are rare when we are doing on this. No CSF leaks, very few orbital. If there are complications, they are orbital many times. Otherwise, not. So a few common complications like hemorrhage. How you will manage the hemorrhage?
Hemorrhage, first I think is very important preparation, as we have already talked about. Preparation is one. Then secondly, as somebody has said,
I think this we already discussed.
Yeah, the other things like heparin or aspirin.
Yeah, I
that
just
should be
wanted to
stopped.
complete.
And secondly is the intraoperative management.
Yes.
The anesthetic part, where it was said it is a capillary bleed. So the hypotensive anesthesia is not that important now, considered important, but it is the position of the patient which should be handled by
That is
position,
also one of the
and
facts,
also
yeah.
the packing which we do just before starting the procedure That is very important.
Yes.
And third is keeping the pulse rate towards the lower side, that is
Yes.
bradycardia.
So what about the nasal mucosa, mucosal bleed, uncomplicated bleed? This is also very common, which you should be taken care of. So what are the things that you should be taking care of? What are the causes of this
Respect
and how it
the-
affects your surgery?
Respect the mucosa. Don't do any, even when you're injecting local anesthesia, see that you're very careful and you don't make multiple punctures, especially for juniors. When you're packing the nose, sometimes you do a very bad pack. When you open it, everything is bleeding. So be very gentle. That's what our teachers have taught us, and that's what we'll ask the next generation to follow. Be careful with the nasal mucosa, because if you have one tear, it's going to increase your surgical time by almost half an hour,
Yes.
45 minutes. And when you're going to operate, posterior to anterior is a better thing, because then the posteriorly it keeps on oozing and spoils your vision, and you have to keep on removing your the endoscope multiple
Yes.
times.
So this was
Also use a micro debrider and a good suction, so
yeah,
that
so-
your surgical time reduces.
Yes, so this was your answer, that arterial hemorrhage happens at the average blood pressure, and venous hemorrhage occurs at the mean blood pressure in the vascular territories of the vein, and it is more of the capillary vessels, which is the layer of an uncomplicated mucous membrane hemorrhage during fest. So that is important. So we should do good decongestion and good instrumentation, not to touch anywhere, respect the mucosa, as Dr. Sarika said, and that is to avoid all mucous membrane hemorrhage. So many of the things you have already said, like Hopkins rod and rod lens endoscope whenever you are going in, that should reduce the oral mucosal lesions too. Then topical saline Adeline patties, administering hypotensive anesthesia. This was the answer for you, doctor. Yeah. And this is more important to give the clear view. And what is the, how much blood pressure you keep whenever you are going ahead for the FES? So what you tell your anesthetist?
160 and pulse less than 90. And
Pulse less
we
than
use
90.
clonidine also.
Okay.
We use clonidine also. It is a ganglionic blocker which gives you a good hypotension as well as bradycardia.
Dr. Surinder?
I don't see the blood pressure. I ask my anesthetist to keep the pulse rate between 70 to 80.
Okay.
That's all. And the position, of course.
Yeah, anybody else?
Position. Yes.
With the Dexmed, I think the
Yeah,
results are
Dexmed.
better.
Yes, Dexmed,
So I
yes.
tell the anesthetist to use Dexmed whenever.
Yes. And to have more clearer field, you have to go long surgery. You have to do a long surgery. So better to, I tell my anesthetist to keep between 90 by 60. So our is standard protocol to keep BP between 90 and 60. As soon as they come up to the 90 by 60, your field is absolutely clear, and you come to know. You come to know that the BP is less. As you ask for lots of bleeding and this is how much is the BP, you suddenly ask, and very correctly said your pulse rate and your heart rate should be less than 65, 70. If you keep that, yes, sir. Yes.
Rather than we ask
Normotensive.
the cardiac output and all, right? Cardiac output is very
Mm.
heart rate has to be reduced.
Yes.
Rather than the blood pressure.
Yes. So it has to be multiple things.
Physiologically speaking, it's about
Yeah.
the same thing. If you reduce the heart rate, blood pressure, cardiac output, all these
Very right. But it's a criteria when you're reducing. I said all the things, like if you're decreasing the heart rate, so BP also comes back to that. So it's a standard in our that do the endoscopy. You can't do endoscopic sinus surgery in a 120 or 160 by 100 and 90, so that is one of the things. Dr. Surendra?
I think one of the problem with hypotensive is sometimes you are operating under hypotensive anesthesia. You are very happy that bleeding is not there, and you just pack post-op. When the
No,
blood
that
pressure
you have to
rises,
see. That is the
patient starts
management of the
bleeding.
anesthetist. That they manage. Now you have completed the surgery, they'll come up. Yes.
But sir, during extubation, generally the blood pressure rises, patient exerts. But when you are not doing hypotensive anesthesia, that is a normal blood pressure, then you can know whether the patient is going to bleed or not. But when you are hypotensive, already hypotensive, then there are more chances.
Sir,
compared to-
I
I'll
don't
just
think so
end this-
because I think
I'll just end this
yes.
because we're going on forever.
Yeah.
So when your surgery is over,
Yeah.
surgery is over, the pressure is near normal. You look for any major bleed, and if you have at that time, address it immediately, because post-op you can't just wait for the packs to work, and you don't want to take the patient back into the OT in the next 24 hours for a reactionary hemorrhage. So when your blood pressure is near normal, look for any active bleeding.
Yes.
Control it so that the post-op residents don't
Give
have a
time
bad
to
time.
that. Yes. And
Yes.
yes. No, yeah, because yeah, just to summarize it up, main aim is that you should have clear field during surgery. During surgery.
I think we can
So if you
keep
don't
on-
have clear field, you will cause complications.
Please excuse me. I think we can keep on doing this discussion because it is an unended discussion.
So,
This topic of
yeah,
interest to everyone.
aggressive approach.
So we have to conclude somewhere there.
Yes. So lamina praepatia, one last thing, lamina praepatia injuries if we have. So what is your take on that, lamina praepatia?
Suppose
You have
minor
injured.
paprici is injured, then it is not a problem till we reach the periorbita and the fat comes out, because once the fat comes
So
out.
how you will
then-
recognize that the fat is there or polyp is there in front?
So one is there something protruding out from that part, and we can just take a piece of that material and put it in the slime.
What is your take on this, Dr. Pawan? Should we take out the
if
piece
it's
of
a-
fat?
No.
And then,
If it's
no.
a minor injury to periorbita or even the lamina praepatia, there would be some punctured hemorrhages, subconjunctival hemorrhages that will go off on its own within few days. Maybe even subcutaneous hemorrhages they will. But if it is a gross prolapse of the fat down there, then you have to do something.
So yeah, this is for the residents. Yes, we should not never
Don't-
take out
don't
the
pack
fat.
it.
Yeah.
Don't pack it.
And don't pack it hard, tightly.
The other thing is you should be able to identify it. If you are using a debrider, you might pull out whole of the orbital. fat
Yes,
in
yes.
your
So that should
debrider
not
in
be
no
used
time.
near to that.
It has to be identified.
Yes, and there is a Stankiewicz sign which says if
Yeah,
you
you can press
palpate
the
it lateral to medial, so you can see the same movements happening inside. So that is the most important thing. And that constantly generates the bulging of fat, corresponding movements. So that should be seen rather than plucking the fat out and leave it as such. Yes? Yeah. Yeah, that is also
Yes.
there. If lamina praepatia injury is there. Yes. So I think the time is very less. So it was intraorbital hematoma because of, I think the cause is everybody knows, anterior ethmoidal artery. You should look for that location so that it doesn't happen. 40% cases damage occurs. And what you should do immediately?
So I think one should learn to do a good lateral cathode. That is the important.
That is post-operatively. If you find it intraoperatively, then what? And you have suddenly seen that the orbit is ballooning out. Whenever you are working near the orbit, look for orbit, always outside also, what is happening. So what you can do at the time? Intraoperatively.
Polarize the entrance, but that's it. If it is visible there.
If it is visible, if it has retracted into the orbit, then what? Dr. Singhal?
Expanding, then you have to do it.
Dr. Surendra Singhal?
I have 2 cases of orbital hematoma. I did an immediate canthotomy, but when I tried
Intraoperatively,
yes. And when I went through the Linz-Haworth to see the retracted vessel, I could not find it. But patient's vision was normal.
But
you could do a medial decompression.
medial decompression, yes, that is the right thing. If you are intraoperatively, you are well versed, you can do endoscopic medial wall orbital decompression at the same time. And this is the small thing which I showed. You are doing medial wall decompression. So that way you can do after doing, it should be quick with a skillful surgeon. And then although this video was, I took for the thyroid ophthalmopathy, just 2 weeks back I did. And then we are, what I'm doing is the incision and superiorly as well as inferiorly. This is to avoid the diplopia in these type of cases, although this is not related to that. But whenever you are doing for the medial wall orbital decompression, start coming from posterior to anterior, because most of the time hemorrhages at the posterior part and optic nerve, suddenly you will see dilated pupil. So to avoid that, come from posterior to anterior. It is always advisable.
A bit inferior so that you don't injure the medial rectus muscle there.
Yes.
Otherwise,
Yeah. So that's why we are leaving a sleeve of periorbita to protect the medial rectus muscle. So
The
that
other
is the
factor
way. And just try to take out that hematoma from that side, because there can be venous small oozes of venous.
The other factor is if you do from anterior to posterior, the fat will prolapse and the vision will be hampered. You will not be able to see the posterior.
So that
side.
is why
So
you should
have to come from posterior to
posterior to
not
anterior. Yes,
to
vision
posterior.
will be hampered. You will not be able to take it out. So always, this was just a pre-op and post-op. I took that picture. Chances of ICA last. Very sorry to complete. I took more time.
Inflammatory disease, it should not happen. Tumor surgery, it's of course, I have told in
Very,
my
very
presentation, I
rare.
had one carotid bleed, which we managed.
With the rhinosinusitis, nasal polyposis?
No, I did
No.
not get.
I'm asking in this.
If you are very callous with the sphenoid.
Yes,
and don't
yes,
understand
very
the
right.
anatomy.
It is very rare.
I think the most
It can
important
happen.
is read the scans well.
Where you can see, read your ICA also in the scan with the disease, right? Because there can be dehiscence of the ICA many times. So read that there and then, and all those things. Onodi cell, less than 1% intersinus septa crossing, you have injured that, and ICA hemorrhage can occur. So what is the management?
I mean, immediately
happens
packing with
in-
the muscle pieces and sending the patient to interventional radiology.
Very right.
for
I'm
coiling.
finishing very fast. Yeah. Yeah. If there is risk of ICAs, you should have preoperative CCT. Otherwise, we just get plain CT nose, PNS, and paranasal sinuses, and MR arteriography too, many times. And if skillful surgeon should call the skillful surgeon, experienced surgeon at the same time, and immediately pack, very rightly said by Dr. Pavan, muscle should be kept there. Muscle should be kept and pack it nicely. Yeah, and in 70% cases, if we sacrifice IC, nothing happens. But if it is there, then Bellew test, occlusion, and immediately DSA with embolization
I
should be
think
done
when
with
there is an
coiling.
ICA bleed, you don't have any time to pack with
Yes.
the muscle.
No,
You have
no.
to just pack with the ribbon gauze tightly and then send the patient to intervention
You
radiologist.
you can
The
pack
moment
it.
You,
You
the
can
moment you remove the pack, it's a gush of blood which
Anybody
comes,
else?
unless you have 2 or 3 suctions with good suction vacuum, which they can suck out and immediately you can pack. That's of course where like PJ conducts a course on arterial injury on an artificial mid sheep head. He maintains all the parameters.
Yes.
Normal blood pressure. Then you injure the internal carotid artery, same, and then how to manage it. Those cases, if you have attended, you might be
Yes.
able to handle it.
So this
Otherwise,
criteria-
pack it and send to intervention.
Yes. So these protocols also we should know, well versed with that. Dr. Pavan, you were saying something.
Yeah, you can pack with the gauzes, sir, but immediately you just make a slit on the thigh of the patient.
Yes.
Take out some muscle part there.
Very correct.
Use 2 suctions from both the nostrils. The assistant is suctioning from one, and you are one with endoscope. After using suction, remove the packs and then
Remove
just
the
push
pack
in the
and just
muscle there.
push the muscle.
Muscle is the best material to stop the immediate, stop bleeding immediately.
Very right.
The sphenoid
Otherwise,
sinus.
even with your
Because
packs,
without muscle pack, you
Bleeding
can't
will
send
not.
that patient to interventional radiology.
yes. So
Patient will
then
succumb
only you
to
can send
that.
the patient to the intervention. Yes. I think this is the last. And thank you very much. I salute my teachers and my seniors and my juniors too, who made me learn all these things. And this is, I happened to meet Professor Stamberger in New Zealand in one of the conferences, and we deliberated our views also. And I really respect him. He's no more now, but he's the one father of us. So thank you so much.
Thank you.
All the panelists. Thanks.
Thank you so much, everyone. Now I request our panelists to kindly present a memento to our moderator, Dr. Rajunita.
Lot of things from him. Was my senior as well.
Now I request Dr. Rajunita to please present a memento to Dr. Chandni Sharma and Dr. Sarika Verma. Our next talk is by Dr. Jatin Verma on the topic Management of Single-Sided Deafness. I request sir to kindly come on the dais. The chairperson for this session are Dr. Ashok Gupta, Dr. Asaruddin, Dr. Surender Kumar, Dr. Jitendra Singh, Dr. Surender Bishnoi, and Dr. R.K. Pruthi. I request the chairperson to kindly come on the stage.
Really excellent. I know. I know. Okay. Good afternoon, everyone. As we all know, blindness, it separates people from objects, but hearing, a person who becomes a deaf person, he's isolated from other people. This is about if he's totally deaf, but what if he has got single-sided deafness? By single-sided deafness, I mean to say 1 ear he is having severe to profound deafness, which is non-audible, and the other ear is completely normal. That is, the threshold is within 20 decibel. The incidence of single-sided deafness is 0.4 to 3.4 per 1,000 live births. We can have various etiologies for single-sided deafness. It may be sudden sensory neural hearing loss or ototoxicity, or it may be Meniere's disease, or we can have enlarged vestibular aqueduct or unilateral vestibular schwannoma or ossification. This is audiogram and BERA showing 1 ear normal and other ear we can see profound deafness. So what all this single-sided deafness do? First, I'll talk about head shadow effect. Suppose if a sound is coming from the left side, then this sound is going to reach left ear faster and it's going to have a greater amplitude. That is interaural latency difference, it's reaching faster. Second is interaural level difference, amplitude will be more. That is why brain chooses this ear as the preferred ear. But what if this ear becomes deaf and speech is coming from this side? Obviously that person is going to have problem, because that sound, by the time travels here, all the things happening, patient won't be able to localize the sound, he won't be able to spatially discriminate, all those things happen. Even much more important is squelch effect. By squelch effect, I mean to say, because of this interaural level difference and time difference, a person, suppose he's in a conference or he's in a meeting and different people are talking, first this one, then other one, then other one, then shifting his focus from one to other, then another. All this is what squelch effect. So if one ear is not working, is deaf from that ear, he won't be having that leverage. He'll always face difficulty in noisy situations, conferences, meetings. So suppose if he is having all these issues, one more issue I forgot. summation effect. Suppose both ears are working together. That means patient gets additional 3 to 5 decibel of threshold. So he can hear softer sounds also, which he may miss out if one ear is not really, it's profoundly deaf. So what this single-sided deafness does, suppose if patient is having deafness on the left side, again and again, he'll be moving his right ear to that side or the other side so that he can really, listen to the sounds. So that it really impacts cognition, because that is going to put pressure on the brain to really make the adjustment movements of the body. And he'll also have to learn lip reading strategies. In children, they'll have delayed oroverbal skills. So what are the options that we can have for this management of single-sided deafness? We can have cross hearing aids, we can have bone conduction implants, we can have cochlear implants. So first I'll start with the cross hearing aids. In cross hearing aids, microphone is worn in the deaf ear and receiver is worn in the normal ear. So there will be contralateral routing of the signals. Suppose signal is coming from the deaf ear, that signal will be routed to the normal ear. But then because of aesthetic concerns, patient says, Doctor Saab, I am wearing a hearing aid in the deaf ear as well as on the right ear, because microphone is in deaf ear and receiver is in the other ear. But obviously, suppose he's a candidate non-surgical, he doesn't have the finances, then cross hearing aid is the option. The hearing that it is going to give is a pseudo binaural hearing, because whatever sounds they are coming, they are being diverted to the normal ear. And ultimately he is using only one auditory pathway, not the two auditory pathways that we use in normal hearing situation. Then the next option is cochlear implantation. As we all know, it's a gold standard for bilateral profound deafness that we have up our sleeve, and it's one of the most important inventions of the last century, and it has stood the test of the time too. The advantages that we get with the cochlear implant is we can have good speech discrimination, we can have musical appreciation, we can have a good sentence and word recognition, sound localization. And it's very interesting to note that in cases of single-sided deafness, it was actually used for tinnitus suppression in the beginning. It was only after that that studies were carried out and we came to know that it can really help in the hearing also. But there are certain concerns that when to do the cochlear implant. Patient is deaf on the one side, patient comes to us. So according to the studies and literature, what I have gone through, the critical period is 1 year. The best results that we are going to get is within 1 year. But obviously few studies have said up to 7 years, they have got good results. But beyond that, it's really dicey. Of course, we need rehabilitation just like we need in the other deaf cases. Mostly 6 months will do. There's another concern. There was a concern whether this electrical hearing in 1 ear and acoustic hearing in the other ear, whether they will integrate. So we have gone through sufficient data. There is no problem for the brain in integration of acoustic hearing from one ear and electrical hearing from the other one. Then if we have cochlear implant, it's a gold standard. So why can't we do cochlear implant in each and every case? There are certain indications where we'll have to go for bone conduction implants. Suppose a patient is having Michel's aplasia, that cochlea is not developed on one side. Patient is having severe cochlear ossification. We can't do a cochlear implant. Patient has absent nerve on one side, but other side nerve is normal. We can't do CI. And suppose a patient is past critical period for this CI. A patient comes to us after 10 years, 15 years. We know the results are going to be dicey. That time we can opt for bone conduction implants. So how do they work? They basically work like vibration from the deaf ear will be carried through skull bones to the other normal hearing ear. It's similar to cross aids, but instead of using air conduction as the route, it is using bone conduction. It also helps in overcoming the head shadow effect. And most importantly, we do not need any rehabilitation after bone conduction implants. In bone conduction implants, we have two options, either BAHA or bone bridge. We have been using bone anchored hearing aid, that is BAHA, for so many years. But as we know, as India is a humid country with so much of perspiration, there have been issues with skin reaction, osseointegration failure, all these things happening. So the newer technology which has come across is the bone bridge. Bone bridge is an active transcutaneous device in which everything, it has got two parts, just like cochlear implant, external part and internal part. Here we can see this external part is the audio processor, which consists of microphone and speech processor. This is the internal part, which has got this floating mass transducer, demodulator, and this is the radio frequency coil. So the internal part is going to stay under the skin and everything is going to be closed, not like BAHA, that transcutaneous abutment which always protrudes out through the skin and we have to connect the speech processor to that. So there are certain requisites in which we can do the bone bridge. Minimum age required for doing bone bridge is 5 years. In US, it is 12 years. Minimum 1 centimeter skull thickness has to be there so that we can do this bone bridge, because the thickness of the implant is in itself is 9 millimeters. Like I told you, the parts, internal parts and external parts, I've already told. There are 3 approaches by which we can do this bone bridge. One, we can do transmastoid if we have got a wide cavity, pneumatized cavity. Suppose if we have got cholesteatoma or disease in the mastoid, sclerotic mastoid, then we'll have to put that bone bridge in the retrosigmoid region. Middle fossa approach is also one of the options. This is how the bone bridge is performed. We give a cutaneous incision. We have raised the periosteal flap. After that, this is the T sizer for which we are making the markings with a small burr, just like we do in a cochlear implant when we are making the well. After that, once that mark is made, we shift on to the bigger burr. Slowly and slowly, we are drilling out the mastoid, drilling out the cortical bone. Now we can see the dura, but still the thickness of the well, it's not enough to accommodate the receiver demodulator. So what happens? Floating mass transducer. So now what we are doing is we are further taking off the bone and exposing the dura in the circumferential region, leaving behind a chip of bone in the center. Just create, we create scripts oasis in cochlear implant. Now we have made markings for the screws. After this is done, we are putting that bone bridge in the well that we have created, and this floating mass transducer, now the screws, the sockets that we had made, now we are tightening the screws. And we have to ensure that torque that is created after this has to be less than 30. In this, our case, we had 20 N-centimeter as torque. So the advantages are that abutment is not there, no skin reaction is going to be there. And other thing, what happens is with the growing age, the size of the abutment falls short. We have to replace the abutment. So that is not required in bone bridge. The complications rate are obviously less. Another important point to be made is that the vibrations, they are not transmitted by the floating mass transducer directly to the skulls. They are transmitted by the screws. That is why we do not need any osseointegration. And it is compatible with 1.5 Tesla MRI. The sound quality is obviously natural. There is no head shadow effect, which I was talking about, no occlusion that we get in cross hearing aids. But however, as compared to cochlear implant, the sound localization and speech perception is in noise. Obviously, they are not going to match what we get in cochlear implant. So in the end, I would like to conclude, there is no best option as such for a single-sided deafness patient. But however, according to the rehabilitation needs, expectations, and financial constraints, we have to really make our choice from the options that I have discussed. Thank you very much for your patient listening. Thank you, sir. Any questions?
Thank you so much, sir. I request our chairpersons to kindly felicitate our speaker, Dr. Jatin, with a memento, please. Sir, वो एक बार ये change करा दीजिए. Now I request our speaker to kindly present a memento to Dr. R.K. Pruthi, please. The last talk today is by Dr. Ravi Bhatia on the topic CT scan of temporal bone. The chairperson for this session will be Dr. Raman Sharma and Dr. Ashima Saxena. हम बोल दिया फोन करके आ रहे 2 मिनट में आ रहे हैं कोई दिक्कत नहीं
थैंक यू सर थैंक यू डॉक्टर सुनील मुंजाल सर मैं आज के मैच का लास्ट बैट्समैन हूं तो आई होप मैं बॉलें वेस्ट नहीं करूंगा एंड आई विल ट्राई टू डू सम मीनिंगफुल जॉब फॉर द यंग गाइज हु आर सिटिंग इन द लास्ट बेंच. Friends, before starting my talk, I would like to thank 3 surgical gurus of my life. One is obviously Dr. Satish Jain sir, who is teachers of teacher, Dr. Monish Grover sir, who taught me the basic and advanced surgical technique of cochlear implant. And another one is Dr. Sharal Lata, whom he has made a significant impact on my surgical career. So just a brief recap of our ear for our young friends. This is how we see the ear. Extranodic canal, outer 2/3 cartilage, inner 1/3 bony. Then there is a tympanic membrane, malleus incus and stapes making a contact with saccule, that is vestibule, we all know. Then there is a cochlear tuns, modulus and vestibulo-ocular nerves, cochlear nerves. Then comes the basic diagram. I think the main action for the CT temporal bone, as a ENT surgeons, we all are interested in the anatomy of the middle ear. So this is just a schematic diagram of the middle ear, and we are looking from a tympanic membrane. So the wall which we are seeing in front of us is the medial wall. So the medial wall, which houses the important structures, are like the basic bulge of the promontory, which is nothing but the bulge of the prominence of the basal turn of the cochlea. Apart from that, and then above the promontory, there is 2 bony ridges, ponticulus, subiculum. There are 2 windows. The superior one, oval window, the inferior one, round window. Apart from that, medial wall houses the tympanic segment of the facial nerve, and above that is the lateral semicircular canal, which makes the impression on the medial wall. In the posterior wall, we all know there lies the opening for the aretus ad antrum, and there is a bony projection from where the stapedius muscle or tendon takes off and gets inserted into the stapes. The inferior wall contains the jugular bulb. Sometimes it is dehiscent, projecting, whatever it may be. And in the anterior wall, we all know it houses the opening for eustachian tube, tensor tympani, and in the anterior inferior wall are carotid makes a dent. So that is the basic anatomy of the middle ear. I think I am amply clear to all of the young colleagues. So I am shifting my slides to further structures: malleus, incus, and stapes, malleus, head, neck, long process, incus. We all know body of incus, short process of incus, long process, lenticular process, makes a contact with the stapes, anterior crura, posterior crura, and the foot plate. So jumping our slides, going into the main focus of today's talk, that is the temporal bone. Friends, we all know that as a CT-PNS, paranasal sinuses, our coronal cuts are the main workhorse of an ENT surgeon. But it is not the case of CT temporal bone. CT temporal bone में सारी information हमें कहाँ से मिलती है? Axial cut से. And axial cut जो हमारा mainstay है, that is from the orbitomeatal line, a line which is drawn parallel to the orbit and meatus. And coronal cuts are the perpendicular to this orbitomeatal line. So two cuts are very important. Main one is axial and another one is the coronal, which is perpendicular to the orbitomeatal line. The another important point, this is not my slide, taken from somebody else, but whenever we are going to study the structures, any structure or any anatomical or surgical structure, if it is lying parallel to our plane which we are studying, suppose we are studying any structure and that structure is vertical in orientation. So vertical cuts means coronal cuts. If it is lying parallel to that coronal cut, we will see that structure in the complete entirety. तो वो structure हमें पूरा दिखाई देगा. But the same structure when we will study in our axial cuts, it will be seen as a circular shadow. Always remember this. Suppose some structure is lying horizontally and we are studying that structure in the axial cut, so that structure will be completely visible. And the same parallel structure will be seen as a circular shadow in the coronal cuts. Always remember. Now going into our axial cut. The important, again, one important thing, whenever we are studying a CT temporal bone, we have to follow a certain protocol in our mindset. We cannot just go and do a hierarchy कि मैंने अभी एक कट देखा, फिर उसके बाद दूसरा कट देखा, फिर जो मेरे मन में आया मैंने वो कट देखा, तो we will be lost. So always study CT temporal bone in a certain protocol manner. The most commonly performed or practiced manner to study the CT temporal bone is, for axial, it is superior to inferior. I will repeat, we are coming from superior to inferior. Always. So the first structure which we are going to see is superior to inferior. Suppose a case of lateral semicircular canal fistula comes to you, you are doubting, and you cannot just go and open the slide and see where the fistula, you will be missing many other findings. Suppose a case of facial nerve palsy comes to you. Suppose you are going to do an mastoid, so you cannot just go on see if you go in a certain possible way, so the chances of doing error will be marginally less. You will come to know which ossicles is missing, which is not missing. So I repeat, always study cuts in a certain protocol manner. Should not be doing just an random study of any CT temporal bone. So we are coming from superior to inferior. Got it, young friends? Clear? Am I clear? Are you able to get my thoughts? So the first cut which we come to see is the axial cuts. Okay. So I cannot point because my angle is like that, but I'll try to make some sense. So this is outer cortical. This is the medial one, petrous apex. This is the middle cranial fossa. This is the posterior cranial fossa. This is a tegment plate. This is the posterior face of the tegment plate. And this is our sigmoid sinus or a lateral sinus. In between, there is a mastoid air cells. The first structure which we encounter, a significant structure, is the superior semicircular canal. So this is a dome-shaped structure that is a superior semicircular canal. This is the anterior end, this is the posterior end. So this is anterior, this is posterior. The anterior end of the semicircular canal, and this is the posterior end of the superior semicircular canal. So going into the inferior cut, we are coming from superior to inferior. So the dome shaped structure is now two circular dots because it is now perpendicular. So we will be seeing perpendicular things. So we are seeing two circular shadows, as I've told you. This is the anterior and this is the posterior end of the superior semicircular canal. This is the ampullated end and the posterior one is non-ampullated end. This is outer, middle cranial fossa, posterior cranial fossa, tegment, posterior face of tegment, and petrous apex. Similarly, now we are going little bit inferior. Okay. So now we see that two again semicircular canal, same thing. And in between we see a isodense channel running from posterior to lateral. Posterior to lateral. This is called, this is what? This is petromastoid canal. It houses the subarcuate artery. But we know it as a, since it is a bony thing, we know it as a subarcuate petromastoid canal, not the subarcuate, but it houses the subarcuate artery. In the second cut, now what we see, we are seeing little bit of labyrinth getting formed. We are seeing more of a labyrinth. So anterior, still it is the superior semicircular canal, ampullated end, but posteriorly, instead of the dot, we can see that is extending towards the lateral end. So this is what? This is the, now we know, posterior semicircular canal is starting to emerge. This is the posterior end of the superior semicircular canal and this is the superior end of the posterior semicircular canal. They both are joining to form crus commune. Am I right? So crus commune, non-ampullated end of posterior and superior. So we are going into the inferior slides. Same thing, middle, posterior, medial, lateral, petrous apex, outer cortex. ये लेजर थोड़ा डिम हो गया है लेजर और है आपके पास पॉइंटर. So in this cut we can see on the medial aspect of the petrous apex a isodense sac like structure appearing. This is anybody from the backbenchers, young minds, what is this structure? Anybody? Internal acoustic meatus is starting to appear. So this is the internal acoustic meatus and the same posterior semicircular canal, and rest of the structures are, there is no new structure in this part. Sorry for interruption. He is changing cells. Yes. Now we can see our internal acoustic meatus getting formed and in the going to meet towards the labyrinth part. This internal acoustic meatus is now getting formed. This is the anterior lip and this is the posterior lip. Though CT scan is not the diagnostic tool to diagnose any internal acoustic meatus or this area of lesions, they are better diagnosed in MRI. But still, it is said that in cases of any tumor or any mass effect, this posterior lip blunting will happen. So it will be very obtuse in a normal given situation. The infundibulum, the size of internal acoustic meatus is approximately 4.5 millimeter. In case if it is more than 6 millimeter, then it is supposed to be called dilated internal acoustic meatus. So that is that. Apart from that, now we see a similar iso-intense structure going towards the medial lateral end. This is what, friends? Now this is now getting completely circular in shape. Anybody will be telling me what is this structure, friends? Madam? Anybody from that side? Very commonly encountered structure, first structure to get encountered in cortical mastectomy. Lateral semicircular. This is the dome of the lateral semicircular. So it is a signet ring like appearance. Now what we see, our internal acoustic meatus is making a complete contact with the medial this medial wall. So all the important structure of the internal acoustic meatus wall has now come into the picture. And what we see, a similar iso-intense canal running towards the medial end from the posterior face of the mastoid. This is what? Anybody? You'll get 100 rupees for that. Very good. Dr. Ashima, you may collect your prize. So this is vestibular aqueduct. What it contains? What vestibular aqueduct? Which structure? Membranous structures. Anybody? Anybody? Endolymphatic sacs. Have you heard about endolymphatic sacs? I think जो पीछे बैठे हैं सब पीजीज हैं, ENTs है ना? हैं? पीछे वाला सारा लॉट कहीं ऐसा तो नहीं है कि और इस तरह से हो, मतलब मैं डिटेल में चला जाऊं. So now we can see the complete vestibular aqueduct into the picture. If its size is more than 2 millimeter, it is supposed to be called dilated vestibular aqueduct. Then chances of, in case somebody is planning to do stapedectomy or cochlear implant in this case, then chances of CSF gushers are very high for these cases. Okay, got it? So, or its size is more than the size of the posterior semicircular canal, then also you can take it roughly that it is dilated. So now in the enteroacoustic meatus, we can see many things happening. What are the many things happening? Our posterior semicircular canal has now totally disappeared. Our lateral canal has also started to disappear, and we can see a bulbous like structure over here. So this is what? This is our vestibule. So utricle and sacule. And apart from that, we see a enteroacoustic meatus. There is a sac-like structure appearing on the anterior part of the labyrinth. This is what? This is nothing but our cochlea. Okay? First turn to appear and last to disappear in cochlea. It is the basal turn of the cochlea. So basal turn of the cochlea is now started to appear. So always remember, we are coming from superior to inferior. So superior, all the semicircular canal will appear, and now when we are in the middle part of the temporal bone, so cochlea has started to emerge on the anterior aspect. Apart from that, we see a bony spicule going, and in between cochlea and labyrinth, we can see a this isodense canal running like this, and then turning backwards. So this is what our friend called facial nerve. Am I right, friends? खाने के बाद सो तो नहीं रहे? पक्का? So this is nothing but facial nerve. Facial nerve has got many courses, many parts of the facial nerve. Cisternal part, brainstem से जो आगे जाती है fundus तक. Fundus के बाद enteroacoustic meatus में it is called intrameatal facial nerve. From intrameatal facial nerve से फिर वो जाती है labyrinth part पे, और वहाँ वो 180 डिग्री का retrograde turn लेती है. तो ये वो टर्न है, ये गई और ये वापस मुड़ गई. ये एंगल बनाया इसने 180 डिग्री का, ऐसे गई ऐसे आ गई, और यहां से इसने अपनी पहली ब्रांच दी फेशियल नर्व ने, ये आगे ऊपर निकल गई. ये ब्रांच कौन सी है? 100 रुपए. वेरी गुड. तो ये गई GSPN, और ये गए फर्स्ट जेनु, और ये गया हॉरिजॉन्टल पार्ट ऑफ द टिम्पैनिक सेगमेंट ऑफ द फेशियल नर्व. वेरी क्लियर. ये कॉक्लिया आ गया हमारा. ये देखना यार, मेरी स्लाइड्स आगे नहीं हो रही. क्यों हो गया? लॉक क्यों हो गया? मेरा हाथ कहीं तक तो होगा. नेक्स्ट स्लाइड. इंटरलैकोस्टिक मियाटस, टर्न ऑफ कॉक्लिया, वेस्टिब्यूल. इंटरलैकोस्टिक मियाटस के कंटेंट बताएगा कोई नया बच्चा? प्लीज. बताओ बताओ बताओ. Very good. So it contains the 4 neural structures. It has got 3 compartments and 4 neural structures. Anterior quadrant, posterior quadrant. Anterior और posterior किससे बनता है? Transverse crest से. और जो सुपीरियर क्वाड्रेंट होता है वो वर्टिकल क्रेस्ट से एंटीरियर और पोस्टीरियर में डिवाइड हो जाता है. उस वर्टिकल क्रेस्ट को हम क्या बोलते हैं? बिल्स बार. ठीक है. तो इट इज एंटीरियर सुपीरियर. इट कंटेन्स व्हाट? इट कंटेन्स 7 अप. 7 अप. तो इट इज द फेशियल एंटीरियर सुपीरियर में, और एंटीरियर इंफीरियर में कॉक्लियर कोक डाउन. आपको पता ही होगा 7 अप कोक डाउन. or posterior superior, superior vestibular nerve, posterior inferior, inferior vestibular nerve. Very simple. Always remember that. So now what we can see, intra-acoustic meatus has now started to disappear in the inferior cuts. Many things are happening right now in this cut, and the intra-acoustic meatus खत्म हो रहा है. Turns of the cochlea are now started to appear. Basal के साथ middle भी आ गया है. Apart from that, our friend facial nerve has totally disappeared from the medial wall. Tympanic segment खत्म हो गया है. Now it is going to यहाँ पे अब हमें posterior wall of the middle ear में मिलेगी. Now it will become vertical. When it will become vertical in the axial cut, it will be looked as a circular shadow. तो अब वो यहाँ पे हमें as a circular shadow नजर आएगी. Now it has started to come to lie on the posterior wall of the middle ear. Okay, got it? So अब now we can see division of the cochlea divided in between bone, white thick bone. This is interscalar septum. So it is the interscalar septum. It is a thick bone which divides the basal, middle and apical turn of cochlea. And what is osseous spiral lamina? In between आपको osseous spiral lamina दिखेगा. You will be able to appreciate more in MRI or in a 64-128 slice. That is a membranous bone which contains the spiral ligament or spiral ganglion cell. That is osseous spiral lamina. Apart from one more thing, it is the modulus also. So three structures are related with the cochlea in case if you are thinking for doing implant: osseous spiral lamina, interscalar septum and modulus. Now what we see in the posterior wall of the CT temporal bone, two clefts. One cleft is called sinus tympani and the another cleft is called facial recess. Am I clear? So the medial one is what and the lateral one is what? Anybody will tell? कौन सा medial होता है, कौन सा lateral होता है, facial recess या sinus tympani? 100 rupees. Facial recess lateral and the medial one is sinus tympani. In between there is a projection called pyramid. So it is very important. Facial recess we all know, very important. The place for a residual cholesteatoma and as well as for the approach for cochlear implants. So every cochlear implant surgeon knows about the importance of the facial nerve because यहीं से वो approach करेगा for the round window. In this cut we see the sac-like structures now making a contact with the middle ear. Now middle ear will open. Middle ear opens, inner ear opens through two windows to the middle ear. One is the oval window and another one is the round window. So when we are coming from superior to inferior, we all know oval window is superior to the round window. So first window will be the oval window. Okay. Now intra-acoustic meatus has totally disappeared. We can see complete this cochlea, and instead of the tympanic segment of the facial nerve, we see a membranous structure running towards the anterior. And there is a hook-like projection. This is nothing but processus cochleaformis. Oh, sorry. This is nothing but process cochleaformis and the canal for tensor tympani, which will travel towards the estation 2 on the anterior segment. This is the same. Now we can see instead of our ice cone like appearance of the malleus and ossicle, now we can see two single dot of the malleus and incus. Anterior one is malleus, posterior one is the incus, and we see lateral sinus. Apart from that, we see a structure appearing on the posterior wall of the this petrous temporal bone. Now we can see that structure. Now jugular bulb has started to appear, and now see this. Previously it was oval window. Now this is round window. Okay. Now our round window started to making a contact. So this is the place where the implant will be inserted. Apart from that, there is many new structures have appeared in this cut. What we can see the external aortic canal. Okay. We can see the external aortic canal and we can see the anterior tympanic plate. Apart from glenoid fossa and the angle of this is the mandible. And this is middle cranial fossa, posterior cranial fossa, and now our petrous bone is making a contact with the sphenoid, and it will be going to form a clivus. Occipital bone, sphenoid bone and temporal bone. So we are approaching the clivus area. So now we are in the hypotympanum. All the ossicles have totally disappeared. We can see the tympanic membrane. We can see complete externodontic canal. We can see dumbbell-like structure of internal carotid artery. We can see jugular bulb, and our this mastoid antrum has also thinned out. So our all the labyrinth and cochlea has totally thinned out. We are in the level of infratemporal fossa. So this is almost we are making an exit. Okay. Now since अब हम inferior आ गए हैं जहां से ये दोनों important vascular structures घुसते हैं temporal bone पे, तो carotid and jugular. Carotid and jugular, carotid and jugular. All the inner ear structures and middle ear have now totally disappeared from our scan. Am I making some sense to you all young guys? समझ आ रहा है चीजें या थोड़ा सा बोर कर रहा हूँ? Now we have come to see our coronal cuts. Okay? तो coronal cuts में हम क्या करेंगे? अब हम जैसे वहां axial cuts में superior से inferior गए. Am I right? अब हम यहाँ posterior से anterior आ रहे हैं. Now we are coming from posterior cuts to anterior cuts. ठीक है? तो अब यह हमारा coronal cuts है. Now we are seeing the temporal bone through the vertical section. So ये आपका middle cranial fossa, posterior cranial fossa, tegment mastoidea या dural plate, और ये सारे आपके हो गया इधर जुगुलर बल्ब का इंडेंटेशन. ठीक है? अगर हम पोस्टीरियर से एंटीरियर आएंगे तो फर्स्ट स्ट्रक्चर अगर हम एक्सियल में हमने कौन सा देखा था? एनीबॉडी? द फर्स्ट स्ट्रक्चर व्हिच वी आइडेंटिफाइड इन द एक्सियल कट वाज सुपीरियर सेमीसर्कुलर canal. But in this case, the first structure to be identified from posterior to anterior will be posterior semicircular canal. Am I right? Making some sense to all you friends? तो ये posterior semicircular canal का dome आ गया. Superior and inferiorly आपको jugular bulb दिखेगी. इसी जगह पे आपको carotid भी दिखेगी. When you will come anteriorly, okay? तो how you will come to know कि ये जो मुझे यहाँ पे जो structure दिख रहा है वो jugular दिख रही है या वो carotid दिख रही है? You have to be make a difference. Suppose you are going to do a glomus or any vascular tumor or any fracture you are studying or any kind of phenomena, high jugular bulb riding kind of a situation. How you come to know कि ये जो structure दिखेगा वो jugular है या carotid? तो always remember this simple idiom कि G for B and C for C. G for B, jugular for G for V, sorry, jugular with vestibule. जब आपको पीछे vestibule दिखेगा तो जो नीचे दिख रहा है वो jugular होगी. और C for C जब आपको cochlea दिखेगा यहाँ पे और नीचे जो bulb दिखेगा same ऐसा ही दिखेगा, वो carotid होगी. When you can see the cochlea, the inferior bulb will be of carotid. When you can see the vestibule, the inferior bulb will be of jugular bulb. Always remember. So now dome shaped structure divided into two parts, superior and inferior. Superior part of posterior semicircular canal and inferior part. Apart from that, there is a jugular bulb shadow. The rest of the structure we all know. Outer cortex, ये सारी चीजें. Now we can see crus commune. अब आपका posterior semicircular canal ऊपर चला गया with the superior semicircular canal. So this is crus commune, superior and posterior joining together. And now this is another isodense shadow जो laterally जा रहा है, बाहर की तरफ जा रहा है. ठीक है, ये बाहर की तरफ गया. So it's a inverted T-like appearance. Inverted T-like. So ये posterior, ये lateral और ये उसका posterior का ही part. ठीक है, inverted T बन गया. Apart from that, friends, what we can see in this coronal cuts, we can see a isodense canal running in a totality. Now we know vertical part of the facial nerve, and we are seeing the vertical section of the temporal bone. Both are vertical, so we will see the structure in the complete totality. The complete facial nerve is seen. Am I clear, friends? Backbenchers? Now we can see inverted V-like structure that is nothing but vestibule. And this is the impression for superior semicircular canal, and this is a lateral, and this will will be forming superior arcuate eminence. Sometime it forms. Sometime this is a third window phenomena, and it is dehiscent on the top. So now we are seeing that inferior vestibular structure, like making an opening in the middle ear. We can see the interacoustic meatus being completely formed. Now it is making a contact with the inferior part. Since we are in the posterior, we are coming from posterior to anterior. So अभी हमें posterior और inferior जो चीज मिलेगी interacoustic meatus की, that is nothing but inferior vestibular nerve. So ये inferior vestibular nerve है. It supplies the saccule and the posterior semicircular canal. Now we can see a crust-like structure dividing the interacoustic meatus in between. Am I right? Can you appreciate, friends? So a crest-like structure is what? It is transverse crest. It divides the interacoustic meatus into two parts, superior and inferior. तो जो हमें एक्सियल में दिखता है वो होता है वर्टिकल क्रेस्ट, और जो हमें कोरोनल में दिखता है वो होता है ट्रांसवर्स क्रेस्ट. Am I right? And this is an open crocodile-like appearance of the ampulated end of the posterior semicircular canal and the lateral semicircular canal. This is called open crocodile mouth-like appearance. And along with that, we can see the cochlea getting formed. Okay. कोरोनल में हमें पहले दिखेगा कॉक्लिया राउंड विंडो, और एक्सियल में हमें पहले दिखेगी ओवल विंडो. Now we can see complete crest. Now we can see our vestibule is totally now started to disappear, and we can see our basal turn of the cochlea getting well formed. Apart from that, we can see some bit of the ossicles. So now we have started coming at the level of aditus के level पे आ गए हम. तब हमारा short process of incus बनने लग गया है, और ये हमारी interacoustic meatus है. ये हमारा अब tegment tympani हो गया है antri से, roof of the middle ear. So we can see the tegment tympani. Apart from that, this is hypotympanum. This is the attic area, and we can see the thick lateral bony plate, which we all know as a lateral bony plate, which is very thick in nature. We all know this plate as a, friends, what is the name of the thick bony plate? Scutum. So this is scutum, and this is the malleus now getting appear. तो अगर ये eroded है तो कोलेस्टोमा और इन सारी चीजों के chances बढ़ जाते हैं. Now we can see the complete cochlear turn, malleus incus, everything same, nothing new. This is a styloid process. हमारा external auditory canal आ गया है यहाँ पे. हमारा external internal acoustic meatus चला गया है. Complete ये ossicles आ गए हैं. TM आ गया है. इसमें हमें we can see the little bit of the bony shadow of the stapes making a contact. Now our we have come very anterior, just going backward. जैसे हमें jugular की shadow दिख रही थी, we can appreciate the same shadow over here, isn't it? But this is not jugular. This is our carotid, because we can see the cochlea into the picture. So always remember, when you can see the cochlea, it is going to be carotid. When we can see the vestibule into the picture, it is nothing but jugular. So going a few last slides, we can see the facial complete vertical part, but we can see circular. तो ये same जगह के हैं, ये axial cut है, ये coronal cut है. Young friends, whenever you are doing any mastoid surgeries, always study your CT temporal bone. Many times you can see your aberrant enteral carotid artery or a dehiscent carotid artery just like this. They will appear just like this. So be ready in case if you know about it. If you have read it, and you will be careful. Okay. So high jugular bulb. If it is at the level of basal turn of the cochlea, we will come to know whether it is high or low or dehiscent or it's covered with the bony plate. Similarly, whenever you are going to do a simple mastoidectomy or a cortical mastoidectomy, in case if you see a picture like that, you know that this distance have become very narrowed. You will be thinking about jugular, and you will be very careful before doing your surgery. Similarly, suppose you are doing a mastoidectomy and you see a coronal cut and you can see a very small distance in between, you will be very careful for your low-lying dural plate. This is a dilated endocaustic meatus. You can see how much it is dilated. This is a dilated endolymphatic sac. So in case if you are going to take a patient for stapedectomy, so you obviously you will have a red flags and you will avoid doing surgery in these cases because CSF gusher तो इसमें होना ही होना. And I think लास्ट ओवर में लास्ट बैट्समैन से कुछ रन बन गए होंगे या बोर कर दिया मुझे पता नहीं, बट आई ट्राई टू डू दैट.
Thank you so much, sir, for the wonderful session. Now I request our chairperson, Dr. Sarala Ahuja, sir, to kindly felicitate our speaker, Dr. Ravi Bhatia, sir, with a memento. Thank you so much, everyone. Now we'll be taking a short 10 minutes break for lunch, and then we'll assemble here in the same hall for quiz competition, final round of quiz competition.
Dr. Falsi, आप इतने में arrange कर लो, फिर अब बस एक रोटी खा के आए बोलो, only one. आप क्या
एक मिनट हेलो 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 हेलो
ये लीजिए।
Hello, hello.
ये जस्ट हमारी ये मॉडल लैपटॉप क्यों थी नहीं
All of the residents here.
Hello. Hello, everyone. Good afternoon. I hope all the participants for the quiz, they have taken their lunch. I don't want them to attempt with empty stomach. I'm sure you have had your lunch. So for the information of all of you, out of the 9 teams, the qualifying teams are 4 only. And you know that there was tie for the team of PGIMS Rohtak and BPS Kanpur Sonipat. So in that competition, BPS Sonipat has an edge over PGIMS Rohtak. So after this second tiebreaker and elimination round, we have zeroed on 4 teams. First one, as per the merit, is MAMC New Delhi. This will be called as Team A. Can I call them in the front bench to come and take their seat? MAMC New Delhi. Second team is MAMC Agroha. I wanted them to sit this side. My A team should. Yes. The back side. You will have a lot of strain on your eyes if you sit in this row. Similarly, MAMC Agroha here, and third team is GMC Chandigarh. You are already there, and fourth team is BPS Kanpur, Sonipat, please. Yes. Bete, GMC Chandigarh, you. This girl can take this seat, or you can just shift. You can just shift. So just to have the adequate space and distance between the teams, this is the arrangement. Okay, so we will start the session right away. We will start by introducing the teams once again. You introduce yourself in the morning. You please introduce once again. We can start from there. Team A, Maulana Azad Medical College, New Delhi.
Dr. Ranjan, PG third year from Maulana Azad Medical College.
Dr. Avinav, PG third year from Maulana Azad Medical College.
Dr. Mandata, PG third year from MAMC Delhi.
Dr. Faiz, third year PG from MMC Agroha.
What's your name?
Dr. Faiz.
Faiz.
F-A-I-Z.
Faiz.
Yes, sir.
Okay. Faiz Ahmad Faiz, the great poet, Shair. Suna hai ki nahi naam? Good. Yes.
Dr. Sachin Huda, senior resident, MMC Agroha.
Dr. Barnamoy Bhattacharya, first year PG, MAMC Agroha.
Dr. Mandira Sharma, GMCA 32 Chandigarh, PG third year. Dr. Mehni, GMCH 32 Chandigarh, third year PG resident.
Dr. Madhika, PG third year, GMC at Chandigarh.
Dr. Akash Gupta, secondary DNB resident, BPS GMC Kanpur.
Dr. Ramya, third year resident, BPS GMC Kanpur.
Dr. Shirish, third year DNB resident, BPS Kanpur.
Okay. So we have two mics without cord. So two teams will share this mic, two of you, and this mic will be shared by team A and team B. Is that okay? Now, I wish good luck to all. And we can start. So this is the resident ENT quiz for the year 2022 being held at Rohtak in our annual conference of AOI Haryana. I am the quiz master, though I am a last minute replacement, as I told you. So whatever best we could organize, we have done it. We got a very little time to prepare a very, very good, exhaustive presentation for you. But anyway, we'll try to justify. I have a team of my assistant quiz masters, Dr. Ashima Saxena. She is the consultant in her own hospital at Rewari. Whereas Dr. Raman Sharma, he is assistant professor in ENT department at World College of Medical Science and Research, Jhajjar. Participants, we have already introduced. You have won the race, half the race already. 4 teams, team A, B, C, and D. For rest of the time, I will call you Team A, Team B, Team C, and Team D. So I will stop taking the names of your institution now. Dr. Sampada, some queries?
No, sir.
Shall we wait or we can start? Now the instructions. As I told in the morning, both PG students and senior residents are eligible. You are there. We'll have total of 10 rounds. 9 plus 1, last round will be rapid fire. I'll show you the pictures on the screen for the first 9 rounds. And the last round, I will have a printout of questionnaire for each team consisting of 10 questions, which will be rapid, non-stop. Okay? These first 9 rounds will carry 10 marks each, 10 points each, whereas the rapid fire round will fetch you 20 marks, maximum 20 marks. There is no negative marking for the wrong answers. Wrongly answered questions may be passed on to the audience if time permits. We are already very late, so we'll try not to do that. I will myself prompt the teams as and when required. So don't worry, you will get justified hints. Audience are requested not to prompt, please. There will be interesting queries for the audience too in between. All out efforts have been made for an impartial and transparent proceedings. Without the help of the audience sitting behind the participants, it will not be possible. So I request the audience in this crowd to be patient and no prompting at all. Of course, decision of the quiz master will remain final. So ready? So I'll start with team 1, team A. This will be a spot round. You have to tell what you see. The question will be there. Okay. Well, Dr. Raman Sharma is the scorer right now, and Dr. Ashima is observing you, all of you, and she will also pose certain questions in between. Identify this. What do you see? First in X-ray and then the clinical. Very simple. I am not going to pass questions to the next team if they don't answer. We'll have a separate question for you. There is no negative marking for wrong answers. You should put an attempt fast.
Sacculocyst.
Wrong. This is laryngocele. It was quite simple. Anyway, they don't get a point. Team A. Now the next question comes to team B. Are you ready?
Yes,
Say
sir.
yes.
Yes, sir.
Very simple again. Very, very simple.
Rhinosporosis.
Rhinosporosis is the correct answer. Give them a big applause, please. The first right answer comes 10 marks to them. 10 marks to team B. The next question comes to team C. Team C is ready. GMC Chandigarh. What do you see?
Atrophic rhinitis.
Very good. Very nice. 10 marks to team C. Please give them applause for the correct answers. Team C gets full 10 marks. Last question of this first round goes to team D now. This is the answer of the previous question. Yours is also very simple. Tell us, what do you see? Very simple. It used to be a very common condition when we were students like you.
Membranous tonsillitis, diphtheria.
Diphtheria is the more specific answer. Of course, it is classified into membranous tonsillitis. So give them the applause for answering very correctly. Full marks, full 10 marks to team D. So at the end of the round number 1, we have 3 correct answers and 1 wrong, rather no answer. So first round, the spot round is over, and we quickly move on to the next round. Audience question, I am not putting right now. This is very simple question for audience, by the way. Okay, I move on to the next one. This will be depicting some pictures of celebrities and ENT personalities you have to identify. Okay? Your general knowledge is being tested now. Team A, once again, don't get disheartened. Cheer up. Identify the gentleman and the abnormality on his right pinna.
Sushil Kumar, and the condition is cauliflower ear.
Very right. The first right answer from team A. Congratulations. Full 10 marks to them for the correct answer. Sushil Kumar, the boxer, and having a cauliflower deformity, which is the hallmark of all the Pahalwans. Similar question comes to team B now. Okay. Identify the gentleman.
Justin Bieber with Bell's palsy.
Very good, very good, very good. They get 10 marks, full 10 marks. Justin Bieber is a famous pop singer. We don't know him, but you, the young crowd, must be knowing him. Justin Bieber. He made this video of his getting the Bell's palsy himself viral into the media, and this was caught from there. Whether he had Bell's palsy or Ramsay-Hunt syndrome was not, properly diagnosed, but he had facial nerve paralysis. Okay, question number 2 to team C is this. Very famous.
Van Gogh with pinna amputation.
Reason being, what is the story behind pinna amputation?
Sir, he was mentally disturbed at that time. Then he had a fight with a fellow painter, and during the fight, he cut off his own ear to prove a point.
No, that won't happen normally. Your answer is half right. He had an ENT problem.
Excessive pruritus.
बेटे excessive pruritus की वजह से तो कोई कान नहीं काट सकता अपने. It has to be something more disturbing. Okay, we gave 5 marks to them. He had a very bad tinnitus. Unilateral tinnitus. He was fed up and he chopped off his own pinna and showed in his paintings. So your answer is half correct. So we cannot give you 10 marks. 5 marks to team C. So similarly, team D is ready. Okay. Very familiar face comes to you for your testing. Identify the gentleman. Quick.
Rakesh Roshan.
That's right, Rakesh Roshan, the famous film hero, producer, director, and father of
Hrithik Roshan.
Hrithik Roshan. Any ENT issue he had? Why I have chosen him? Why not others? What ENT problem he suffered from? And do you know who his father was? Rakesh Roshan's father. He is father of Hrithik Roshan, but his father.
No, sir.
Who was Roshan? Dr. Vikas Kakkar, Dr. Aditya Bhargav, Dr. Kamar Singh would answer this. He was a famous playback music director. जो वादा किया वो निभाना पड़ेगा, ताजमहल मूवी का गाना सुना है कभी? Composed by his father, Roshan Lal. Okay, he suffered from squamous cell carcinoma of the larynx. This gentleman, Rakesh Roshan. So they don't get 10 marks; they get 5 for half right answer. So we come to the end of second round. Dr. Raman, can you tell us the score of the various teams?
So team A, 10 score. Team B 20, team C and team D both are 15.
So it's okay. You all are competing well. I will request Dr. Ashima to go for the next rounds.
Okay. So we'll come back to the audience questions when we have some time in between. We want to sort of wrap it up quickly, but you'll see the answers, so don't. Okay. So the third round is focused on otology. All the teams, these questions have 2 parts. So the first part is going to be identification, and the second question will be attached to whatever you're seeing in the first slide. There'll be 5 marks for each. So we'll start with team B first this time. So please identify what condition this is
This is herpes zoster oticus.
I'm sorry, that's not the right answer, but we'll still give you the second part of the question. See if you can answer that.
Malignant otitis externa.
That part you've already lost that answer.
Technetium 99 scan, bone
That's
scan.
correct. So for the second part of the question, they'll get 5 marks. The finding was malignant otitis externa. It was described that the patient has a facial nerve palsy along with granulations in the middle ear and external auditory canal. Next question to team C. What is the diagnosis in this case?
Sir, can patient with herpes zoster oticus can also present with facial palsy and granulation and this pain, severe pain?
No granulations, you'll have vesicles.
Only bullous eruptions. Herpes zoster oticus gives eruptions in canal wall skin. It doesn't give you extensive granulations, which you can see in this. It cannot be treated with herpes zoster.
Okay.
Furunculosis.
That's correct. The next part of this question is, which part of the external auditory canal does it involve?
Cartilaginous external auditory canal.
Is it the
Cartilaginous 2/3, which is the
cartilaginous the
lateral part of,
1/3 or 2/3?
sorry, 1/3. 1/3, sir.
Okay,
Lateral
that-
part of the external auditory.
That
canal.
is correct.
हमारे साथ क्या सुलूक किया जाए? तुमने मिक्स आंसर दिया। तुम बताओ, we will do accordingly. We give you 5 marks or 7.5 or 10? 7.5. Unfortunately, Ashima and Raman, they don't want any high or 3.5 or 4.5.
But sir, ये 1/3 2/3 तो blunder है.
We can give them 10. I am taking this as slip of tongue out of 2/3 and or out of 1/3.
Okay. Next question is for team D. Identify this condition.
EAC atresia with microtia.
Yes, that is correct. It is microtia and canal atresia. The next question is, according to Nagata microtia grading, which grade is this? So you have to tell separately for both the pictures.
Sir, ma'am, in the right ear it is grade 3, and in the left ear it is. In the right ear it is grade 2. In the left ear it is grade 3.
You were going right first. In the right ear it's grade 3 and in the left ear it's grade 4. If you had not prompted her, she would have probably answered it correctly. So grade 4 is when there's just a stub, there's complete canal atresia and there's just a knob. So that's close to a nausea. The next question is for team A. Spot this diagnosis. 10 marks. Oh, sorry, 5 marks because they got that answer wrong.
Congenital cholesteatoma.
Absolutely right. The next question
Give them
is,
some clapping here.
what is the most common site of origin of congenital cholesteatoma?
Anterior tympanic part.
Can you be
Which
more
part?
specific as to which quadrant?
Anterior superior quadrant.
Absolutely
Yes,
right.
that's the correct answer.
So anterior superior quadrant is the most common site of origin of congenital cholesteatoma.
So we
Moving-
come to the end of round 3.
Yes, sir.
Okay.
The next question is the rhinology round. We will be starting from team C as the first team. So team C, please brace up. This round is going to be a little harder than the rest of the rounds. We will ask you to identify the condition and then there will be a question associated with it. Both of them will carry 5 marks each. Okay. So your question is identify and name this condition and name the syndrome that it is associated with.
Choanal
Absolutely right.
associated with Chard syndrome.
Will you like to elaborate on the
Coloboma,
components of
heart anomalies, choanal renal anomalies, genitourinary anomalies, and
You're not entirely correct.
Let's give you a round of applause. You've got a little bit wrong, a little bit right, but very good effort. E is for ear anomalies and R is for retarded growth, not for renal anomalies. But I think, sir, it was a tough question. We can give them
10 full marks.
So yes, absolutely right. It was a picture of bilateral corneal atresia and it's associated with Chard syndrome. The next question is for team D. What is the classical finding seen on MR imaging in case of this tumor? So name this tumor. Please listen to the whole question. Give the alternate names of this tumor and what is the classical MR finding in this case?
This is inverted papilloma, also known as Ringer's tumor.
Great.
And on MRI, we will see cerebriform appearance.
Absolutely right. This is an inverted papilloma. It's also called as a Schneiderian tumor or a Ringer's tumor. And on MR imaging, what we see is called a convoluted cerebriform pattern, CCP.
Yeah, it looks like brain. From the external appearance, it looks like brain. That's why the name, cerebriform.
Okay, the next question is for team A. Identify this condition and please answer that which sinus is most commonly affected. This is a very classical picture that looks upon CT.
Ossifying fibroma with ground glass opacities and seen in most commonly maxillary sinus.
Okay, so the second part of your question is correct. It is most commonly seen in maxillary sinus, but it's not an ossifying fibroma. It's a fibrous dysplasia. In ossifying fibroma, you would have seen much more calcification as compared to this. So we'll give them 5 marks.
You know that you differentiate between fibrous dysplasia and ossifying fibroma. These are not synonymous.
Okay. The next question is for team B. I want you to identify what type of trauma, maxillofacial trauma this is and elaborate on the classification that we use.
Leafort fracture.
Which type of?
Type 3.
Yes, absolutely correct.
How
did you tell?
How do you tell? How do you tell?
Sir, in this craniofacial disjunction appears.
What finding prompted you to classify it into Leaford 3? What is that finding? Here on this picture.
Raccoon eye appearance.
Absolutely right. Lovely.
Give them a round of applause, please.
So the second part of the question is, how do you classify Leafort 1, 2, 3? What is there in 1? What's there in 2?
Leafort 1 fracture, the fracture line go along the upper jaw.
Correct.
Second, according to second, this will go below the orbit and involving nasal bone.
Yes.
There will be. And in type 3, there is complete craniofacial disjunction.
Absolutely right. Full marks to team B. We finished round 4. Round 5 is an identify and answer. So we'll be putting up pictures of instruments and then asking you related questions. Again, there'll be 2 parts to each question. Try and identify, and then you'll get the second part of the question. This time we're going to start from team D as the first team. So team D, please identify this instrument.
This is an old instrument. We saw this, you might not have even seen it, but in the books, the pictures are there. Dr. Vikas and Dr. Aditya, do you recall having used this sometime during your PG ship?
Would you like to pass this question on to the audience? Anybody in the audience wants to take
I
a
have
guess?
already passed, but the audience is not answering.
Okay. So this is a tonsil compression forceps. Then, okay, but you still have 5 marks to fight for. So team D, your next part of the question is, what is the most common cause for primary hemorrhage in tonsillectomy? We want a very specific answer. Please get it right.
Primary hemorrhage means during surgery.
Bleeding from the inferior pole of the tonsil by the tonsillar arteries.
Is it an arterial bleed or a venous bleed?
So the bleeding is from the paratonsillar vein.
Correct. It's from the paratonsillar vein. So should we give them marks? Because she
Yes,
said
yes,
inferior
yes.
pole
They have
artery.
corrected on time, so they
Okay.
can be given.
So yes, it's a venous bleed and it's the bleeding from the paratonsillar vein. Team A, the instrument for you is this one. Please identify it.
Guillotine tonsillectomy instrument.
Absolutely correct. This is a guillotine tonsillotome. The next part of your question is, what is a guillotine?
It was a device which was used for beheading the person during French Revolution time.
Absolutely
And-
correct. A big round of applause for Team A.
Yes.
Okay. Team B, the instrument for you is this. Identify it. Whatever is the first guess that is coming to your mind is probably correct.
Cusco speculum.
Sorry?
Not Cusco.
That unfortunately is the incorrect answer. Does anybody in the audience want to take a turn and identify and guess what instrument this might be?
Some sort of nasal speculum. We have not seen this.
So I'll tell the answer. It's a laryngoscope. Coming to the second part of the question, please listen carefully. What was the source of light for the first indirect laryngoscopy?
This question is to which team?
Team B.
पहली बार जब इनडायरेक्ट लेरिंगोस्कोपी किया तो लाइट सोर्स क्या यूज किया गया था?
Candle light.
That unfortunately is the wrong answer. The right answer is that sun was used as a source of light. There's an interesting story behind it that laryngoscope was not discovered by an ENT surgeon, but actually by a singer, Manuel Garcia, who wanted to inspect his own vocal cords that had gone hoarse from singing. So he used a mirror and he used sun as the source of light. Next question is for team C. Identify this instrument.
Tonsillar snare.
This is
No,
not
no,
a
no.
tonsillar snare.
Look at the other end. We give you another chance to improve. Don't look at the handle. Look at the end. It resembles something.
Can we pass this question on to the audience? Yes, please.
Yes,
Yes, absolutely
yes.
right. This is an adenotome.
You will get chocolates at the end. Please don't forget to get it. Okay. You can have it right away.
Okay. So the second part of your question is, what is guy's aproxia?
This is another name to commonly used terminology, which we will not tell you anyway.
Anybody in the audience wants to take a chance with what is guy's aproxia? So obviously something related to adenoids. So try and think.
The question is related to the instrument shown to you.
Anyway, so we'll be keeping the answer and the chocolate. It's a dull, vacant look that you see in the eyes of the children who have adenoid hypertrophy. Can the audience guess which instrument this is? Yes, absolutely right. This is a Baronese voice box. And what about this? Yes, this is a Ballinger civil knife. Moving on, we are on to round 7, and I'll ask Pasi sir to continue the quiz from here.
So as we are sharing the burden, we come to the next round. Quickly, about the various incisions. I will not put it as part A or part B. This will be a straight question. You have to only name the incision. Team A.
Weber Ferguson.
Correct answer. Let us give them 10 marks. I go on to the next team, B. Very simple. Team B.
Lynch-Haworth incision.
Lynch-Haworth. Very correct. Give them 10 marks, please. Another very simple question. These simple questions we have put to just make you feel a bit easy. Team C.
Modified Blair's incision.
Very correct. Let us give them 10 marks too. This is modified Blair's incision. By the way, what is the modification in Blair incision? No. It has got something to do with giving a less, more cosmetically acceptable look postoperatively. Okay, I'm just asking you, by the way. I'm going to go to the next team, Team D. You have already secured your marks anyway.
McPhee incision.
Very correct. Let's give them 10 points too, and all the teams got should get encouraged. Can I ask Dr. Raman to give us the latest score, please? Oh, great. What a coincidence. I have not seen such a close contest ever. Now to just release the pressure further, there is a very simple, interesting query to the audience. Name the incision and other things in ENT related to the same name. First of all, what is the name of this incision? The knife is going onto the septum. There is Frears and there is another one. Okay. Can you name 4 more Killian's contribution in ENT practice? Yes. Yes. So you have answered all except goose. Anyway, so this is, our audience is also awake and involved. I'm very happy about it. So we go back to our team A for the next round, that is round number 8. This is a radiology round. Again, straightforward questions. Without wasting time, we will ask you to identify the structure marked by arrows. Only one arrow will be there. Team A is ready. Identify the structure marked by the arrow.
Haller cell.
Very correct. Haller cell. Team B. I quickly go on to team B. Identify the structure marked by the arrow. It's very simple. You see this every day. Guesswork.
Agar Nizai.
Agar Nizai is the correct answer. Let us give them full 10 marks and a round of applause also for them. A round of applause, please. It took time, but they could come out with the correct answer. Team C. Ready? तुम लोग बातें बहुत कर रही हो, तुम तीनों लड़कियां. Prompting is not allowed. You are talking too much even when the others are supposed to answer. Keep your volume low, please. Your turn is there now. Identify the structure marked by arrow.
Onodi cell.
Onodi cell. Very good. What is the surgical significance of Onodi cells? You got your 10 points, but just an extra thing. They get 10 points. We are always worried about Onodi cells.
So during sphenoid sinus, while we are opening the sphenoid sinus, we can inadvertently injure the optic nerve or carotid.
Optic nerve is very, very close. Okay. Team D. Similar question. Identify the structure.
So it's a supraethmoidal frontal cell.
Yes. What type of? Frontal cell has got types. Which type is this?
Type 3.
Type? Name of the cell? Type 1, type 2, type 3, type 4, type. They are having names.
So it's a loner cell.
This is the answer. Dr. Raman, they will get 5 marks. So we finish our round, radiology round also. Question for audience. Question for audience. Angutha. In acute epiglottitis. Correct answer. Do you have these many chocolates? Dr. Rupinder Ranga ko de do. So after the audience entertainment, let's go to finish our task. This is also for audience, by the way. Even residents can, the team participants can also answer. Angiography, what is the name of the investigation? Angiography is such a vast general term. DSA. That's right. Okay. So we will go to the next round, which is the final round before rapid fire. Okay. And this will be a bit testing for all of you. Name the procedure. Team A. Identify the lesion on the CT and then see the machine. What procedure is being performed. This is the recent advances.
It's an investigation
round.
procedure. It's a
Procedure.
procedure.
You have to look at the diagnosis on CT, then you can understand the procedure. Very simple.
So, intensity modulated radiotherapy, IMRT. Also,
No.
gamma. Gamma
You
knife.
cannot give me 2-3 type of answers. What is your answer?
Sir, gamma knife for
Gamma
CP
knife.
angle tumor.
For?
Cerebellopontine angle tumor. Vestibular.
Okay. Which CP angle, which is the commonest CP angle tumor?
So, vestibular schwannoma.
I think we can give it to them, Dr. Raman, though they were reluctant replier, but we give it to them. Okay. So it is, you are quite close to that. It is a different name, but gamma knife will do. It's okay. We give you 10 marks. Next question to team B. Name the device and its 3 applications in rhinology. First of all, name the device. Presence of this equipment is a necessity now in each ENT department.
This is for laser surgery.
Very right.
Yes.
This is laser only,
Yes.
but in rhinological procedures, where do you use? I'm not asking about otology or laryngology procedures. You got 5 marks.
The application in rhinology, in laser. Laser can be used in an inferior turbinate hypertrophy.
One.
To reduce.
One.
Adenoid hypertrophy.
You have a different equipment for that.
Yes.
What are you using for adenoidectomy these days?
Ovulator.
So you don't
Yes,
use laser
yes,
there.
Yes. Second, in case of inverted papilloma.
Very good. Very right. एक और बता दे.
Yes. Inverted.
7.5 नंबर नहीं दे सकता मैं. बताना ही होगा. बहुत ज्यादा टाइम दे दिया तुम्हें हमने.
Yes. Rhinolith.
भाई क्या करेगा लेजर उड़े? न्यू निकल जाए है.
Sir, in case of any nasal hemangioma.
Very right. Shage bhai. Give them a round of applause. They have done the efforts and they are successful. Good. So your recent advances knowledge is being tested. Team C. Team C is ready. Identify the device. ये लेटेस्ट है.
Bionic ear.
Oh, great. Correct answer. But what is bionic ear? What does it mean?
So it's a functioning artificial ear which is made out of tissue from the donor.
This is manufactured thing. It consists of pinna and the central part speaks of the functionality. So it will give some relief to patients. You know, we all know that the surgical outcome of patients suffering from microtia or anoxia with canal stenosis, with conductive hearing loss is very poor. So these kind of things are now coming up. Bionic ear. We give them full marks, Dr. Raman. A round of applause for them. Very good. Team D. You have a simple question.
Bone anchored hearing aid.
Very right, very correct. Baha, give them 10 marks. So we complete the round number 9 also with a correct answer from team D. So I will like to know the latest score now. I hope you will not repeat the tie situation. I am really tired of tying tie and tie since morning with this batch. Team D is 60. Okay, Team D, buck up. You did very well in the beginning. You have all the teams have the rapid fire is meant for doing the sixers in slog overs. Yes. Surya Kumar Yadav. So let us try to be Surya Kumar Yadav. Now I'll come to you rather. I will need one for next slide. Again, I will start from team A. I have a questionnaire of 10 for each team. I will keep on speaking, whether you answer or you don't answer. You have a tough job ahead, not to record wrong in marking. This is important. So quickly you have to answer. Causative organism for acute epiglottitis is
Plus influenza type B.
correct. Exposure to wood dust predisposes to which sinonasal malignancy?
Nasopharyngeal carcinoma.
Incorrect. Which enzyme deficiency leads to angioneurotic edema?
T1 esterase inhibitor.
That's the correct answer. Sign seen in laryngocele when gurgling sound is produced on pressing the swelling is known as?
Rice sign.
That's the correct answer. Which microorganism is most commonly associated with nasopharyngeal carcinoma?
Epstein-Barr virus.
That's the correct answer. Dip at 2000 Hertz in air conduction seen in otosclerosis is called carrot notch. False or true?
False.
That's the correct answer. That's the correct answer. What is the length of an adult eustachian tube?
36 mm.
That's the correct answer again. Dysphagia lusoria is due to compression of esophagus by which artery?
Apparent right soft clap and
That's the correct answer once again. Exostosis of external auditory canal are multiple and associated with cold water swimming. Is it true or false? Correct. Last question. In Frey syndrome, cross innervation is seen between fibers of the facial nerve and which nerve?
Lesser petrosal nerve.
That's the wrong answer. So we finish this round with team A. So I'll move on to team B. Okay, ready? Well, you are competing very well. So do well now also. Team B. Ecchymosis over mastoid, not eye, mastoid, seen in temporal bone fracture is which sign? That's the correct answer. Stipple sign is seen in X-ray neck lateral view. True or false?
Lateral, कौन से view में sir?
Stipple sign is seen in X-ray neck lateral view.
No, sir.
This is the
False.
thing I am saying.
False.
That's the correct answer. What is done in type 4 thyroplasty? What do we do in type 4 thyroplasty?
Lengthening of vocal cord.
Lengthening of vocal cord. That's the correct answer. Very good. Gold standard surgical treatment for management of OSA obstructive sleep apnea is?
Tracheostomy.
Tracheostomy. Unfortunately, this should not be the gold surgical treatment, but as it stands today, it is the gold standard. Yes. Next question. What is the approximate number of nerve fibers in facial nerve?
10,000.
मोटर और बाकियों में कितना है?
7,000 और 3,000.
7,000. बहुत अच्छा है भैया. Correct answer. Give it to them. Phenomena of recruitment is seen in retrocochlear lesions. It is false or true?
False.
That's the correct answer. Confirmatory biochemical investigation for CSF rhinorrhea.
Beta-2 transferrin.
That's the correct answer again. Splaying of internal carotid and external carotid artery is seen in carotid body tumor. What is this sign known as?
Splay sign.
Splay to hota hi hai na?
Yes,
That's not a correct answer. Patient with recurrent sinusitis, bronchiectasis, situs inversus is seen in which syndrome?
Carter syndrome.
That's the correct answer. Last question. Very simple. Mouse nibbled appearance of vocal cord is seen in?
Laryngeal TV.
That's correct answer once again. I think they have done very well once again. I move on to the next team. Team C. Okay. Ready? अब देखता हूं कितना बात करती हो तुम. False positive fistula test in congenital syphilis is known as, very simple. That's the correct answer. Stapes suprastructure develops from which branchial arch? Second is correct answer. Gutman's pressure test is done to diagnose which clinical condition? जो लड़कियों में नहीं होती. Sorry. Most common foci of involvement in stapedial otosclerosis is? That is a correct answer. Number of ossification centers for the aortic capsule are? How many ossification centers?
14.
14, correct answer. Give it to them. Causative organism for malignant otitis externa is? Pseudomonas is the correct answer. That's a very simple question as well. Rhinophyma of the nasal tip is due to hypertrophy of which glands? That's the correct answer. Name the condition which is reverse Meniere's disease. That is the hearing loss and tinnitus first and vertigo later on. Lermois syndrome is correct answer. Gallen's anastomosis is between superior and inferior laryngeal nerve. True or false? Anastomosis, Gallen's anastomosis is between superior and inferior laryngeal nerve.
False.
True or false? False, yes. It is between internal laryngeal and recurrent laryngeal nerve. Last question. Cornus septum is formed by?
Remnant of Peter's squamous suture.
All right, let us give it to them. This is the correct answer. They could have elaborated. Anyway, so they have also done very well. I move on to team D with the last questionnaire. Yes, ready? Wavelength of KTP laser is how many nanometers? KTP laser
419.
wavelength is?
419.
It's 532. Wrong answer. Frog face deformity is seen in? Very simple.
Juvenile nasopharyngeal laryngofibroma.
JNA. Correct answer. Supplying artery for pectoralis major flap is which artery?
Internal thoracic.
No. It's thoracoacromial. Wrong answer. Jajavi fracture of nasal septum is a horizontal fracture. True or false?
True.
That's the correct answer. Brown sign is seen in brown sign glomus to glare. Wrong answer. What is Tullio phenomena? Answer through this.
Vertigo on hearing loud sounds.
Yes, sound producing vertigo is Tullio phenomena. Very right. That's the correct answer. What percentage of temporal bones have a pneumatized petrous apex? Yesterday, you had a lecture on petrosectomy. How many petrous bones are normally pneumatized out of 100? 33%. No answer. Drug of choice for chemical labyrinthectomy is gentamicin is correct answer. In noise-induced hearing loss audiogram, dip at 4000 Hz is seen in both bone as well as air conduction thresholds. Is it true or false? That's the correct answer. Last question. Which drug would you avoid in a patient with Semter's triad? Aspirin is the answer. That's the correct answer. So we come to the end of the show, and they have done very well. They have performed. They have attempted very well. I think everything went smoothly. Now I will wait for our scorers to tell us who is where.
So the scores were 65 Team A, 65 Team B, 65 Team C, and D on 60 marks. In rapid fire, Team A, they gave 2 wrong answers. Team B and Team C, they have a tie. They gave 1 answer wrong, each team. And Team D, they gave 4 wrong answers. So we have a tie between Team B and Team C.
So that means our team D stands at number 4, and tie is still after us. We are not getting rid of ties. We have a tie between Team B and Team C, and Team A is Team A.
Team A is
Number 1.
Team A is number 3.
Acha, okay. Oh, okay. Can you tell us the score, individual score of each team?
Count.
Total score. Dr. Munjal kahan hai? You have a tough job ahead. We have 2 teams. Or shall I go for a tiebreaker again?
Yes, between Team B and Team.
इनको रनर अप तो इनको मिल ही जाएगा ना. First, whosoever answer first. तो ये तो लड़कियां बहुत तेज हैं बोलने में, ये जीत जाएंगी. अच्छा फिर ठीक है. So this is girls versus boys. I think this is a good suggestion. 1 question only. What do you say? So ये असली रैपिड फायर अब होगा.
We are observing. They'll raise the hand. Whosoever raise the hand first.
Raise तो दोनों कर देंगे.
नहीं. If हाँ अगर वो आंसर गलत हो, then they have to answer. हाँ. Yes. Then negative. And only 5 or 10 seconds. 5 seconds.
Okay. So whosoever answers first will be number one. No, only one. If we can decide only on one, we will do that. Okay. There is a CT scan view called partial view, POSCHL of CT scan. Partial view of CT scan is used for which pathology condition? All the six are silent. I'll go to another question. What is, this is about juvenile nasopharyngeal angiofibroma, JNA. What is Ramharan sign in JNA? You can't answer. Only these two teams. What is Ramharan sign in JNA? Yes. Yes.
What is this sign?
Team B.
They are. It is wrong. We have already given the instructions.
No. We will take a decision. You will not take a decision. We will take a decision. They had a query whether it is a radiological investigation. So we gave them that. उससे ज़्यादा तो कुछ नहीं हुआ है ना? हाँ, तो वो तो आपको भी सुनाना जो मैंने उनको बताया वो आपके लिए भी है. That hint is for you also. No. No, this question is, okay, I'll repeat it. What is Ramharan sign in JNA? No. That decision we will take, not you. I told you earlier also. I'll give another question. Now, Ortner syndrome is paralysis of superior laryngeal nerve due to cardiomegaly. False or true? No prompting, please. We are going to put difficult questions only. They win.
Congratulations.
Congratulations, Team C. Team B will have to be satisfied with runners-up position. So I think we should appreciate all the teams, and I will appreciate the audience more than the teams for their absolute discipline. Thank you very much for that. And thank you very much, Dr. Sunil Munjal and Sampada and all others who have been working tirelessly. Thank you. So whatever formalities are required now will be done by the organizers. I want a group photo of all the participants on the stage. Yeah. इनकी फोटो ले लेते हैं ना पार्टिसिपेंट्स की एक जिन्होंने पार्टिसिपेट किया आई वांट ऑल द पार्टिसिपेंट. अच्छा ठीक है, ओके आ जाओ. लड़कियों को यहाँ खड़ा कर लें. इधर से आओ, इधर से. So it is team C, GMC Chandigarh. You are GMC Chandigarh. GMC Chandigarh is number 1 team, followed by आप ऊपर आ जाओ।
Dr. Bhargav sir. Sampradam? जरा कोजी हो जाओगे। आप लोग नीचे आ जाओ, ऊपर वाइट कलर का है, आप लोग नीचे आ गए, ये नीचे आ जाओ। तो संबंध इस साइड आ जाओ, आप लोग इधर इधर हो जाओ, आप लोग संपदा को सबसे आगे रखो। मैं इधर आता हूं। संपदा का ही मगर पड़ गया। संपदा की फोटो सबसे अच्छी आने चाहिए। थैंक यू। सारे संपदा ही सर एक फोटो बाहर करेंगे सभी।